May be revealed later on.
Yeah.
Sir, I don't think that TS is to be done. Already it is euthyroid state. Very, it is a incidentaloma. You can say it is a incidentaloma. Patient is fine. So actually there is a dictum. We should do the in a thyroid nodule, solitary thyroid nodule. We should do the TSS first investigation as a first investigation. But as you have mentioned, it is in the euthyroid state. So I'm not going to do the TSS.
Yeah, but TSH.
So let's agree to disagree on that. We can do the TSH or we may not do the TSH.
So, as per ATA guidelines, we need to do the TSH.
Yeah, the ATA says we must do and the British guideline says you need not do. So there is a disagreement there. Okay. So now, should we do an FNAC?
So this is a typical case of incidentaloma, less than 1 centimeter, no Hurwicks factor, detected incidentally. So we will not go for FNAC. There is no indication of FNAC because if you do FNAC, this is again increase the agony of the patient. They will go to second surgeon, third surgeon, fourth surgeon. So this is simply an incidentaloma. We just can follow up her because ultrasonologically reports are completely in favor of low risk category.
Sir, though it is an incidentaloma, suppose if the ultrasound findings are in favor of this malignancy, microcalcification is there, the central vascularity is there, margin is there. So then we are not going to FNAC.
So should we do a thyroid scan?
So, as per ATA guidelines, thyroid scan needs to be done only when TSH is normal or it is subnormal.
Right.
But I mean, if it is above the normal range, but if it is below the normal range, there is no indication of thyroid scan, because even if the patient is found to be having an autonomous nodule or hyperfunctioning nodule, the chance of malignancy is less than 1%.
Right. So we are not looking at thyroid scans for diagnosing or increasing the suspicion of a malignancy. We are looking at a thyroid scan only if the TSH is low to identify a hyperfunctioning nodule or a hyperfunctioning thyroid. We agree?
Sir, practically thyroid iodine scan is that are said then done. Nobody nationally and internationally has done thyroid scan. If your THS is subnormal, then we will take the help of P3, T4. Even the endocrinologist will not advise for a thyroid scan.
No, what she says is correct. If the TSH is low, then it's a hyperfunctioning thyroid. We want to know whether the nodule is hyperfunctioning or the thyroid. The treatment varies, changes. And so that is correct. What she's saying is correct.
So if TSS is subnormal, then we should do the free T4.
That's okay.
If it is high,
that's okay.
Then we can go for the radionuclide scan for the thyroid.
So should we do a thyroglobulin assay?
Yeah. Thyroglobulin is no rules.
Anybody in the audience wants to say, please join me. Yes, sir.
Regarding that first finding, 0.8 centimeter nodule in the right lobe, I'd also like to know where in the right lobe that nodule is, because if it is near the posterior side, near the tracheoesophageal groove, I'd like to, investigate further, because these are the nodules which might be not as benign as they look.
So Dr. Ahmad has highlighted a potential risk factor if there is a nodule which is near the posterior capsule or near the tracheoesophagus. Should it turn out to be malignancy, you may have easy involvement of the recurrent nerve. That is why he is concerned about it. But then a 0.8 centimeter nodule, very, very likely that on follow, if it is a malignancy, and we'll talk of follow-up, we'll come to that point again a little later. So we all agreed we are not doing a thyroglobulin.
No.
Now,
no, sir.
So are we just going to reassure her and leave her?
Yeah, we are going to follow her up.
So who are the people who deserve to be followed up? And what is your follow-up protocol? This lady has a 1 centimeter thyroid nodule, not near the posterior capsule. Now, who are the people who should be followed up, and who are the people that you will say no follow-up needed? Because if we say follow-up, you'll have a huge number of people like her coming for follow-up. So there must be a way to triage and say don't follow up these people.
So once
Yes.
once we detect a nodule in the thyroid, the guideline says we should be following up according to the risk factor associated with the ultrasound report. And these reports keeps on changing. It has been seen that small percentage of patient in Akira Mayosi series also, about 2 to 3% of patient has turned out to be again with high risk factor in follow-up scans. And location of the nodule, what Sare says, it's called the danger triangle. In the region of tracheoesophageal groove, where there is a recurrent laryngeal nerve, if the nodule increases in size in future, there may be a chance of involvement of the recurrent laryngeal nerve. So frequency of follow-up will depend upon the change in the ultrasound report. And this includes whether there is appearance of calcification, margins, appearance of new nodule. So this factor needs to
So
be,
we have seen her today, Rajyoti,
yeah.
and now we want to ask her to come back for fall. This took me 2.5 months to convince her not to do anything. All right, it's not something that happens like that. She's very, very anxious, and at one point I actually told her, if you're so anxious, we'll go ahead with the surgery. Then she goes back and comes, her husband is involved, they read, somebody said, no, Dr. Google, sister Google. So she reads Google, she comes back with more information. Finally, right now she's on follow-up. Now, when will you ask her to come for the next evaluation?
So this is a low risk category, sir. So I'll call her up around the interval of 6 to 12 months for
Okay.
the first ultrasound.
You see her after 12 months, this is the same picture.
Yeah.
Then what will you tell her?
So again, follow up after 1 year. This is what guideline says, sir.
You want to say something?
Actually, it's a very small nodule. If patient has no comorbidities and no family history of thyroid cancer, no other high risk factors, then 6 months follow-up is not warranted as far as the guideline concerned. 1 year follow-up is, first year follow-up is required. Followed by USG, if there is no growth but no substantial increase of the size of the node, and again 1 to 3 years like that you have to follow it up according to guideline.
Sir, according to study, up to 10 years, the followed up case, there was no interval change in the 65% cases. No interval change. And very few, 35% cases, the small interval was there. If it is in favor of the adenoma, thyroid adenoma, non-malignancy. So I think the 1 year interval follow-up is enough, I think. According to that study I have seen. 1 year ultrasound. One ultrasound is enough to see this. In particular this case, the ultrasound is enough within 1 year.
Anybody else? Go ahead.
Sir, what I know from ATA guidelines, for first 2 years it's
So remember, there are ATA guidelines, there are European guidelines, there are
Yeah.
British guidelines, there are
So-
Japanese guidelines.
Yeah, so
We have NCG guidelines.
we have NCC, we have got Indian guidelines
yeah,
also now.
yeah.
So what ATA guidelines says, because this is followed all over the world, British will follow British, but Indian mostly follow the ATA guidelines. And Indian guidelines has also come up in comparison to ATA guidelines, almost similar. So what ATA guideline says that up to 2 years, the follow-up should be 6 months to 1 year. After 2 years, it should be yearly. And it all depends upon the appearance of high risk factor. If you see at 2 years, your nodule is giving you some suspicious features in ultrasound, then you have to expedite your follow-up.
Let me ask you another question. What if somebody has done an FNAC and FNAC says benign? Then what will you do?
I will again
Somebody
raise-
did an FNAC.
That
The
FNAC
doctor did
doesn't-
an FNAC and report is benign.
That FNAC doesn't have got any importance in my books. Sir.
No, don't say that, yeah, Baba. Your pathologist will come and
No, this is not a
Get
nodule
out
to be.
you.
No, that is what written in the book also, sir.
No. So the guideline is, if the FNAC is unequivocally benign, ultrasound is benign, we don't need to follow up these patients. We don't need to see them again.
The other way around is that if you do a FNAC, it's going to increase the more agony of the
No,
patient.
I'm not saying do it. Now this lady will very well go to some corporate hospital somewhere, and somebody, she talks to 50 doctors, somebody will put a needle. I'm willing to bet on that. Okay. So she sees 10 of you and comes to me for the 11th time. I will say she's seen so many. I will also say go put a needle. You understand? Somebody will do this. And so she will come to you with a report. Correct. He says,
So that is what I wanted to enlighten. If you do an unnecessary FNAC, then the agony of the patient will
what I
go on
want to say
increasing.
is that how many times the patient you approach, what your conscience says, you should not give up to that patient, sir.
no, sir.
What, because 0.8 centimeter needle incidentally detected and no other fissures, and why to put the needle on that?
We
on
don't
that
have
patient?
to. You or I or Rajyot may not recommend it. But the fact is, she will go doctor.
No, every doctor should. That should
No,
be
that is what we are trying to tell. Yes,
that
that's
message should go to all the doctors in
Correct.
across the world.
correct. But the fact is, she will come to you with an FNAC. She's so worried. Some doctor will say, okay, kar do
That
FNAC.
if 10 doctors say the same thing, the patient will not go to that another 11 doctors.
So
because we are uneducated.
no,
Sir,
I did not divulge
because
this information.
We are not able to convince the patient. Weakness lies in us,
Sir,
not with the patients.
Sir, this patient actually had an FNAC done. She came to me with an FNAC report. I did not divulge that here, but that is a real life situation. They will have it done. Somebody will do it. We can tell everybody, and yes,
you have mentioned that it is a professor, wife of a professor of an engineering college. That is really interesting.
yeah.
She may be very apprehensive, for number one, and the engineer, husband engineer also very much, they are searching. As you that FNAC will do, if I don't suggest, according to ATA guidelines,
No, sir.
someone will do.
Sir, thing is that once somebody does a FNAC, you need to talk to that doctor immediately that FNAC is not required and FNAC.
Don't get into
No,
this.
no, you are in BPCI. You may not do.
No,
but
we are
someone will
dealing, Rajot, we are dealing with a patient who is anxious, who has this nodule, and we have to handle her. So, if she goes to see several doctors, and one doctor does an FNAC to reassure her,
That's where
it's
the
not
problem.
wrong.
That's where the problem arises, because we are satisfying the egos of the patient.
It's not ego, sir, it is fear. It is fear, it is not ego.
And
She's not standing, she has no idea. She's not saying this is my opinion, do an FNAC. She is afraid. And
that is the we cannot allay the fears of the patient.
See-
All lies with me, because I cannot allay the fears. Because even that patient is a scientific person, but we are scientifically not able to establish and convince the patients that this is a benign lesion.
Sir,
yeah, I'm coming to that.
no,
I
sir,
have put that
excuse me, sir.
scenario.
The point is that if we do a FNAC, comes out to be papillary carcinoma, are you going to intervene this nodule?
So then we will talk about that.
We are not going to
Just
intervene
wait,
this
don't-
nodule
don't-
because
don't-
papillary carcinoma is regarded as the low risk carcinoma.
Wait, Rajot. First thing is, if she has had an FNAC and that is benign, the ultrasonologist says it is benign, we don't have to follow her up. Period. We just leave her alone, tell her she has no problem, let her go back to normal life. If she has not had an FNAC, as he says, and the sonologist is very clear, unequivocally benign, repeat it once, twice, thrice, and if it is benign, we can stagger the follow-up. We can let her be at ease. We can tell her then also that don't worry, there's nothing wrong, go home. So it is, ultimately we have to reassure her, and there is no need to evaluate all incidentally detected less than 1 centimeter nodules. So when will you evaluate? That's the question. When will you evaluate less than 1 centimeter? There are high risk features. There is suspicious lymphadenopathy. There is a symptomatic individual. There are people, young age individuals, people who are less than 15, 16, 18, 20 years, we must evaluate all thyroid nodules. Okay, we should not say 10-year-old girl comes with a nodule, we should not say nothing. We should evaluate. There's a family history, this is more nebulous, and then when there is such an overwhelming fear of cancer, sometimes individuals will go and have surgery also. And so from ultimately we are treating a patient in toto. We are not treating the signs of the disease. And if the patient's fear has to be alleviated by an FNAC, so be an FNAC. It is not, I as an oncologist will not recommend an FNAC. Somebody as an endocrinologist may not recommend an FNAC. But a doctor who is dealing with the patient, who has no way of handling her fear, has to do it. That is one way to allay the fear. So come to your question, no, what if this FNAC shows papillary carcinoma? What will you do?
So if it is papillary carcinoma, 0.8 millimeter nodule, no family history, no exposure of radiation in the childhood, still I will follow up this patient.
So what are the other options?
Sir,
So instead of saying I will follow up is one option.
yeah.
There are other options.
Sir, you see, thing is that you have to see the histology of the patient. If it is in the aggressive variety, tall cell variant or the
So
insular variant.
just let's pause, no? The
Yeah.
pathologist, on cytology, will you be able to tell us whether it is tall cell or sclerosing or?
Sir, actually classical and non-classical. If it is very tall cell, there are now diagnostic criteria has been established. If it is very clearly evident, we'll tell it, sir. Most probably variant, but generally almost 90% of the time it is not. Like sir, follicular variant of PTC, we can definitely tell it is a follicular variant, this thing. But follicular variant and encapsulated variant, we cannot differentiate on FNAC. But sometimes tall cell variant, yes, can be. But hobnail and columnar, it is difficult, sir.
Right, go on, please.
So sir, in classical PTC, okay, we can wait for this one. But in the aggressive variety, like she told, hobnail variety or the columnar variety, sclerosing type, these are the aggressive tumors. So we can go for the other option. What is wrong if we do the lobectomy? If there is no node in the level 6 or the lateral nodes, so we can go for the lobectomy as
So
well.
lobectomy is another option. Is there any other option that we can offer the patient? Or she asks, I don't want surgery, but can you do something non-operatively?
Non-operatively, sir.
So molecular testing can be.
Is it capable?
Oh, okay.
Molecular
We'll come
testing,
to
yeah.
molecular test. But
Molecular
we already
testing.
have a diagnosis of papillary carcinoma.
Yeah. So we can do the mutations at least. For the papillary carcinoma, we can go for the BRAF mutation also. Or
No,
mutation.
now we have a diagnosis. We have to decide on treatment.
Yeah.
Now BRAF or whatever is not going to help with the surgical decision.
So can you go for the chemotherapy? I don't know. I'm not.
No, nowadays non-surgical techniques are coming up, like radiofrequency ablation, then ethanol injection,
Those are all
laser
Yeah.
laser therapy. So these are the options. And regarding molecular testing, when you have got a papillary carcinoma of 8 millimeter, I don't think there is a role of molecular study. And so these are the non-surgical options. These are coming up, and these are done also in Asian countries. Even the FDA has approved this. So these are the other options. Up to 3 centimeter nodule, you can still
small
go-
nodule, this
Yeah.
1 centimeter nodule, you can consider RFA also.
Even malignancy, then non-malignant nodule also there. You can do RFA.
If it is not near the posterior capsule or the tracheoesophageal, you can even think of microwave ablation.
Microwave ablation.
You can think
And
of
even-
There are other options.
Even
But-
this is practiced in recurrent cases also, small recurrence, when person doesn't want to go for re-surgery and all. In those cases also, then recurrent primary, recurrent nodules, you
Sir,
can go for non-surgical.
just one query,
Yes,
sir.
yes.
Is RFA or ultrasonic ablation or boiling water, whatever, is it advisable in malignant diseases?
In a 1 centimeter size lesion, we can consider all these
But
options.
in the books it's written that it's done
Yeah,
mostly-
wait, I was just going to add a thing. This is not standard of care. We are not going to recommend this. A woman who's unfit, this lady will be fit, she's only 35 years. But hypothetically, somebody is unfit, somebody is unwilling for surgery, but somebody wants something. These are options that we need to discuss. Today, if you don't discuss, they will come out with a thing and ask you. So it is good to generally have an idea what to tell the patient. These are options, but I would recommend a hemithyroidectomy, whatever.
But permitted to say, sir, recently I have attended a conference in Bangkok last 2 weeks back. So Asian countries are doing in primum cases also, nodule of 2 centimeter, nodule of 3 centimeter, even papillary carcinoma, thyroid.
We heard that man at the FHNO, no?
Yeah.
He's all small tumors, he's not operating on them.
Yeah, even
Very large series.
Even small malignant nodule also we can do RFA and
Yeah,
frequency ablation.
It can. One question before we move on to the next patient. Radiologically, you said there are high risk features. So one of them is calcification. So how do you use calcification to tell us whether it's likely?
Basically, we have 4 categories of calcification, which decides the risks of malignancy. One is coarse calcification. This is very less chance of malignancy. One is ring calcification, moderate risks. And another is the microcalcification less than 1 mm, not shadowing, not giving acoustic shadowing. These are the calcification which has highest malignancy risks. And once I see the cometal artificial calcification type of calcification, then it is a 100% benign. It is usually seen in colloid nodule. But ring and microcalcification are 2 calcifications that are very suspicious.
All right. Any other? You said hypoechoic or hyperechoic. Is vascularity a feature that you will consider, or you will not consider?
As far as this vascularity is concerned, there is no rule for vascularity except, very important indication, except papillary carcinoma with cystic changes. They have usually a large cystic component to a small nodule. This nodule gives you a lot of vascularity on Doppler. This is the only situation you can apply for Doppler. Otherwise, there is no rule for Doppler.
All right, thank you. So,
even presence of micro and macro calcification in a single nodule has carried the same chance of malignancy as compared to only presence of microcalcification.
So in ultrasonography, correct me if I'm wrong, one feature is not used to define a malignancy. It is a cluster of features. Hypoechoic, margins, calcific, all put together is what the radiologist will use to say malignancy or not. He's not going to say malignancy based on just one feature.
So one more important point is that the cell pattern is also important. It is wider or the taller. If it is taller,
can you explain what is wider and taller?
Yeah.
Basically, we have 5 features. One is composition. Composition means consistency of the nodule, whether it is a cystic or solid. Number 2 is echogenicity, whether it is a isoechoic. Isoechoic means the nodule equivalent to ecotexture of the normal thyroid parenchyma. Whether it is a hypoechoic, the ecotexture just below the ecotexture of the normal thyroid.
So, excuse 1 minute.
Yeah.
When you say isoechoic, then the nodule has to be clinically palpable, or you can see an isoechoic nodule on the ultrasound.
Non-palpable, even a small nodule you can see it because they have a small capsule.
Right.
And that way we can differentiate basically.
Right.
This, if the echogenicity is less than normal thyroid parenchyma, it is a hypo. If it is echogenicity is less than step muscle, it is a very hypo. It has a almost 90% sensitivity of being malignancy. Number 1. Number 4 is this one, calcification. Then again, shape. Only 2 shapes. Wider than taller, that means you have an oval nodule here. In 10 bars, you make a 10 bars image, you measure it, longitudinal and vertical AP diameter. This one is wider. Then AP was the taller. This is taller. That means oval nodule has a less chance of malignancy. We usually give in thyroid 0 point. Once the nodule is vertical, that is taller than wider, tall is more than the wider, that is a very specific, it is a very, malignancy is very, very high. If I get very hypoechoic, taller than wider, it is a malignancy.
Sir, what is the composite thyroid score on which you will give the...
I have a presentation for that, so I will explain to you.
Thyroid score, you will have a
I have a presentation.
Yeah. This is just for people who are not very tuned to ultrasound or new to this field. Can you just explain what is vertical and what is horizontal in terms of anatomical position?
Sir,
or the position of the patient.
so if you do ultrasound like that, this is the Tanba scan, this is longitudinal scan. Superior inferior is longitudinal. This is the Tanba scan. You make a scan in Tanba sleeve, fix the image and see the nodule, whether it is a oval shaped or is a vertical shaped. If it is oval, definitely is wider than taller. That means superior inferior is the wider. You have to make superior part inferior is long axis diameter and short axis. Suppose there is a nodule like that. You make a long axis and short axis. Short axis is the taller than wide. Taller than wider. Long axis is the wider than taller.
What if it is round? Both are equal.
Equal, then we have to see other features.
Okay.
My understanding is you are making the patient lie down when you are doing the sonography. So the patient is like this. So this plane is the transverse, and this
Anteroposterior.
and the anatomy.
Anteroposterior.
This is transverse, and this means this is vertical, anteroposteriorly. Anatomically, I mean, anatomically speaking. Yes. Transverse.
These pieces are there in the ultrasound machine, I suppose. So one more thing I want to add. If there is a component of cystic and solid component in the nodule, that's called as a mixed nodule. And in the solid component, there is a heterogeneity in area and there is no homogeneity in one area. So heterogeneous area should be targeted for FNAC. That carries the more chance of malignancy.
Basically, this is a mixed type, solid and cystic nodule having cystic component and solid component. Solid component idea is a tumor. Number one. Number two, idea it is a concealed hemorrhage, because the hemorrhagic component migrates to the peripheral area and adherent to the wall of the cyst, and you cannot move. So USG gives a solid cystic appearance. So Doppler has a rule in that case. If there is a vascularity in that solid component, definitely is a papillary.
Thank you. Let's go to this picture I picked up from the internet. This is not my picture. This is a 28-year-old housewife with a slowly growing swelling in the lower part of the neck over the last 4 or 5 years. And on examination, it's a 3 centimeter solitary thyroid nodule clinically. Now, what should we do?
So first of all, I'll do the clinical examination. What is the apparent size of the nodule? What is the consistency of the nodule? Whether it is moving or not. Then the moves on deglutition. Is there any tenderness? So after that, I'll go for the TSS estimation. If the TSS is abnormal, I'll go for the T4, phi T4. If it is high, then one radioiodine scan to be done. If it is a hot nodule, we'll leave because it is not malignant. If it is a euthyroid state, cold nodule, euthyroid state, and a hypothyroid, then I'll go for the ultrasonography of the neck. In ultrasonography, so I'll see the location of the nodule. First of all, whether it is anteriorly placed or posteriorly placed, the extrahepatic extension is here, is there or not. Then the consistency, if it is purely cystic, it is again benign. If it is the solid and the cystic, that means mixed, then it could be the benign also, it could be the malignant also. So ultrasound guided FNAC is needed to target the solid part for the evaluation, proper evaluation. Then again the microcalcification is there. Then the hypervascular.
So let's come to this, no?
Yeah.
Ultrasound shows a
Yeah.
taller than wider
Yeah.
tumor, which is
Okay.
3.5 centimeters. FNAC shows a colloid goiter.
Yeah, colloid goiter. Sir,
Yeah, go ahead.
It,
Yeah.
so it is, you see, it is a nodule of the 3 centimeter. So,
So, 1 minute, let's go back to the pathologist, no?
yeah.
So, in pathology, what all will give us a yeah.
So when Whenever we received a thyroid FNAC smears, first we like to see the cellularity first and background. If like background colloid is there, mostly it is favors benign, and with that and we are seeing the cellularity of the smear. If cellularity is high and in the presence of benign, still will favor it is benign colloid goiter. So it will be Bethesda category 2. Suppose we are not able to see the colloid in the background, but cellularity is also high, but we are not definite of atypia, nuclear morphology is not showing any atypia, we'll put it as category 3, sir, AUS, undetermined significance. And when we see the classical features of nuclear features of PTC, we'll put it as malignancy. And suppose there are few areas which is showing presence of tumor, atypia, all the features not there, then we'll put it as suspicious for malignancy. This is how we approach, sir.
So, okay. Anybody else wants
So
to add?
as you have told, it is the benign. So we can observe also, but there are two indications for surgery. One is the cosmetic purpose we can do the surgery, as because it is a female, and the apprehension of the patient. If the patient is very apprehensive, so we can go for
In
the
a
surgery.
benign multinodular goiter, only two indications: fear of cancer and cosmesis.
Yeah.
You want to say something?
So FNAC will be important in this case, sir. This FNAC is benign, that's management will be something different.
Right.
Investigation will be also different.
Right.
If it's a malignant, the investigation also will be different, management will be also different.
Right. So let me come back to it again. FNAC says follicular neoplasm.
If FNAC says follicular neoplasm, then I will go for lobectomy. And I like to do a ultrasound, CT scan in this case, because it's a follicular neoplasm. If there is a suspicious nodes in the central compartment, I will be a little bit cautious during my surgery, because if this is a if follicular carcinoma comes out to be malignant in the final histology, this patient will go for total thyroid.
So what? Sorry. Sorry again. Come again.
So if it is a, what did you say, sir? Follicular neoplasm. So in follicular neoplasm, whether it's a malignant or benign, pathologist has to get the whole specimen.
Right.
Then only in the capsule they can find out whether there is angio invasion or not.
Right.
And number of angio invasion is also positive. It
Right.
has to be more than 4. So if it comes to be follicular carcinoma in my surgery after doing a lobectomy, according to the size of this the tumor,
3 centimeters.
so still it's okay with the guidelines.
What do you want to do?
We want to go for lobectomy, sir.
Yeah, exactly. Yeah, if it's a differentiated follicular or papillary, does not make any unless
But
there is so much of angio invasion on histopathology. You're not going back to complete the thyroidectomy.
But one thing we should be keeping in mind regarding the ipsilateral central compartment. If it comes out to be follicular
I'm coming to you. I'm coming to that. Wait. So okay. So when will you do a CT scan? As this lady has a 3 centimeter size nodule, and will you do a CT for all patients? And the FNAC says papillary carcinoma or follicular neoplasm.
No, sir. We are not going to CT scan in that situation. But thing is that if it is the extrathyroidal extension is there, if it is posteriorly placed, then also nodal, the very big nodal mass with the externodal extension is there. In that situation, we will go for the CT scan of the neck. Otherwise, in that situation, we are not going to. This is ultrasonography is enough for this patient.
Okay. So will you? FNAC says. Yeah,
if,
please go ahead.
if the ultrasound says there are significant lymph nodes, whether central or lateral neck, or if there is suspicious clinically or ultrasonographically retrosternal extension,
Right.
definitely CT scan will be recommended.
So there are specific indications for a CT scan in an otherwise mundane papillary carcinoma of the thyroid. Either features suggestive of extrathyroidal disease, clinically there's hoarseness of voice or the retrosternal extension, you must have further evaluation.
Sir, you have rightly said, this is a clinical point. Once patient comes with a nodule with hoarseness of voice, that's first presentation. CT scan is mandatory to see the extent of the disease.
Yes.
Second symptom is patient comes with the symptoms of hemoptysis. These are all angio-invasive symptoms. Third point is that if the patient comes with a small nodule which is very much fixed. Fourth point is that if patient comes with in a recurrent disease, it's better to go for CT scan.
Yes, accepted. Will you do a PET scan for this patient?
No, sir.
Anybody wants to do a PET scan?
No, sir. PET scan is having the no role access. According to ATA guidelines, sir, one thing I got in the book, that if it is 1 centimeter nodule or less than 1 centimeter, so suppose FNAC is of course negative, but the ultrasonography says that the points are in favor of the malignancy. In that situation, could you do the PET scan? One, this report is there, one that writing is there. That's why I am asking.
PET scan has a role in thyroid only in dedifferentiated thyroid, sir.
No, but what he says is true. You know, there are lots of publications that talk of PET in an indeterminate thyroid situation where you have not operated. So we will. That's a big story in itself. Let's not talk of it now.
Sir,
So, yes.
As
Yes,
per
yes.
ATA guidelines, PET will not come if FNAC
Not
ultrasonography.
indicated here.
Yes, already done. Then PET has no
Not
role in
indicated
this
here.
scenario.
In this patient, it is not indicated. Correct. So, question: hemithyroidectomy or total thyroidectomy? You have already answered. Tell us about the central or lateral compartment. When will you do a central compartment dissection? Will you do a central compartment dissection in all patients with undergoing a thyroidectomy, hemi or total thyroidectomy?
So central compartments is mostly addressed in two ways. One is called prophylactic and one is called therapeutic. Prophylactic central compartment is done when the primary tumor is high stage, that is T3 and T4. And if we detect ultrasonologically or by ultrasound or by CT scan, clinically there is a presence of neck node, then we should address the central compartment or lateral compartment according to the positivity of the node. The guideline says that if there is a central compartment node about more than 8 millimeter, and if there is a lateral compartment node more than 1 centimeter, FNA proof, then we have to consider.
Okay, let me split it up for you. If there is a locally advanced thyroid cancer, you will address the central compartment.
Yes, sir.
If there are enlarged nodes in the central compartment, you will address the central compartment.
Yes,
if there are enlarged nodes in the central compartment, will you address the lateral compartment?
No, sir. That becomes a prophylactic neck dissection.
Right, okay.
So,
If there are enlarged nodes in the lateral compartment, but there are no nodes in the central compartment, will you address the central compartment?
yes, sir. Yes.
So, yes, please go ahead.
Is there, I don't
One
think
minute,
that
let him say no.
Sir, yes, if there is enlarged node, which may have been proved with an FNAC, and it is positive for this papillary carcinoma, then I'll address the central compartment also, sir.
Yeah, whenever there are when you are addressing the lateral compartment for metastatic nodes, you will address the central compartment. So if you are doing a hemithyroidectomy, will you address the ipsilateral component of the central compartment, or will you do bilateral?
Sir, node is there.
We are addressing the ipsilateral central compartment because there is an enlarged node.
Yeah.
My question is, will you do both sides or will you do only one side?
In the ipsilateral side, sir. In the ipsilateral side is enough.
See,
If
the-
there is no node in the contralateral
The
side.
concern about central compartment dissection is because of permanent hypoparathyroidism. The superior parathyroid you can preserve,
Yeah.
where it's anatomically at a constant location. The inferior parathyroid unfortunately can go anywhere up to the arch of the aorta, and so you don't know where to look for it, and so you are concerned that you will end up with permanent hypoparathyroidism. That is why this whole, otherwise you will clean carotid to carotid and leave the whole area bare. The problem is with the parathyroids. Recurrent nerve damage is very unusual. Most surgeons will know how to preserve the recurrent nerve. It is the parathyroid which are a problem. So let me ask you one question. You're doing a hemithyroidectomy, but on the opposite side there is a 0.8 centimeter nodule. How will you address that?
Sir, we can go for the FNAC of this nodule if it is positive, definitely we will go for the bilateral neck dissection, lateral neck dissection.
Anybody else?
If it is negative, so we can.
If it is negative, yes.
If it is negative, we.
Opposite side. This side has a 3 centimeter nodule on the right lobe. Left lobe has a 0.8, the previous patient, 0.8 centimeter nodule. Will you do how will you handle that situation?
So regarding primary or second neck dissection?
Not the neck, the thyroid. We are talking of hemithyroidectomy and total thyroidectomy. This patient had a hemithyroidectomy. But what sonologically or on the table you find a nodule in the opposite side which is 0.8 centimeters.
So this patient goes for a total thyroid. Sir.
So, and the report will come as a benign nodule.
It's something like doing a lobectomy for nodule, because there is a CA in the one lobe. So multicentery is an indication of.
So
total
while the fact is in the incidence of cancer in a solitary nodule is much higher than an incidence of cancer in multinodular goiter.
Correct.
But when you have multiple nodules, each nodule has the same risk of a cancer.
Yes.
So it's quite possible that you will have one nodule which is having cancer and the others are all benign. This is very likely.
Very.
And so a lady who's 35 years old who has a 3 centimeter thyroid cancer on one side, the opposite side if there's a 1 centimeter nodule or a 0.8 centimeter nodule, I think it is important to talk to the patient about what we are proposing to do. We talk about the pros and cons of a total thyroidectomy, about the need for iodine replacement, about the need for thyroxine replacement, iodine ablation, follow-up, and all the and the risks of hypoparathyroidism and recurrent nerve, vis-a-vis evaluating that nodule. What he says may be a good option to do an FNAC and see if that is benign or malignant. If it is benign, we have the option of doing a hemithyroidectomy and leaving the opposite side alone for follow-up.
Sir.
Yes.
Sir,
please.
is there any role of a nodulectomy during the surgery?
Sorry, role for?
Nodulectomy.
No, we don't do anything
Nodulectomy.
less than a total
Or a
lobectomy in
or a
thyroid these days.
Even lobectomy is rarely done, sir, nowadays. It's called a hemithyroidectomy.
Hemithyroidectomy, okay.
Part of the lobe and the part of the isthmus has to be removed.
So we've done the hemithyroidectomy for the opposite side. What remains is the lobe only.
Sorry, sir?
We've done the hemithyroidectomy for the opposite side. What remains is only the lobe.
Yeah.
Okay, we don't have time. We've already exceeded the time. So, so all of us are familiar with the risk stratification parameters for thyroid. Age and sex are mandatory for all staging risk stratification systems. There is extrathyroidal extension, there is metastatic disease, there is now aggressive histology. We'll probably get into molecular staging also. So what happens following surgery? She's had a hemithyroidectomy. So will the follow-up differ for hemithyroidectomy and total thyroidectomy?
Sir, let me see the previous slide.
She's had a hemithyroidectomy.
Yeah.
She's a 35-year-old lady. She had a 3 centimeter papillary carcinoma in the thyroid. There was no extrathyroidal disease. Clinically, we did not have any metastatic disease. It was a classical papillary carcinoma thyroid. How are we following her up?
Metastasis in the distant metastasis or sir regional?
Clinically, there's no metastasis.
Yeah.
We have not done a PET scan. We have not done a CT chest. We only done a hemithyroidectomy.
Okay, it is.
Stage
Yeah.
1, well differentiated thyroid cancer in 35 years. Yes.
We will keep the patient in follow-up.
That's clinical follow-up.
Yeah.
So will we do a serum thyroglobulin?
Thyroglobulins are no, it's such no role.
Unless
because,
we have done a total thyroidectomy,
Yeah.
we are not going to use serum thyroglobulin for
No.
follow-up.
No,
Are we going to put her on suppressive doses of thyroxine?
no, sir, not at all necessary because it is hemithyroid.
Anybody else?
So I will do a single THS stage in the first postoperative period to see, because it has been seen from the studies that if we do 100 cases of hemithyroidectomy, at least 1/3 will end up in
Yeah, hypothyroidism. Yeah, that's fine.
So that is only done to just to see whether the thyroid status, other than nothing else.
Yeah.
Still we can
Unless we have done a total thyroidectomy, we are not putting the patient on suppressive doses of levothyroxine. Will we consider iodine ablation? When will we consider iodine ablation following a total thyroidectomy?
So it is.
Later.
So iodine ablation for total thyroidectomy as per ETA guidelines is recommended only for intermediate risk and high risk cases. It is said that radioiodine ablation is not routinely recommended for low risk cases, and if at all anyone wants to give radioiodine therapy in case of low risk cases, then 30 millicurie is sufficient and need not give more than, means 30 millicurie is preferred over higher dose. That is, this is what ETA guidelines says.
So there are two schools of ablation. One, I know what we used to follow at the institute was we would give a 5 millicurie dose, not as ablation, to do a scan, and if there is increased uptake in the thyroid bed, we would give 30 millicuries, as you say, and if there is no increased uptake in the thyroid bed and 5 millicuries does not show metastasis, we would not ablate them.
So actually for doing the scan, it is not, if we do not go for 5 millicurie, we give 1 to 3 millicurie just to avoid the phenomenon of stunning in therapeutic dose.
Okay.
So we can do the scan with 1 to 3 millicurie, that is called the diagnostic scan. Diagnostic scan means not to diagnose the disease. Patient is already diagnosed with the disease. Diagnostic scan means to see whether the uptake of the radioiodine tracer is there or not in the neck or anywhere else. And then 30 millicurie is the ablation dose only when there is uptake in the neck, in the thyroid bed, postoperative site of thyroid bed. If there is metastatic uptake outside in the nodes or lungs or bones, then 30 millicurie will not be sufficient at all. But in this case, patient has undergone hemithyroidectomy.
No,
so
forget her. If we've done a total thyroidectomy.
Okay, total thyroidectomy. So total thyroidectomy, intermediate risk, high risk, we can go ahead with therapy, and low risk, if anyone wants to give therapy, 30 millicurie is sufficient.
My question is, will you straight away do a 100 millicurie or 80 millicurie dose, or will you do a uptake scan and then decide whether you need to ablate or not?
Pardon, sir?
See, my question is, patient has a total thyroidectomy, TSH is tested and found to be very high, and so you've decided to ablate her. My question is, will you do a diagnostic scan before deciding on ablation, or you just give them
No, sir, diagnostic scan is mandatory. Whenever any radionuclide therapy we are dealing not only in thyroid, or like we are giving PRRT and all, the diagnostic scan is, the one scan before giving therapy is mandatory.
So you
we
will
have to do that.
So you do a 1 millicurie diagnostic scan.
Yes, sir.
If there is systemic uptake, you ablate. If there is no uptake, you don't
no
ablate.
uptake, we do not ablate, because if there is no uptake, then we are giving a higher therapeutic dose of 30 millicurie. So that uptake will not be there by the thyroid cells.
If I am not wrong, Mandagini, if you do a diagnostic scan, suppose there is an uptake of around 5%, 7% in the thyroid bed, are you going to ablate?
See, with iodine scan, we hardly see the percentage of uptake. If any focus of uptake is there, visibly.
So any minimum focus of uptake you will go for ablation?
Yes,
or
we do. We do go.
See, my understanding is, any uptake in the neck, you will go with 30 millicurie.
Yes, yes, sir.
Any
yes.
uptake elsewhere, you will go with a higher dose, 80 or 100 millicurie.
But
if there's no uptake, then we don't do any ablation.
We don't do any ablation.
so once Dr. Bal from AIMS told that we do a diagnostic scan, and there is a happy percentage for the nuclear medicine physicist, and that is below some percentage. I forgot actually, it's 3% or 7%. Even there is a uptake of 3%, 7% in the thyroid bed, that need not to be
That is what we used to follow at the institute also.
Yeah.
Less than 5%, we would
Yeah.
not ablate.
So
But
diagnostic
I
scan
think
will,
thoughts are changing now.
yes, a diagnostic scan will guide us for ablative scan and all.
Thank you. I think we've overshot the time. Thank you very much. Yes, sir. Please
Sir,
go ahead.
but, for this patient, 3.5 centimeter nodule.
No, Mr. Sir was asking when will you ablate, not forget about this case.
Thank you very much.
Thank you, sir.
I call upon the panelist and the moderator to the felicitation corner for felicitation. I call upon the panelist and the moderator to the felicitation corner for felicitation. I request Dr. Professor Kalpana Sharma to kindly do the honor.
Thank you. Thank you.
Thank you very much. You are a good examiner. Very simple questions.
Hello? Quizmaster Anupam Hazarika wants to make an important announcement for the postgraduates.
I'm the deputy actually. Quizmaster is still on the way and we have announcement here. We invite as many postgraduate groups from all the existing medical colleges and other DNB institutions. They can submit their name to our scientific secretary, NEBOI, and to me as well. And each group consisting of 3 members and 2 groups preferably from each medical college if you have more than 1 groups, but not more than 2 groups. And we may have make changes as per the number of participants and the number of groups. So 3 can become 4 as well. So you can just have a permutation combination amongst yourself from the medical colleges where from more than 2 groups are expected. So you can submit your names either to Rinku ma'am or to me. Yes, 2 can also. Minimum 2. 2 member group can also be there. Maximum 4.
We are going to start our next session. This is invited talk. The chairpersons are Dr. Quddus Ahmed and Dr. P.K. Saikia. You are requested to take the chair. The first speaker is Dr. Debadip Bakchi. His topic is surgical anatomy of the thyroid gland. Dr. Debadip, are you prepared with your slides?
Beforehand, I have a request to each and everybody to attend the GBM, General Body Meeting, on time. It's my earnest request to you all, because I like to change little, and there are so many things to be discussed there. Okay, thank you.
Good morning, everyone. My name is Dr. Devadip Bakchi. I am presently a consultant in the Department of Head and Neck Oncology in the State Cancer Institute, Guwahati. I completed my MS in ENT and MCH in Head and Neck Oncology from the AIMS, New Delhi. And today, I will be talking. Sir's mic is not working. No, sir wants to say.
Time for presentation is 13 minutes, 2 minutes for discussion. Okay.
Yes, sir. Yes, sir.
Okay, thank you.
Thanks. So, the topic of my presentation today is the surgical anatomy of the thyroid. So, let us start with a little bit of history. So, the thyroid is an endocrine gland which is present at the front of the neck, and although nowadays it is such a common surgery, there was once a time when we didn't understand what it was. So the anatomy had not been started to be recognized even up till the Renaissance, even though goiter as an entity has been known since ancient times. So a few names are definitely important. The thyroid gland was named for, due to its shape, which looks more like a shield, and it was named by Thomas Wharton in 1646. There was once a time when thyroidectomy was considered a butchery, and it was actively discouraged amongst medical circles. However, gradually that changed. The first partial thyroidectomy was performed by Pierre Joseph Nasal, and the first total thyroidectomy performed by Guillaume Dupuytren. These were all in the 18th century. However, even in spite of all these advances, it still remained a very dangerous surgery until the advent of anesthesia, antisepsis, and the invention of the surgical hemostats. Two names are important to mention. Dr. Albert Theodore Billroth, who pioneered thyroid surgery at the very beginning and very bravely published a mortality rate of 40% in his case series. But that series was before the antiseptic era. That mortality came down to 8% once he started using antiseptic protocols in his surgical OT. However, the biggest name in thyroid surgery must be Dr. Theodore Cocker, who was instrumental in developing the modern surgical technique and demonstrated a mortality rate of 0.2%. So that's a difference from 40% to 0.2%, and he received the Nobel Prize in Medicine in 1906 for his contributions. So why is the anatomy of the thyroid important for us surgeons? Many a times we have to put knife to the skin for many indications, broadly, which we can consider them to be because of cancer, cosmesis, or because the patient himself is choking on his thyroid gland. However, the risks are many, and before surgical training, before the anatomy was understood, the patient would bleed either during OT or after OT. Sometimes they would develop hoarseness, sometimes they would develop stridor, sometimes they would develop tetanus, sometimes all of this all at once, and mortality rate was significantly high. So starting from the embryology, where does thyroid gland originate from? So it's the earliest endocrine gland to appear, and it has a rather complicated development journey. There is a double origin of the thyroid gland. The primitive pharynx gives rise to the structure called the median thyroid anlage, and there are simultaneously there is a paired development of the lateral thyroid anlages. These develop from the neural crest. So from the second to third week of gestation, the median thyroid enlarge originates over the first to second branchial arches. It's at the midline, and as the thyroid gland develops, it is dragged down along the neck along with the descending heart. So it expands to form a bilobed structure, and as it descends down, some of its remnants stay back at its site of origin, which is often seen as the foramen cecum at the base of the tongue. The lateral thyroid analages are also known as the ultimobranchial bodies. These are 2 in number, and they originate in the 4th pharyngeal pouches. With the development of the thyroid gland, they fuse with the median enlarge, and they contribute to the development of the parafollicular C cells. As we will see in further slides, the parathyroids are related, especially the superior parathyroids are related to these ultimobranchial bodies, the lateral thyroid analogue. The parathyroid glands are separate glands, but they are very intimately related to the thyroid. The superior parathyroid gland originates from the endoderm of the 4th pharyngeal pouch, and as such they are often denoted by the notation of P4. The inferior parathyroid develop from the endoderm of the 3rd pharyngeal pouch, and they are denoted as P3. The P3 develops superiorly, but they migrate inferiorly along with the thymus, whereas the P4 migrates along with the ultimobranchial bodies. So once the embryo has developed into a baby and eventually the baby grows up, so where does the thyroid lie? It lies in the lower anterior neck straddling the upper trachea, most commonly over the 2nd to 4th tracheal ring. It is the largest endocrine organ in the body. It weighs around 15 to 20 grams. It is bilobed with a narrow isthmus. Each lobe measures around 8 to 10 ml in volume and measures around 5 cross 3 cross 1.5 centimeter in size. It is invested by the pretracheal fascia, which holds it in place. Parts of the fascia are thickened especially over the isthmus, where it is referred to as the anterior tracheal ligament, and the upper part of this anterior tracheal ligament, which is around here. So this is known as the suspensory ligament of Berry, and it creates a very firm attachment between the thyroid and the trachea, and it is very important during surgery, as if they are not properly controlled, then it's a site for a very irritating bleeding. So grossly we can see that the strap muscles cover and invest the thyroid. The thyroid is practically hidden behind curtains made of the sternocleidomastoid, the sternohyoid, the omohyoid, and the sternothyroid. The lobes of the thyroid are placed posteriorly, and as we will see in future slides, there is a structure called the tubercle of Zucker-Kandel, which often overlies the posterior aspect, and sometimes it can insinuate into the tracheoesophageal groove. Laterally it is related to the carotid artery, and during surgery the carotid artery has to be separated from the thyroid to make space for dissection. The coverings of the thyroid are basically 2 in number: the investing fascia, the pretracheal fascia that we have that I have just mentioned, and the true capsule. So the plane of dissection often proceeds along a plane just between these 2 capsules. So this is called the subcapsular dissection, and dissection in this plane ensures that there is minimal bleeding encountered during surgical resection. So the vascular supply is it is supplied by 2 paired arteries and 3 paired veins: the superior inferior thyroid arteries and the superior middle and inferior thyroid veins. However, sometimes there is the presence of one unpaired thyroid artery, which is often present at the inferior pole. This is known as a thyroid ema, often seen in up to 3% of case thyroidectomy specimens, and it arises from the innominate artery. The superior thyroid artery is the first branch of the external carotid. It courses inferiorly, deep to the omohyoid, and superficial to the inferior constrictor and the cricothyroid muscle. As we can see, this is the thyroid ema artery that can arise in up to 3% of patients. The thyroid veins, the superior and middle thyroid vein drain into the internal jugular vein, whereas the inferior thyroid vein drains into the brachiocephalic veins. The inferior thyroid artery arises from the thyrocervical trunk and it passes deep behind the common carotid artery, and it runs in a course which is perpendicular to the recurrent laryngeal nerve. We'll see the laryngeal nerve in more detail in further slides. So the superior thyroid and veins, they often terminate in multiple small terminal branches, and these branches are often intertwined with the external branch of the superior laryngeal nerve. And there used to be a dictum that we should tie the artery away from the superior pole, but that has now changed, and it is more prudent to have a more meticulous dissection and deligate these specific terminal branches in order to spare the nerve. Similarly, the inferior vein and the inferior artery, they also have multiple terminal branches, and the inferior vessels are often related to the inferior parathyroid gland. The inferior thyroid artery is the major blood supply to both the superior as well as the inferior parathyroid glands. The lymphatics are distributed into two broad categories, the intraglandular and the extraglandular network. The intraglandular network is hypothesized to be the reason for multifocality that is often seen in thyroid cancers. The extraglandular network, for the most of the gland, it passes through the central compartment, that is the level 6, and then it follows the arteries in a retrograde manner, the secondary lymphatic echelons being the lateral neck. The one exception to this is the superior pole, because it has a different origin and it lies more superiorly. So there are possibilities of direct lymphatic drainage to level 2 bypassing the level 6. So who are the neighbors and who occupy the neighborhood of the thyroid gland? So the larynx is innervated by the superior laryngeal nerve, the recurrent laryngeal nerve, and sympathetic fibers, and these nerves are practically smothered by the thyroid gland. So and they're intimately related to each other, so their knowledge is very critical during thyroid surgery. So the superior laryngeal nerve arises from the vagus 2.5 centimeters below the skull base. It passes deep to the carotid and divides into an internal and external branch. The internal branch goes into the thyroid membrane and it is away from the thyroid, and unless the thyroid is enlarged, we are unlikely to encounter this branch. But the external branch runs parallel and deep to the superior thyroid artery, and it ends medially in the cricothyroid muscle. In 10% of patients, however, the external branch can enter into the inferior constrictor before it enters into the cricothyroid muscle. The recurrent laryngeal nerves are also branches from the vagus, and they follow a fairly complicated course. So during development, they loop under the 6th aortic arch, but as the embryo develops, the 6th and 5th arches are lost and they come to lie beneath the 4th arch. And the 4th arch creates different structures on either side of the body. So on the left side, the branch, the recurrent laryngeal nerve arches under the aortic arch posterior to the ligamentum arteriosum, and on the right side it loops around the right-sided subclavian artery. Posterior to the lobe of the gland, it goes along the tracheoesophageal groove in a inferior to superior direction, and it enters the larynx posterior to the cricothyroid joint. It has been seen that in around 60% of patients, the recurrent laryngeal nerve divides into an anterior and posterior branch around 5 millimeters below the cricothyroid joint, and it has also been demonstrated that they send fibers to the inferior constrictor muscles as well as the cricopharyngeus muscles. So damage to the recurrent laryngeal nerve can cause not just hoarseness, but can also lead to a certain degree of dysphagia that some patients may report post-surgery. The parathyroid glands have a very unreliable anatomy, and 85% of the superior parathyroid lies within a 2 centimeter radius of a point 1 centimeter above the inferior thyroid artery and recurrent laryngeal nerve intersection. The inferior parathyroid lies below the inferior thyroid artery or within 1 centimeter of the lower pole of the thyroid. If we take a coronal plane along the plane of the recurrent laryngeal nerve, the superior parathyroid lies dorsally, the inferior parathyroid lies ventral to this plane. Triangles have been described by many surgeons over the course of the years to describe the critical anatomy of this region. So I will just mention a few. The Bear's triangle is bounded by the common carotid, the inferior thyroid, and the recurrent laryngeal nerve. The Simon's triangle, common carotid, esophagus, and the inferior thyroid artery. The triangle of concern, which is considered to be the commonest site for bleeding, is bounded by the trachea, the recurrent laryngeal nerve, and the base of the neck, the root of the neck. with the Berry's ligament at the apex. The lower's triangle is bounded by the medial border of the common carotid, the trachea, and superiorly by the inferior pole of the thyroid. The Joel's triangle is formed by the midline, the hyoid bone, and the superior thyroid pole and the superior thyroid pedicle. And the cricothyroid space of Reeves, which is an avascular space between the upper pole of the thyroid gland and the cricothyroid muscle. And dissection in this space is important, as identifying and opening up this space reveals the external branch of the superior laryngeal nerve to the operating surgeon. The thyroid pathology, the thyroid anatomy can be quite fickle, as there is a lot of variation. So along the course of descent of the thyroid in the embryological origin, there may be ectopic tissues and thyroid rests. So the most common kind of ectopic thyroid would be the lingual thyroid, which is seen in 90% of patients. There can be other ectopic rests which can lie in the sublingual, high cervical, or even mediastinal area. The descending thyroid stalk itself can persist anywhere along the path of descent and lead to the formation of thyroglossal cyst and thyroglossal sinuses. The pyramidal lobe is another embryological remnant of the thyroglossal tract. It is seen in 55 to 76% of patients and is more common on the left side of the isthmus. The lateral aberrant thyroid has been described in literature, which is more likely to represent metastasis from follicular thyroid cancers. However, rarely they can also be due to non-fusion of ultimobranchial bodies.
Please wind up your space.
Just final few slides. The tubercle of Zucker-Crandall is seen in up to 2/3 of thyroid glands. It lies posterior and lateral to the thyroid gland and overlies the recurrent laryngeal nerve. Sometimes the recurrent laryngeal nerve can even run a course superficial to the tubercle of Zucker-Crandall. Similarly, I already mentioned the parathyroid glands. They can be very inconsistent in their position, and even up to 12 glands have been reported in the literature. The superior laryngeal nerve is classified by the Cernia classification. And it can have 3 different types, where depending on its distance from the superior thyroid pedicle. What is important for the surgeon is that in up to 20% of cases, the superior laryngeal nerve can dip down to below the superior pole of the thyroid, and that causes risk of injury during surgery. The last, I would mention the recurrent laryngeal nerve. The most important here is the non-recurrent laryngeal nerves, which is seen very rarely, more on the right side, around 0.2 to 1.6%. However, it can also be seen on the left side, and its incidence is seen to be 0.4%. It is always associated with some sort of vascular anomaly. On the right side, it is associated with the aberrant subclavian artery or the absence of the innominate artery, and on the left side, it is
can you please wind up?
Situs inversus. Last slide, sir. Related with the situs inversus. So. This is the last slide. I will just skip it because of lack of time. And basically what we have learned is that thyroid anatomy is intricate and confusing, and surgery can be dangerous if performed recklessly. And knowledge of anatomy allows us to navigate the ocean of surgery safely, and it is imperative that all surgeons are very well versed with the involved anatomy. Thank you.
Thank you, Dr. Devadeep. This discussion will be at the end of all 3 papers. The next speaker is Dr. Pratap Kakoti. His topic is radiological evaluation of thyroid pathology. Dr. Kakoti, please.
Dr. Pratap Kakati is a senior radiologist at Guwahati and is practicing at Arya Wellness Center in Guwahati. So he will be talking to us on the radiological evaluation. Dr. Kakati, you can start while the, yeah.
Okay, good morning everybody. Thank you organizing committee for inviting me to be part of your forum. So today I would like to talk about the thyroid pathology, especially thyroid nodule using ACR thyroid guideline. So learning objective of my talk to know about little bit of statistics, demographics and impact of thyroid cancer in patients, understanding the concept of overdiagnosis, and to introduce you a thyroids for thyroid nodule thyroids, and to apply some thyroids cases, thyroids to unknown cases. So you know thyroid nodule is a very common in your clinical practice. So how common is it? It depends on detection of the methods. It depends on, in autopsy it's 2%, by clinical diagnosis 0.2%, and overall diagnosis of the overall death of the papillary carcinoma is very minute, only 0.3%. More importantly, in the last 20 of 25 years, 80% of the thyroid nodules are found, meaning that there is threefold increase of the thyroid nodules since 1990, perhaps because of Chernobyl or other nuclear disaster. More importantly, increased use of ultrasound, leading the increased number of the nodules and other cross-sectional modalities, and this leads to overdiagnosis of the thyroid cancer. So what is overdiagnosis? Overdiagnosis is a detection of disease that never caused symptoms or death to the patient. Because it shall never harm the person, harm instead could come from the treatment used to cure the thyroid cancer. And some patients may have postoperative complications like vocal cord palsy and hypocalcemia. And more importantly, we label the patient as a cancer victim. It leads to a lot of mental stage on the patient. In fact, 50% of the thyroid cancer in women and 40% of the men in last 20 years clinically irrelevant, meaning that we are treating the patient that not help for the health of that particular patient. If you see the curves, new cases versus that, the blue line, this is the curve here. You have seen since 1997, 75 to 2010, 2014. There is, although cancer detection has gone up to substantial increase from that point to that point, but the rate of death from this orange one, the rate of death from the thyroid cancer remains almost constant. Therefore, we are not detecting thyroid cancer that impacting mortality. So question is, what is bad cancer actually? So bad cancer is, fortunately, it's not very common. So most of the carcinoma, thyroid cancer, well-differentiated papillary carcinoma, and almost nearly indolent and benign acting. If you see this curve, the survival rate approaching almost 100%. From almost 100% of the. So what do radiologists do? So radiologists, we use triad. We use some features to differentiate malignant versus benign, and thereby to improve the quality of the care and cost effectiveness of the patient. And we as a radiologist use public guidelines. That's why we bring public guidelines, so-called THYREDS. THYREDS stands for Thyroid Imaging Reporting and Data System. So what is THYREDS? The aim of the THYREDS to standardize the recommendation regarding when and how to report the incidental thyroid nodule, use of standard lexicon for reporting so that you can understand what radiologists write. Basically, it gives a effective communication between the radiologist, cytologist and clinicians. Okay? So level of suspicion of each nodule is similar to BIRATS. The nodules, incidental nodule detected on EUSG is based on this composition, echogenicity, shape, margin, presence or absence of the echogenic foci, that means calcifications. There is increased risk of malignancy allergy recommendation for when to pursue biopsy if you follow the thyroid category. Each category is assigned a point, multiple points, 1, 2, 3, 4, 5, like that. And all values are added, and each nodule given a thyroid category. Okay, I will see in the later slides. So what are the thyroid category? This is the graphics borrowed from the white paper of the Asia Thyroid Committee. Here you can see 5 categories: composition, ecogenicity, shape, margin, and ecogenic foci. That means calcification. So some features are given to that particular categories, and points are assigned to each features. This, by permutation and combination, you add the features, you will get the thyroid category. Okay. First features, the composition. We choose one of that. You have a five composition: cystic, spongy, mixed, and solid. What is cystic? Is black, totally anechoic. This black thing is totally anechoic. There is no point. The follow-up should be stopped here. If you see this cystic nodule, no follow-up, nothing, no FNC. If you have a spongiform nodule means the cystic part is more than the solid cup. More than 50% of the nodule should be consist of cystic component. So if you see the spongy, if I write the spongy nodule, there is no need for follow-up, no need for FNS. Okay. Then third category is a mix. That means you have a solid component, you have a cystic component. Thyroid get 1 point. Okay. Then if the nodule is totally solid, is almost ecogenicity similar to thyroid nodule, you get 2 points. In solid nodule, 2 points. Second category, ecogenicity. If you see the normal thyroid gland here, this is the normal thyroid gland. This is the capsule ecogenic line here the capsule, and these are the step muscles. Ecogenicity compared with this thyroid nodule and muscles. So if it is hypoechoic, cystic, that is called anechoic, 0 point. If it is isoechoic, the nodule almost similar to thyroid gland. That means it's isoechoic. Or if it is ecogenicity is more than thyroid gland, this is called hyperechoic. Okay, it gives 1 point. Then this is the nodule. This nodule is relatively hypoechoic as compared to this is the normal thyroid parenchyma. So this is the hypoechoic. It gets 2 points. This is the hypoechoic. It's the hypoechoic is lesser than the hypoechoic. This step muscles. It's not as much as like thyroid, but it's too hypoechoic. It's called very hypoechoic. It gets 3 points. So whenever I write hypoechoic, hyperechoic, or very hypoechoic, meaning there is increased risk of malignancy whenever I describe the nodule as a hypoechoic or very hypoechoic. Shape, only 2 shapes. This is called wider than taller and taller than wider. This is the canvas scan of the, if you do the scan here like that, you will get this image. Then you measure like that. Measure like that. This is wider than taller, this is taller than wider. Okay? 10 mm and 9 mm. So this gives you 3 points. It's a very sensitive sign for malignancy. Next is margin. You have a smooth margin here, 0 point. Ill-defined margin, suppose there is a multiple coalition nodule in your thyroid. You cannot determine the margin. This is called ill-defined. Okay? This is ill-defined nodule. Then this is nodule, hypoechoic nodule with irregular margin. Lobulated, this is lobulation. Hypoechoic nodule is lobulation. If you get lobulation and irregular margin, it gives 2 points. This is the nodule, ill-defined nodule. The capsule is here normally, but there is no capsule in that side, posteriorly and anteriorly. So this is called extracapsular extension. If you see the extracapsular extension, if I write the extracapsular extension, it gives 3 points. Okay, highest point in the extracapsular extension. Next category is echogenic foci. That means calcification. If I get calcification with comet tail artifact, that means the calcification gives some brightness in the posterior aspect of the calcification. This is called comet tail. It gets 0 point. If the macrocalcification usually tends to give posterior acoustic shadowing, you will get dark thing like that. Calcification below it, you get dark band here. This is called posterior acoustic shadowing. Then it get 1 point. And if you see the peripheral calcification, it get 2 points. And if you see microcalcification, micro dots here, 1, 2, 3, 4, 5, like a multiple punctate echogenic foci are seen. This called microcalcification, and it get 3 points. Okay? So microcalcification has the highest chance of malignancy. So what is Thyroid 1? Thyroid 1 is the anechoic lesion, no septation, no solid nodule, comet tail artifact with calcification, and spongiform nodule. When if you see the report like that, that means spongiform nodule, anechoic nodule, no need for FNSC, no need for follow-up. Thyroid 2 is the solid and cystic component, not suspicious, no FNSC. If there is no vascularity is there in the solid component. Thyroid 3, mildly suspicious, FNA or equal to 2.5 centimeter, and follow-up if it is more than 1.5 centimeter. Okay? Thyroid 4 is a 4 to 6 point, is a moderately suspicious. By FNA is required if it is more than 1 centimeter, 1.5 centimeter. Follow-up if it is less than 1 centimeter. Thyroid 5 is 7 point plus, so it's a highly suspicious. FNA is required for 1 centimeter nodule. If it is less than 0.5, you can follow up of this patient. The shortcut for you, if I write cystic or spongiform nodule in my report, there is no stop assigning the point. There is Thyroid 1, no need for FNSC. If I write solid or partial, solid complex solid cystic lesions with these features, taller than wider, very hypoechoic, extra thyroid extension, microcalcification, that it usually gets 4 points. So you have to do FNSC for that lesions. So higher the number of TR, the higher the chance of malignancy. Highest in TR5, almost 35%. So how will you follow up? Usually 6 months follow-up is not recommended in incidental thyroid nodule. Scanning interval less than 1 is not warranted. So except for high-risk cases. So for high-risk cases and in case of known cancer, you have to follow up shortly. In thyroid 5 category, yearly follow-up for 5 years, maximum to 5 years. T4, little less, 1, 2, 3, and 5 years. T3, even less, 1 year, 3 year, and 5 years. And all of this follow-up up to 5 years. Stop following follow-up at 5 years if there is no growth of the nodule. So what is growth? The growth is, if this nodule increase more than 20% at least 2 dimensions. Okay, AP or longitudinal, at least 2 dimensions, if it shows growth, or there is increase, 50% increase in volume, then this is called growth. Then you have to intervene of this nodule. Then FNA, usually we require to review the older scan. No specific guidelines for nodules which previously biopsy. So vascularity has no rule except atypical thyroid cancer. Elastography has a rule, but there's a lot of limitation. I'm not going to discuss about it. Okay. So what will you do? Suppose you have an incidental nodule in PAT. So what will you do? Always do FNSC, because a weak thyroid nodule have at least 40% risk of being primary malignancy. Okay? Then incidental nodule in the CT and MRI, do FNA. If it is suspicious, follow the Thyroid's, ACR Thyroid's guideline. So how many nodule you will do FNSC? According to guideline, at least if your multiple nodules are present, up to 4 nodules with highest point values will be biopsied. Okay? Then this is, let's see some examples. This is a nodule here, well defined. Cystic component is more than echogenic component, so it is spongiform nodule. So there is no FNSC or follow-up. Here is the nodule. The solid nodule is a 2 point. Isoechoic, almost similar to thyroid, 1 point. Taller than, wider than taller, 0 point. No calcification, 0 point. So how many points you will get? 3 points. So your thyroid is 3. This is a benign nodule. Okay? They follow the thyroid 3 guidelines. Here is the example of the thyroid nodule which is very hypoechoic. Okay? It get 3 points. Solid, 2 point. 3 into 2, 5. Wider than taller, 0 point. Angulated margin, 2 point. 5 into 7, and microcalcification 3, 10, almost 10 points. We are getting 10 points from this nodule. So it's a very suspicious nodule. FNAC was done, this patient, so revealed papillary carcinoma, thyroid. Last slide. So again, this is one of the example of the thyroid nodule, which is hypoechoic, solid 2 point, hypoechoic 2 points, lobulated margin 2 points. So it's a thyroid 5, and FNAC revealed papillary carcinoma. So conclusion, adult population harbors a large number of clinical and subclinical thyroid nodules. Stratified the risk of malignancy of a lesion based on the USG features of the lesion. The higher the accumulative score of the thyroid's level, the likelihood of the malignancy. Supporting reporting helps when to use FNA, follow up and ignore. Thank you very much. Any question?
The discussion will be
time is very short, so
discussion will be at the end of the session.
Okay, no problem.
So it was, thank you, Dr. Kakoti. It was a nice presentation on ultrasonography of thyroid gland, and I think people has learned, we have learned something from that. Next speaker is Dr. Rajjyoti Das. His topic is surgical management of differentiated thyroid carcinoma. How much is adequate? Dr. Rajjyoti Das, he is now professor of head and neck oncosurgery at BBCI. He is a senior person working for many years at BBCI and a well-known head and neck surgeon in our area. Dr. Rajjyoti, please go ahead.
Good morning, everyone. Now I will start my talk. I will be speaking on the surgical aspect, which we have already discussed during the panel. And I like to thank the organizers for giving me this opportunity to speak, to stand in front of you. Now, actually these talks were before the panel, but because of Ravikanand sir, he has to leave for his flight and all, the things has been reversed. So, what is the extent of thyroid surgery? So before 20th century, the thyroid surgery was taken to be a butchery with lot of complications and all. But since from Cockers and all, now the surgery has come to a precision surgery with involvement of endocrinologists, genetics, immunology, physiology, technical trainings, and multidisciplinary care. Now, why do you need to balance? Because we have seen that the total thyroidectomy and hemithyroidectomy, there is a lot of difference in respect to locoregional control, distant control, completion surgery, and we know that there is a lot of complication associated with total thyroidectomy in comparison to hemithyroidectomy. So these are some of the problems we mostly encounter during a total thyroidectomy. As you can see in the pictures, if a person becomes hypothyroidism, he has got problems from head to toe. And most common, most dreaded complication is the cardiac complication of hypothyroidism in the form of cardiac arrest and all. So we need to stratify our surgery, whether patient coming with a diagnosed case of carcinoma, whether he'll be benefited from a conservative surgery or we should go for a total surgery. So this is the complication rate of total thyroidectomy versus hemithyroidectomy. As you can see, there are a lot of differences in respect to vocal cord paralysis, hypoparathyroidism, which I have already told. Now, the type of thyroidectomy are hemithyroidectomy and total thyroidectomy. And we need to know the indication and extent of neck dissection, whether we will go with only central compartment or we will do it lateral compartment also. And as we have discussed, the role of active surveillance. Now, all thyroid operation must be extracapsular in nature, because there is always a chance of leaving behind tissue in the upper pole, Berry's ligament, and the pyramidal lobe. This is also called a thyroid ablation. because we ablate whole of the thyroid tissue with our surgery. Nothing left behind to be ablated by the iodine. Extent of thyroidectomy, as I have already discussed, there are definite implications, outcome, complication, and adjuvant treatment related to extent of thyroidectomy. So appropriate patient selection and personalized medicine is a very important factor that needs to be considered, because the choice of the treatment regarding patient choice is also important. Most of the cases of active surveillance, and in some cases of hemithyroidectomy, when patient wants that I don't want to go for observation and all. So in those cases, the patient decision needs to be considered. So these are the some of the type of thyroidectomy. As you can see, if you remove only the isthmus, it's called isthmusectomy. If we remove the lobe along with the isthmus, it's called hemithyroidectomy. Sorry. And if we remove extracapsular dissection of the whole of the thyroid, 2 lobes along with the isthmus, is called total thyroidectomy. Now these are the indication that we have already discussed regarding hemithyroidectomy, hemi and total thyroidectomy and total thyroidectomy. Now main point of controversy is in the point size of diameter. In 1 to 4 centimeter over a large study for around 10 years or more, it is seen that the extent of surgery, whether you go for hemi or total, in a well selected patient, hemithyroidectomy can suffice the treatment. But if patient, as I have already told, if patient doesn't want to go with the surveillance, then we can go for total thyroidectomy. But in cases of nodule more than 4 centimeters, extrathyroidal extension, distance or nodal metastasis, and aggressive histology, should go for total thyroidectomy. This is the guideline we talked about mostly in India. This is ATIA guideline. This has also given the same thing. If there is a neck node of around, nodule of around 1 to 4 centimeter, both the things can be done. Either it's a bilateral procedure or a simple hemithyroidectomy. So extent of surgery for papillary thyroid cancer. This is one of the largest study that has been quoted in the literature, 61,000 plus patients. And out of that 61 patients, 54,000 patients has gone for total thyroidectomy, and more than 8,000 patients has gone for lobectomy. And in 8 of the 15 years, you can see the curve. The survival rate of both the patients going for total thyroidectomy, as you can see, the dotted line, broken line is for total thyroidectomy, and the straight line is for lobectomy. The surveillance at the end of 15 years is almost overlapping. That means almost the same. This is another study of thyroid lobectomy for papillary thyroid cancer, long-term follow-up of 1,000 plus cases. So the cause-specific survival rate at the end of 25 years is more than 95%. So this is also the same. As I have already told, total thyroidectomy are associated with different types of complication. Asthenia is one of the complications that is associated with the total thyroidectomy. So again, the difference of long-term quality of life. Quality of life is an issue of even after thyroidectomy following total, because a lot of differences are there regarding the complication of hypoparathyroidism, the nerve injury. All these things need to be considered. So quality of life is an issue that need to be considered if we do a total thyroidectomy. Now another term called completion thyroidectomy. Suppose after doing a hemithyroidectomy, if we see some of the points like extrathyroidal extension, angioinvasion, nodal metastasis, then we need to consider the removing of the opposite lobe also, that is called completion thyroidectomy. Now these are some of the pros and cons of the hemithyroidectomy. As we all know, lesser number of hypothyroidism in associated with hemithyroidectomy, short duration of stay, the nerve injury is less. But if we see the cons, it's not possible to ablate with RIA, and for follow up with the thyroglobulin is not possible with hemithyroidectomy. Now total thyroidectomy also has got pros and cons. Certain authors say there is a better disease-free survival, TG monitoring can be done very accurately, but con is that again the complication rates are high. Now lymph node issue is a contentious issue in a differentiated thyroid cancer, because there are lots of lymph node positivity of the lymph nodes at presentation. But one good thing is that lymph node positivity doesn't have got any significance in the survival, but it has got significance of the significance in the recurrence rate. As you can see from the slides, ultrasonography can detect up to 30% of neck nodes, and in cases of follicular carcinoma thyroid, lymph node metastases are less. It's less than around 5 to 10%. In this follicular carcinoma thyroid, hematogenous spread to the bone and lung is more important. Now, how the nodal spread occurs in cases of thyroid? The first equivalent group is always central compartment, that is level 6 and 7. Then the level 4 lateral compartments, level 4, 3 and 2. And level 1 is hardly involved in cases of CA thyroid. So this is the pictorial image of the central compartment. As you can see, this is the central compartment. This is the central compartment. This level 1 is hardly involved. This is level 2, 3 and 4, and level 5B needs to be addressed. So what are the factors that constitute the nodal involvement? One is your multifocality. If there is a multiple nodules in both the lobes, then at presentation, if the ultrasonologist says that extrathyroidal extension, large volume tumor more than 4 cm, younger age. These points were discussed during the panel discussion. Younger the patient, more aggressive is the histology. So before the age of 18 years, so these points needs to be considered. Again, if you see a BRAF mutation in a nodule, this carries an increased risk of nodal metastasis, extracapsular extension accordingly. And if you see the histology, papillary has the highest number of nodal metastases, followed by medullary and followed by follicular variety of thyroid carcinoma. So these are the factors that has been studied by different authors, Wengxi, Changai, Ben, all are from Japan, Korea and all. They have quoted also the same thing, extrathyroidal extension, then size, pathology, then BRAF mutation, multifocality. These are the points that needs to be considered. Now, it's always satisfying to show your study in a clinical presentation. This is a study from our institute, which we have done few years back. We have also seen that if this was published in Indian Journal of Otolaryngology Head and Neck Surgery, we have also seen, if you can see the lower two columns, as the size of the nodule increases, the positivity in the different levels also increases. Number of nodes that appears in a size of nodule 2 to 4 cm is less than number of nodes that appear when nodule is more than 4 cm. So number of the primary nodule always corresponds to the nodal metastasis. This is again our publication. This is what we have shown, that pattern of regional metastasis in the papillary thyroid cancers. Pattern means what is the pattern in how it spreads, central compartment, lateral compartment, level 2, 3, 4. So if the nodule is located in the upper part of the lobe, then there is a chances of involvement in level 4 and 5 is more. Then one more point I like to keep in consideration is the utility of the lymph node ratio. Now what does lymph node ratio means is that if we dissect out 18 nodes and out of that 5 nodes has come positive in histology, and in another patient suppose there is a 10 nodes detected and dissected and 8 node has come positive. So that becomes a nodal ratio. So number of node positive in a case of thyroid cancer is also has got a relation to your survival and recurrences. So lymph node metastasis has, as I have already told, there is no effect on the survival, but it has got effect on the recurrence. So this slide, this is the logarithm how you detect if we get a newly diagnosed papillary carcinoma thyroid, if there is no proven nodal metastasis. If it's a follicular carcinoma, we'll simply do the primary. If there is a biopsy proven case of nodal metastasis, we'll go for central compartment, lateral compartment according to the primary and the ultrasonological report. So there is another term what we have discussed in the panel is called the prophylactic central compartment neck dissection. So what is prophylactic is that if there is no clinically evident neck node in the central compartment, that means in ultrasonology and in CT scan also there is no clinically positive neck node, but the size of the primary is more, that is in stage 3 and 4 or tumor more than 4 cm, we have to prophylactically address the central compartment neck dissection. So this is a pictorial post-surgical picture where we have done a total thyroidectomy with central compartment clearance on the both sides. As we can see, this is the vessels, this is the trachea, these are the cricothyroid muscles, this is the strap muscles, the sternocleidomastoid being retracted. This is how the specimen should look like. There should not be any macroscopic visible disease in the thyroid bed. So lateral neck dissection also has got some morbidity, and it's present in approximately 20 to 30% of differentiated thyroid cancer. Lymph node dissection is associated with considerable morbidity up to around 50% of cases. So this is a case where we have done a total thyroidectomy with central compartment clearance and lateral neck dissection. As we can see, this is the trachea, this is the strap muscles being retracted for lateral neck dissection. This is again the vessels, this is sternocleidomastoid, this is the nerve. So this is also ATA guidelines. I will not go into the details. Everybody can Google it from the go into the details of that. So validation of ATA guidelines in Indian population. This is one of our another study. We have also validated that the ATA guidelines has a role in our Indian population also. So this is one of the very lucky moment for India also, because this is a head and neck cancer summit which was held in February in Chennai. And this Indian guidelines in differentiated thyroid cancer, the journal has been released. And this journal was released by none other than, this is the gentleman in the slide is Mr. Dr. Jotin Shah. He is the chief of the head and neck service at Memorial Sloan Kettering, New York. And few of the hard copy were distributed after the release of the main guidelines. I am receiving one of the hard copy from the president of ISTS, Indian Society of Thyroid Surgeons, Jyoti Davalkar from Mumbai. So this is the guidelines, and this guidelines has got many chapters. Out of that, extent of thyroidectomy is one of the chapters, and everybody can download it from the website. So this is what we have discussed during the panel also. There are non-surgical techniques coming up. Very small thyroid nodule, cystic nodule, then recurrent small nodules.
Can you wind up,
be,
please?
Sorry, so I'll take.
Can you wind up, please?
So I'll take only 2 minutes.
Can be anyway.
So this is now a very upcoming procedure, non-surgical techniques. So this is a video where I am doing a non-thyroid ablation in a beef mouth. This I have done when I visited this Asian specific thyroid conference in Bangkok. It's a very simple procedure, can be done, and you can see in the monitor how it looks like. Once the ablation has been done, this part of the nodule has been ablated, and this is a Japanese instrument, and he's a surgeon, he's the staff of the Japanese company. You can see this part of the nodule, the white structure, this part of the nodule has been already ablated. So it's a simple technique that can be doable, and it's very good for the very small nodules, recurrent disease, and even small malignancy also. So this is one of the very important sides. The man with the gray hair, this is Akira Mayushi from Kuma Hospital, Japan. He has conceptualized the whole concept regarding the active surveillance. And he has got a lot of publications also. What he has shown that in 30 years 30 years follow-up of the patient, there is hardly 0.9% of the cases has progressed. So in low category, low risk patient, low risk patient, active surveillance is a very point to be considered. So this is a small short video. I will end up my talk with this video. It's only 1 minute video. Can somebody play the video, please? Oh, it just started. So this is how we mark the trachea. This is the marking on the clavicle. We are raising the submatrixmal flap. This is how after giving the hanging sutures, the superior pedicle has been identified, and this is the external superior laryngeal nerve. We hardly use choosers nowadays. We used to clip the superior pedicle vessels. This is the nerve. Superior pedicle vessels have been clipped and identified and divided. Lateral part of the thyroid gland being dissected with a cautery. This is the carotid artery. This is the right inferior parathyroid gland. Tubercular Zucca canal has come up, and just below that we will get the nerve. This is the nerve. This is the nerve. Different structures had been identified. So that's the nerve being preserved, thyroid lobe being elevated from the trachea, Barry's ligament, and it has been shifted to the opposite side. That's the trachea, superior parathyroid, inferior parathyroid, right radicular nerve. Opposite superior pole being clipped and divided. That's the nerve. One thing I like to highlight, once we detect the nerve, it's better not to trace it throughout its whole length, because there is a chance of vascular injury. So lobe being dissected out from the cricothyroid muscles with the cautery. The whole lobe in toto being dissected out. This is the dissection of the central compartment.
Can you fast forward and wind up, please? Dr.
So I have got
Rajati.
only 20 seconds. So this is the nerve being identified. We are doing as a left central compartment. So this is how the post-operative bed looks like, with all structures preserved. 3 parathyroid have been preserved. So this is the dissected specimen, both the lobes along with the isthmus. Now this is very much mandatory nowadays to look for the vocal cord status videolaryngoscopically. This is the serum calcium that is on the second post-op day. It's 9.4. Thank you for your patience hearing.
Thank you, Dr. Rajati, for taking us through the thyroidectomy procedure and how much is enough. Thank you so much. And actually, all the speakers have overshot their time, so the organizers have informed us that there will be no question and answer session now. So any question to be discussed over lunch or tea break. Thank you so much.
Thank you, sir. Thank you, audience.
I call
Thank you.
upon the speakers and the chairperson to the felicitation corner. Chairperson, please do felicitate the speaker. Debodip Bakchi and Pratap Kakoti, please come over to the felicitation corner.
We are sorry that the question and answers had to be curtailed because of the time constraints. Dr. Bakchi.
I call upon Dr. Bishwanath Sharma. I call upon Dr. Bishwanath Sharma, sir, to felicitate the chairpersons. I'm sorry to inform that Dr. Amitabh Roy Chaudhary is late because yesterday his flight was cancelled. So he'll be reaching here around 12:30 to 1. So we move to the next session, that is SN Memorial Oration Award. The chairpersons for this session is Dr. H. Priyasakhi Devi, Dr. Abadya Boragwahai, Dr. Bijay Boniao. Can you please come over to your seats. Speaker is Dr. Surajit Burman. His topic is What Eye Tells, Comparing Eye Signs to Vestibular Ailments. Dr. Surajit, please come over to the dais.
Good morning, everyone. I'm the organizing secretary of 36 NEBAOI Agartala. So I'm requesting all of you, please kindly attend Agartala for next year conference, that is NEBAOICON 36. So early bird registration is started already. You can contact with me. I'm Dr. Bidhan Das, or even you contact with Dr. Biplab Nath sir. Or we are keeping all these things in the opposite to your registration corner, that is Jupiter Pharma. You can contact directly with them. So please all of you join with us next year, that is 36 conference 2025 Agartala. Thank you very much.
Good morning, all the delegates. And so now we will switch on to the S.N. Sharma Memorial Oration. And we, the chairpersons, thanks to the organizer for giving chance to chair this session. I request the speaker to proceed it, Dr. Surajit Burman. Please get.
Thank you very much, ma'am. And with the permission of the chair, respected madam and sir, and present dignitaries, I am Dr. Surajit Burman. It is an honor to be able to present the Dr. S.N. Sharma Memorial Oration in NEBAOICON 2024. Before going into my presentation, I think the previous generation, we do not need to talk about Dr. S.N. Sharma sir, but S.N. Sharma sir was the stalwarts, was the leading light of ENT as far as Northeast is concerned. So it's such an honor to be associated with such a big luminary. Thank you everyone for this honor. So going to my presentation, what the eyes tell, correlating eye signs to vestibular ailments. I'll start with a simple question. What is the primary function of the vestibular system? We all know the primary function of the vestibular system is to keep balance. And one of the most important pillar of the vestibular system is the semicircular canal. And if I change this question and ask what is the primary function of the semicircular canal, what will be the answer? So anybody who has done the Yenepoya course will immediately answer gaze stabilization, I think. Mukherjee sir said that. So the primary function of the semicircular canal is gaze stabilization. The semicircular canals are part of the visual system. So this is a big statement, but this is true because what basically the semicircular system does is controls the eye movements so that the eye can be independent of the head movements. Why do we need to be independent of the head movement? Is because we humans are basically foveal creatures. What do you mean when we say we are foveal creatures? What we mean is that the fovea in our retina is where the maximum contrast is there, and only images that are falling in the fovea are seen perfectly. So today I'm standing here, I may have all of you in my visual field, yet 99.9% of you are completely blurred out. It is only that particular one person or one point in this whole hall which is falling on my phobia that is perfectly visible to me. How do we prove that? Very simple. We just put up our hands, put our two thumbs in front together, and start looking at the right thumb. As we are looking at the right thumb, what we see is each mark of the right thumb very nicely, very nicely. But at the same time, the left thumb, which is just 1 centimeter away, is blurred. And if we shift our focus to the left thumb, the right thumb becomes blurred. So what it does is the object of interest to be seen clearly and sharply, as in reading the alphabet, the object has to be kept steady on the fovea of the retina. A moving object challenges this requirement. Why? So when I say moving object, it may be what the object that is in front of me is moving, or it may be that I am moving around. When that happens, because the eyes are otherwise fixed inside the eye socket, which is part of our head, when this moves, the eye will also move along with it. So when the eye moves, the phobia being part of the eye will also move. So it becomes imperative that the phobia becomes independent of the head movement, so that we can go on having that image fixed in our eyes. And what helps in this is two systems called the smooth pursuit and the vestibular ocular reflex. What are these? Smooth pursuit is basically good up to 60 degrees per second, the movement. So it is very good in slow movement. Further, it has a latency, so it does not start immediately. It takes a little time to start. So when there is a sudden jump of the movement, either I am moving suddenly or what I am looking at moves suddenly, the smooth pursuit is unable to take hold of it. It is good when the movement is, however, sustained. A long, slow, sustained movement, smooth pursuit can take care of it. The main advantage of smooth pursuit is that it is effective both when I am moving or you are moving. So it is not dependent on anything because it is centrally controlled. The vestibular ocular reflex, the advantage is that it has very short latency, so it can jump into work as soon as the head moves. It is very effective in very high velocities, up to 350 degrees per second, but it is only effective when the subject, that is I am moving. It is not at all effective when what I am looking at is moving. Example, I put my finger up, I am looking at my finger, and I am moving the finger slowly. And we can see the finger appears nice in our field of vision. But if I suddenly start moving the finger very fast, my own finger, we can try that, becomes blurred. Now do the opposite. Fix the finger, move the head. The finger is visible very nicely. Now move the head fast. The finger is still very nicely seen. That is because the viewer will not work when the object is moving, but it works when the subject is moving. Hence, the eye movement at various speed and angle can be used as a measurement of the vestibular system and can speak a lot about not only the type of vestibular deficit, but also the site of the deficit. So now I come to my study. The object of this study was to record various anomalous eye movement and correlate it with various other vestibular investigations to understand how each anomalous eye movement correlate to the specific vestibular ailment. Material and method. Anomalous eye movements patterns of the eyes were recorded using a vestibular oculogram. More commonly we call it a VNG, vestibular nystagmogram, but because it records much more than simple nystagmus, it is now called VOG. I think we have something higher coming up, COG, which had a glimpse yesterday, and it was correlated with other vestibular investigations. The investigations that were used in this study, of course, as already mentioned, we used VOG, a test where eye movements are recorded to find out the status of various components of the vestibular system. We use something called a craniocorpography, a graphical representation of the Romberg and Unterberger's tests. You can see the camera on top. this is not a patient, this is my assistant in my chamber, and that is why I can show him fully. And he has this something on top. So we can explain all of this later on. We actually have a instrument exhibition kind of thing behind Hall B. Anybody interested in come over? The guru of this, Srinivas, is here, I am here, Nilu is here, Anjana ma'am is here. Anybody can show how his things are done. Then we have stabilometry. Stabilometry measures basically how stable a person is. This is not a measurement of anything to do with the eye or the vestibular system. This is more of a measurement of the proprioceptive system and the neurological system and its correlation with the other balance systems. And we have functional head impulse test, a test to determine the status of each individual semicircular canal. So here the advantage of functional head impulse test is it can individualize all 6 semicircular canals and plus also see whether other things like cognition and all has any effect on it. So in that sense it's even better than video head impulse test. So what are the observations? To bring out the observations, I'll come up with 4 cases that have somehow brings out how important each eye movement is. So the first patient is a lady of 45 years who developed sudden onset dizziness following a bout of fever and body ache for 7 days. Day 1 was very severe with bouts of vomiting, although intensity has subsided now. She has, because as he had received emergency treatment locally, she still feels very unsteady, especially on sudden movement. So this is a VOZ recording of her eye movements where we see, I'll show you the video, as you can see, we see right beating nystagmus, and once we do violent head shaking, you'll just see the head shaking. Yes, this is me shaking her head. So once the head shaking is done, you can see the intensity of the nystagmus has increased manifold. So this is basically telling us, since we can see a right beating nystagmus, the nystagmus bit is always opposite to the site of lesion. Anybody who attended the BPPV session that day, Dr. Srinivas had given very nice diagram. So basically this was diagnosed as a left vestibular failure. Now when you think of left vestibular failure, next what we did was we did an F-hit. And in F-hit, because we were able to isolate each semicircular canal, we found that in the left side, her left anterior and lateral canal were hypoactive, posterior canal was okay. So not only do we now understand that her left vestibular nerve is involved, we know now that her superior branch of the left vestibular nerve is involved and the inferior branch is intact. So this is how well we can localize. This patient also, we had put her on something called the escalating sensory denial test. So in escalating sensory denial, we try to test each sense that is responsible for balance. That is the vestibular system, the proprioceptive system, and the visual system. How we do that is we make the patient stand with eyes open on a stable surface. We record her stability. Then we make her eye closed, record her stability. Then we make her stand on a very soft cushion, eyes open, and finally eyes closed. So stepwise we are taking away one by one of her balance system. So in the first time when she is standing, she or he is standing on a balance platform with eyes open, all her systems are working. Her proprioceptum, the balance system, and her visual system are working. We make her close her eyes, the visual system is gone. So if she is still standing, that means her proprioceptive system and her vestibular system are working fine. Next we put her on a soft cushion. That means we take out the proprioceptive system. And once we take out the proprioceptive system and she is still standing, that means her visual system and her vestibular system is intact. Then we make her close her eyes. So not only her proprioceptive system, but her visual system is also gone. So she is only dependent on her visual system for balance, and if she still holds on, her visual system is okay. So escalating sensory denial takes care of each system one by one. So the patient was diagnosed as acute unilateral vestibulopathy or vestibular neuritis, left and treated with oral steroid, nootropics, and vestibular rehabilitation therapy with a very positive outcome. The next patient, this is an 85-year-old gentleman, diabetic and hypertensive, complained of unsteadiness for around 6 months, especially in darkness or on sudden change of position. And he also complains of hearing loss. He was on different forms of vestibular suppressants for long. And here what is important is he gives a history of unsteadiness, not of giddiness or vertigo. So we did a VOG. Here we found that her saccading and sput pursuit had gone wrong. So this person, what is saccadic? We just asked the patient to look at objects with his eyes, right, left, right, left. So if you come over there, we can show how that is done in the computerized study. So his both horizontal and vertical saccades, as you can see from the graph, are complete haywire. This was his smooth pursuit. Again, not confronting to the graph, completely haywire. Then we did what is a functional head impulse test, and we saw that all his 6 canals were not functioning. So this was a complete bilateral vestibular failure. When we do the stabilometry, his vestibular score was very low, 12, and we could see in his escalating sensory denial that every time he closed his eyes, especially when he was on the soft cushion, he just fell. People with vestibular loss, they will just sway around. People with unilateral vestibular loss will fall towards it. People with bilateral will not be able to, there is no definite side of fall, but they will not be able to hold still. So it was diagnosed as a bilateral vestibulopathy. He was put on vestibular rehabilitation therapy, and the most important point here, all form of anti-vertigo drugs were stopped. Bilateral vestibulopathy, we are not supposed to give any anti-vertigo drugs. He is on the path to recovery. We have started, he is on VRT for the last 2 months, and he's showing much improvement now. The third case, this is a 42-year-old lady who came with dizziness on and off for the last 4 years. Each episode sometimes lasted for a few minutes, sometimes it was for 2-3 days. She was bedridden. It was a very haphazard history. But early on in her life, in her school days, college going days, she used to have very severe headaches. But the headaches have somehow got little less now, but she has done multiple CT scans, MRIs and other investigations, ECGs and echocardiograms and all of them, there was nothing significant on those. This is her eye movement. You can see she has a downbeating nystagmus. We talked about it in yesterday's panel, and on head shaking, that particular downbeating nystagmus, if you observe, it actually increases. So this is called perverted nystagmus. What is perverted nystagmus is when we stimulate one plane and the nystagmus appears in another plane. So here we had stimulated the horizontal plane and the nystagmus increased in the vertical plane. So it is not because of something that is happening in the peripheral system. A horizontal canal cannot bring in a vertical nystagmus. So this is something that is happening in the central. We did the Unterberger's test under CCC. Why we did is if you see the first graph, that shows the displacement of the person. So when we are doing the Unterberger's test, the person, although did move around, was still under the normal V. So there was no displacement, abnormal displacement of the patient. But if you see the second below graph, the body axis, that means the whole body of the person was turning around. So what this tells us is that when there is no displacement, the displacement usually means that there is something wrong with the peripheral vestibular system, but his body axis deviation, that means the central command was not giving him with eyes closed, was not telling him his own center. So he was turning around. This is again seen in central causes. When we did an F hit, he showed both anterior canals hypoactivity. The anterior canal hypoactivity is the reason for his downbeating nystagmus. Now, why is there isolated anterior canal hypoactivity bilaterally? Because if there is a neural problem, then the lateral canal should also show problem, because it's the same nerve supply. This is actually isolated anterior canal hypoactivity in FHIT is actually seen in fatigue, what we call vestibular fatigue. And this is a problem not of the anatomy or the physiology, but of cognition. So what happens is, for testing the anterior canal, we have to make the person head go down as he is trying to read the FHIT graph, FHIT alphabet. And this needs a little more concentration than the other positions, and he was not able to do that. She was not able to do that. So there was a cognitive deficit. There are a number of papers which points to cognitive importance of cognition in vestibular migraine. So all this basically tells us this patient is our patient of vestibular migraine, and having put her on anti-migraine therapy, on the last follow-up she was improving by leaps and bounds. The next, this is my last case, and this is not one patient, this is two patients. Two very identical patients, both coming with sudden hearing loss on the left side, just 24 to 48 hours history. The only difference was patient B also complained of severe dizziness and vomiting. So both, this is the audiogram of the first patient, this is the audiogram of the second patient. It's almost like photostat copy. I was actually showing it to someone and they said, have you copy pasted the same audiogram? I said, no, there are subtle differences. So exactly the same, and yet one was having dizziness, the other was not. And we know in sudden SN loss, if it comes with dizziness, severe vertigo, the prognosis is usually not good. Now what we do is we do an FHIT on those patients, and you can see the FHIT of A and B side by side, whereas the FHIT of patient A, who does not have any dizziness, is perfectly normal. Those in patient B shows the left posterior canal to be completely hypoactive, explaining the severe dizziness. But what this also explains is the origin of the sudden SN loss. Whereas the first patient, the sudden SN loss was purely cochlear nerve, and as such can be attributed to a inflammatory cause. The second was a vestibulocochlear pathology and was most likely due to a vascular stroke, a posterior circulation stroke. So in these patients, whereas the first patient will react very well to steroids, whether orally or intratympanic, the second patient, not only will that patient not respond to steroid, but that patient needs follow-up, because the chances of that patient later on developing, going into a cerebral stroke, full-blown stroke, or some other cardiological event is very high. So sudden sensory hearing loss as such is not a vestibular disease. But even in those patients nowadays, as a protocol, it's always better to do an FHIT so that we can actually think of the future. And if there's any FHIT problem, that patient needs, apart from whatever drugs we give, needs a proper cardiological and a neurological evaluation. So with these 4 studies, what I want to put out is that the correlation between the anomalous eye movement and the status of the vestibular system is direct, and what we can do is with this test not only find out the cause but also find out where, how the disease is, and as the last patient shows, actually guide us in the treatment protocol also. So now coming to my journey in neurotology, I passed out my post-graduation in 2006 and started looking after the vertigo clinic in Nightingale Hospital from 1st of March 2007. From then on till now I have had the opportunity to do a lot of tests, but it's not the test, it's the patients that I have seen over the ages. And what I have learned from each patient is individual, each patient is different, each patient has its own. So we need to take care of each patient on its merit. We need to be very careful with each patient, give due respect, and never club any patient into a particular strategy. So like today Nilutpal was talking, some people have this strategy of going for packages in vestibular investigations, Meniere's disease package, these packages. My question is, how can we have packages for investigation? When a patient comes to me with vertigo, if I already know that this is Meniere's disease, why do I investigate? Ask him to spend 30,000, 20,000 for that. And if I do not know and I need the help of this diagnosis, why then do I club them into packages? So what we need to do is look at the eye movement and then decide which investigation is going to help us in diagnosis. Because ultimately in any disease, and especially sure in my kind of problem, it's the history that will guide us. It's the clinical findings that will guide us. Investigations are only there to prod us on the road. Investigations are the GPS. It is the history that is the vehicle. It is the clinical examination that is the steering wheel. So anybody who is dependent on only the GPS and does not know how to drive will not go nowhere. And the other way, anybody who can drive a car can go somewhere, but at the end of it, you do need the GPS nowadays to reach where you want to go. So to conclude, vestibular investigations have come a long way. Since 2007, numerous patients have undergone different vestibular investigation, giving a glimpse in each case to the spectacular functioning of the sixth sense. With such variety in investigation and each with its own individuality, it is important to understand the nuances of each test and tailor them to our needs. The investigation should be our slave and not the other way around. Vestibulometry as a science has grown by leaps and bounds, and you need to ride along for this journey, but with caution. With this, I'd like to say that especially to, if we have postgraduates and new pass-outs here, neuro-otology is a beautiful science. Just like, say, cochlear implant, just like head and neck, just like allergy, just like rhinology. ENT is huge field. It's a medical science with the maximum number of avenues to go forward. But what happens is once we pass out, and this happened with every one of us, if we think of going into neuro-otology, we are very much afraid because we see a lot of things and we understand none. It's like we are facing a myriads of doors. Every door, either unopened or even if opened, is in such a way that we do not understand anything. And instead of treating vertigo, we end up having vertigo ourselves. And it is in these situations where we need mentors, where we need people to guide us. And I was lucky to have 3 very strong people with me. Initially, Dr. Gautam Khand, he's been my rock. I was lucky to have learned with Dr. Anirban Biswas sir, and now Dr. Srinivas Dorasala. So much so that, if you can look at this photo, I don't have a mustache, he has it, and today he doesn't have one and I have it. We have become so interdependent that we have even stealing each other's facial features. So when you have mentors like this, then closed doors simply becomes open and give us a beautiful view. With this, I'd like to thank each one of you. Thank you very much. Yeah, I managed to finish in time.
Thank you, Surajit. Just say, what to say, very wonderful talk, and I am very thankful to you.
Thank you.
So this is another era, to say. It is not, you have make us that not only cholesteatoma or allergy, that vertigo and tinnitus is another thing which ENT surgeon, ENT has to look after. Yes. And I am sure that every delegate here enjoy, and I hope we will practice. And the vertigo, same thing we are facing. Many times that treatment was not satisfied, investigation was not satisfied, and they come, many of patients come again and again and discuss with us. And I request all the delegates here, those who have seen the vertigo clinic, it is behind the stall, no?
Yes, no,
Yeah.
behind the stall, just behind hall B.
Yeah.
If you go through Hall B, you can directly go there, or behind the Signova sofa and all those, just that.
Please
So
have a look. And any question from the audience? Any question? Is a
Oration, we do not give any.
sorry. There
no,
is
it's okay.
oration.
I will take care of any queries once I get down. I'm open to it, and I'm not worried, because if I'm not able to answer something, Srinivas sir is here, Anjana ma'am is here. Two persons who I know knows much more than me, they'll take care of it.
SN Sharma Memorial Award has been given by Nalbari branch of NEBAO. So I request the members of the Nalbari branch to come over to the dais to come over to the felicitation corner for felicitation. Dr. Surajit,
just 2 minutes. SN Sharma Memorial Award is given by Nalbari branch. I was born in Nalbari. I went through SN Sharma sir's life history. He was born in Mazirgaon, which is near Guwahati Airport. Studied in a school called RB school, and my wife's uncle just retired as the vice principal of that school. So somehow got related to both. Thank you.
Dr. Surajit, will you please come down to the felicitation corner? Yeah, Japi to Pinda. I call upon Dr. P.M. Bujar Barua to felicitate our chairpersons.
The chairpersons for our next talk session will be Dr. Biplab Nath, Dr. Y.R. Lotha, Dr. Naseem Ahmed Soikia. Please take your chairs. Our first speaker is Dr. A.K. Biswas, and he will give the talk on basics in audiometry. There's an important announcement. PGTs who want to participate in the quiz competition can contact either Dr. Rinku Ghosh Rehman or Dr. Anupam Hazarika.
Good afternoon. I'm really thankful to NEBAI that I have been given this platform to talk on basics of audiology. Although it is written that basics in audiometry, but what I say it's basics in audiology. So it should be basics in audiology. So we must take this as an audiology, not as an audiometry.
Biswas sir, 1 second. Biswas sir, here. So, good afternoon everyone. In this session we are going to have 9 presentations, and most of the members are very well known consultant in their own fields. And we have in the first presentation, we have presentation by Dr. A.K. Biswas. He is a very renowned audiologist in Northeastern region. So we'd like to invite Biswas sir, Dr. A.K. Biswas sir, to kindly go ahead with your presentation.
Thank you, sir. Thank you, sir. So when we say basics in audiology, we always think that it should start with pure tone audiometry. But thing is that audiology does not start with pure tone audiometry. It starts with different. So first thing, when a patient comes, we must have good otoscopy. When I was teaching in Guwahati Medical College, I used to tell my students that don't send a patient for audiometry. First do a otoscopy, clean the ear if there is a wax, if there is a profuse effusion, clean it, then only you send for audiometry. So basic in audiology when a patient is referred is otoscopy. So you must have a good otoscopy. If there is a wax, if there is a effusion, if there is a profuse effusion, you clean it, then only you send the patient. Then only you will be able to get a good results. So this is the otoscopy that is done for the adult, which I don't need to describe. All ENT surgeons, they all know it. So this is again for the children, how it is done. Next, when a patient comes to me, once I have otoscopic examination, I go for tuning fork test. So this is the basic things we need to have, tuning fork test. So what is in RENE? It is AC is better than BC. Why AC is better than BC? Because it's due to better impedance matching and amplification of sound passes from middle ear to the cochlea. Now if we don't have middle ear, what would have been happen? We should have a loss of around 31.1 dB, because if a airborne sound hits in the cochlea in the liquid point, that it will be a impedance mismatch, and if there is a impedance mismatch, the total loss comes is 31.1 dB. Now what happens to the middle ear? Middle ear acts as an amplifier. It acts as an amplifier, and it gives us around 22.1 dB gain. That is tympanic membrane, umbo, and your ossicular chain, it gives you around 21.1 dB gain, and 10 dB is lost forever. Okay, so this is the impedance matching that is done, and AC is better than BC because of the better impedance matching and amplification of sound passes from the middle ear to the cochlea. Now what happened in audiogram? You see that BC is better than AC. Either it is equal or it is better in audiogram. When you look at the audiogram, this is different. Now why it happens like this? This is because the instrument is calibrated according to that. So pure tone audiometer is calibrated like that. So you have BC is either equal or better than AC. Now what happened in Weber test? Weber test, if it is normal, it is in the midline. If it is in the sensorineural hearing loss, it is in the normal ear. If it is in the conductive hearing loss, then you have it in the affected ear. Now, why it is in the better ear? This is basically due to the Stenger effect. So what is the Stenger effect? If you give sound to the two ear, the louder sound is heard better than the other. So this is the Stenger effect, and this positive Rene or better Rene is due to the Stenger effect. Now what about the conductive hearing loss? What happened to the conductive hearing loss? In conductive hearing loss, we know that it is in the affected site. That is, goes to the affected site. So this is basically due to the occlusion effect plus Stenger effect. Occlusion effect generally increases sound in the occlusion effect that increases sound pressure level. That is, sound pressure level is increased, and Stenger effect, both effect together it will pass to the middle ear. Now this is the graph that is showing that at different level of entrance, if you put occlusion, how much the loss will be. So it is seen that lower frequencies has the maximum occlusion effect. Lower frequencies has the maximum occlusion effect. So that's why, you know, either a 250 hertz, 256 hertz, 512 hertz or 1024 hertz are considered, because you get a better response towards the lower frequency than in the higher frequencies. Once I have completed my otoscopic examination and tuning fork test, I have a good idea about the patient, what can be the patient, because I have the history also. So once I complete my test, I have a basic idea that what I have to do. Then comes the Puritan audiometry. Puritan audiometry, as all of we are aware, this is a measurement to measure the auditory threshold of an individual, and threshold is important. That is minimum level at which an individual can hear sound. Now there are some protocols has to be maintained, and among all the protocols, the most important is soundproof room. Now what I understand by soundproof room? Soundproof room, I don't understand it's an anechoic chamber. Anechoic chamber means there is no noise. It doesn't need a anechoic chamber. But limited level of sound is allowed. Okay. It is said that at 1000 hertz, a 30.1 dB SPL sound is allowed to test a Puritan audiometry. If it is beyond that, then it's a problem. But in a normal condition, 30.5 dB SPL, sound pressure level, not hearing level, sound pressure level is allowed in Puritan audiometry, in a sound treated room. So these are the protocols has to be maintained during the test. Then next comes, once you have tested air conduction, bone conduction, I put in a graph, you have degree of hearing loss. There are many classifications that has been given, and best classification that we observe is Goodman's classification, where 25 dB is considered as normal, 26 to 40 is mild, 41 to 55 is moderate, 56 to 70 is moderately severe, then you have severe and profound hearing loss. In last week, there was a classification. In a group, there was a classification coming. Okay, that was the classification that has been posted by Marshall, that is Dr. S.B. Fukansa. He was giving a classification of American Association of Hearing Surgeon. So he was giving class A, class B, class C and class D classification, and he said that then there is 0, 1, 2, 3, 4 classification, and he was telling that there was serviceable hearing loss and the non-serviceable hearing loss. So that classification has been posted basically for your neurosurgical purpose. So when there is a neurosurgical surgery is done, that classification follows, but not for the day-to-day audiometric presentation. Now you can compare your audiogram. You can have a flat type audiogram, you have a gradually falling audiogram, you have a sharply falling audiogram, you can have a precipitous falling audiogram, you can have a rising audiogram, and you can have a peaked or saucer type audiogram, you can have a trough audiogram, or you can have a notched audiogram. Now, if you want to see the different types in a graphical presentation, I have prepared a manual and I have posted in today's hands-on group that it's a manual of audiology. It's in the group. If anybody is interested, they can take the manual. It's in the soft copy form that is available in the audiology group, today hands-on audiology group. So that manual can give you good ideas about the different pattern of audiogram. Now, if you look at this graph is saying frequency and intensity. Frequency is in the x-axis and intensity in the y-axis. It is seen that mid frequencies has better sensitivity in human being than in the low frequencies and the high frequencies. So in mid frequencies we need less energy, but in the low and high frequencies we need more energy. Now why it happens like this? Why it is happening like this? So there is two explanation has been given for that. One explanation is that we are born to hear speech, and once we born we start hearing speech and all. Our neural systems are tonotypically organized in such a way that low frequencies gets better tuned than the higher frequencies. So they are tonotypically organized in the brain, or the neurons are organized in the temporal region. So they are more responsive because we are born to hear speech. So speech is more sensitive than the other frequency. But if you try to speak, explain in terms of acoustics and physiology, it's different. Now what is in acoustics and physiology? It says ear canal resonance is around 2000 to 4000 hertz, and medullary resonance frequency is 8800 to 1200 hertz. That's why it's basically, they have said 8800 to 1200 medullary frequency, but it is exactly 1631 hertz. Medullary resonance frequency is 1631 hertz. That's why in otosclerosis you get notch. Why do you get a notch? Because medullary resonance is lost. Medullary resonance is lost, and it is 1631 hertz resonance capacity, and once the resonance capacity is lost, you get a notch because it needs more energy. So you have a notch at 1600, 2000. It starts at 1000 hertz, maximum 2000 hertz, then it goes up. Now if you look at this graph, you see the ear resonance. So you have, this is number one is your spherical head, resonance. You have number two is your torso and neck resonance. You have number three is your concha resonance. Then you have pinna flange resonance, and you have ear canal and eardrum resonance. And overall resonance is around 17 dB, and it is mostly seen at the 2700 hertz. So maximum resonance is at 2700 hertz. Now, how the velocity of sounds takes place in the tympanic membrane? If you look at this velocity of sound, that is peaked at 2000 to 3000 hertz. So there is an increase came 3 kilohertz to 4 kilohertz. Now, if there is this is a graph showing if there is a medullary effusion, what will happen? Medullary effusion, this velocity will reduce and you get a flat curve. You get a flat curve in medullary resonance. Now, in different ossicular chain discontinuity, how it happens? In an intact chain, gain is very good, but as you have malleus head fixation, stapes fixation, incudus stapedial joint interruption, and incus removal, the intensity or the graft pattern will keep on changing, and the highest loss is seen in incus removal. This is the different types of audiogram that is seen. That is, I need not explain. This is, one is conductive, one is SN and mixed hearing loss. Now, effects on audiogram. So you have if there is an increase in stiffness, what will happen? The low frequency transmission will be affected, and you will get a rising audiogram. And this is mainly seen in if there is a stiffness of the ossicular chain or stapedous, your autosclerosis and anything that is causing stiffness, you get a rising audiogram. Now, if there is a mass that is medullary effusion, you get a sloping audiogram. That is, more loss is seen towards the higher frequencies.
Mr. Speaker, sir, your allotted time is over. You may kindly.
Over? Okay. And this is a graph that is showing your if there is a medullary effusion, if there is ASM, CSM, you have a flat type of audiogram. Now this is a peaked audiogram that is seen, that is high frequency and mid frequencies affected, and low frequencies is better, and this is a auditory neuropathy spectrum disorder, and this is basically the neurons that are affected. You have different type of neurons. You have black is your basal neurons, green is your mid-brain neurons, and apical neurons, and it is said that higher and lower frequencies are maybe more affected by degeneration due to their increase in length than the mid neurons. Shall I stop?
Yeah, because.
Okay. Thank you.
Thank you. Our next presenter will be Dr. Nilopal Tata. The topic will be rules of central vertigo. You may kindly take the time.
With due permission from the chairperson, actually Biswas sir has another session in the hall number 2. We want to felicitate Biswas sir so that he can move to that hall. I request the organizing. I request one of the chairperson please felicitate Biswas sir.
There is another announcement. Anybody who wants logistic support to banquet tonight can contact Bipul Sharma, 600-216-8611. I repeat, anybody who wants logistic support to banquet tonight can contact Bipul Sharma. His contact number is 600-216-8611.
All the speakers are requested to respect the time. The time allotted will be 13 minutes. And the questions and answers will be after completion of all the presentation.
Move it to that. वो वाला लैपटॉप पे ट्राई करें. लैपटॉप नहीं, लैपटॉप पे तो Audio nahi? Thank you. Shall I start? Thank you. Good afternoon, everyone. First of all, I would like to thank the Sipsagar team of NEBAOI, especially Anjana ma'am, to invite me here today. And I have my roots back from Dibrugarh. I passed both my undergraduation and post-graduation from Assam Medical College, Dibrugarh. And it's privileged to come back to my own native place and speak in front of my mentor and HOD, Professor U.T. Bhuiya sir, under whom I passed my postgraduate exams back then, and my mentors here, Surajit Da and Srinivas sir. So the topic here for me today is rules of central vertigo. Now, why it has been important? Now, for the last 50 years, we have been discussing about how to differentiate between central and peripheral vestibular disorders. Then, around a few years back, we had all those cerebellar signs. We used to do Romberg test, this Unterberger stepping, pass pointing, all these tests we have focused on. Then, last 3-4 years, we are much interested towards the cerebellum. We are discussing about which is the floccular lesions, which are the nodular lesions, vermis lesions, all these things. So today, my purpose of this presentation is to carry you through a journey where I will be discussing right from the cortex, basal ganglia, thalamus, limbic system, brainstem, cerebellum, how in a busy ENT clinic you can have some glitches and some presentations and some history which will help us to at least not quote it as a central vestibular lesion rather than giving it a floccular lesion or nodular lesion or a cortical lesion and send back to a colleague like neurology or neurosurgeon so that it gives much more evidence to your subject what you are practicing. Coming on to the introduction is basically what central vertigo is: a dysfunction in the central vestibular system and its connections, which is basically in the brainstem, cerebellum and higher cortical centers. Importance of the central vestibular system is again along with the peripheral system is the maintenance of balance and spatial orientation. Now, any central vestibular disorders, there are 3 presentations which a patient may come to you in the OPD. One is an acute presentation. It could be a stroke. It could be an anterior cerebral artery stroke or posterior cerebral artery stroke or cerebellar stroke. Chronic vestibular syndromes are something around long-term functional dizziness, orthostatic hypotension, all this could be there. And episodic central vestibular syndromes will be something of more of a vestibular migraine, episodic ataxia type 2. So all these presentations are there. Now coming on to the structural and functional anatomy, we all know that the balance system is mainly maintained with the vestibular, visual and the somatosensory system, but it's the central integration which takes place in the higher parts like in the cortex, thalamus, all these areas allow us to maintain that state of spatial orientation. Now these central vestibular structures are divided into 2 parts, it's the supratentorial and the infratentorial. The supratentorial are basically the cortex, thalamus and the limbic system, and the infratentorial are the brainstem and the cerebellum. Now supratentorial, we'll be discussing first of the cortex. Now what are the cortical theories? Now the vestibular cortex, if you go through the David and Z and all other publications which comes up from the vestibular medicine, it's basically diffuse network, and a lot of the areas like interparietal circus, central circus, parieto-insular cortex, all these areas are there, but the primary vestibular cortex is actually this area. This is the parietal opercular area called the OP2 area. Now this is a functional MRI of a patient. Now there are a lot of patients, mainly the vestibular patients complaining of vertigo and visual auras, scintillating scotomas, auditory hallucinations. There are a lot of patients. In these patients there were studies which showed that and the functional areas, when it was done, then there was an increase in the hypersensitivity of the functional areas which could be seen in the cortical part. Next is the thalamus. Awareness of the motion. Any vestibular disorder patients, any vertigo patients, if there is a sense of awareness of the motion, then there is a high susceptibility, is having a thalamic stroke or thalamic lesion. Now, in thalamus, there are 2 things which are important. One is the photosensitivity and is the photophobia and the phonophobia. This occurs due to a phenomenon called the converse amplification. Converse amplification is basically the cranial nerve nuclei, that is the fifth cranial nerve, which interact, and the dura-sensitive neurons get enlarged, and it helps. So these are those patients who will come to you with vertigo and will tell that we have a sudden motion intolerance. Whenever they are moving their head in the motion, they will have that motion intolerance without mainly migraine pain. These actually are the basis of the syndromes like Alice in Wonderland syndrome. The most commonly diagnosed now is the triple PD, persistent perceptual postural dizziness, where the patient is, something is happening. I'm walking in a, or rocking sensation or walking in a foam. So he's not aware of that. Basal ganglia are balance disorder patients. Basically, it's affected with the motor control and the Parkinson's disease. Now, hippocampus and entorhinal cortex in the higher part is basically for the path finding. Now, I had a patient, I remember, which I discussed with my neurologist, who came to me with a primary balance disorder, but he could not remember the way back to his home when he was in the market. Suddenly he forgot where was the way around. So these are actually areas where there is any minute lesion in the hippocampus, you will be having affecting the spatial memory, directionally of the memory, and they are also responsible for Alzheimer's disease. Now, this is a new drug which has come to the market, working pretty well till now. It's a sterosilbine, what we give 100 milligram twice a day for at least 2-3 months in these patients diagnosed with hippocampal lesions. Now, this is another called autolytic. As we all know, in the vestibular medicine, we will be practicing this autolytes, we will be testing autolytes. Now, autolytic, they say utricles and sacrals, they basically have central connections also. Now, any dysfunction of the autolytes can lead to a tilting sensation, veering sensation, constant swaying sensation, rocking sensation. These things are there. This is a specific one of my patients complain. Whenever he goes to sleep or stand, suddenly he feels that the entire room is tilting. So this is basically occurs due to a room tilt elision phenomenon, which occurs due to environmental visual spatial perception mismatch. Now this can be tested with a skew deviation test, and the lesions are usually in the insular cortex areas. Now with this we finish the supratentorial part. Now infratentorial, there are two lesions. One will be the brainstem and the cerebellum, which you all must be speaking in a lot of conferences. Now the vestibular nuclei, out of which the most common is the vestibular, medial vestibular nuclei, which is responsible for the gaze-evoked nystagmus, which is most of the cases. I'm not going into much details about that due to limitation of the time. Now these are some of the cerebellar vertigo syndromes, very important for clinical perspectives. Now, how to differentiate it? Now, as you know, the cerebellum has other areas like vermis, you will have nodulars, you have this floccular lesions. Now, vermis and vestigial nucleus, these are some of the areas where if there is a cerebellar stroke affecting this, we will be having hypometria and hypermetria. Now, if anyone wants to see what's hypometria and hypermetria, we have a stall with the VOG stall next to the hall B, where we are showing the typical graphs, how we can clinically know. Even if it's quite a bit difficult when you're doing in a, without VNG normal clinical examination, but VNG we have specific set values where we can find easily by the SACAD and the SACAD test, where you can get this hypometria, hypermetria. So vermis and vestigial lesions, if you are getting a hypometria during the VNG test, gives a high suspicion that it could be a cerebellar lesion affecting the vermis and the vestigial nuclei. Next come on the flocculus and the paraflocculus lesion, very common. We discussed about the downbeat nystagmus patients, where very commonly it's affected in the floccular lesions, along with, as Surajita was saying, that impaired smooth pursuit test, impaired viewer cancellation, and gaze evoke nystagmus. I'll be showing one case if I have time. So how this simple MRI, which was not done by the clinicians, did a VNG, got a bit doubt about this, and then again revisited with a contrast MRI how we could diagnose it. Next is the nodular and uvular lesion, the central positional nystagmus. We've been talking in a lot of forums like the migraine causing a CPN, central positional nystagmus. The tilt translational mismatch is the autolytic, again, connections with the central vestibular systems which help us to diagnose it. Perverted post-head-shaking nystagmus will be something you will be shaking the head, horizontal head shaking, but you will be getting a tuck, 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 vertical nystagmus. This is a perverted nystagmus. Impaired habituation to repeated stimuli. Remember, BPPV, refractory BPPV. Every day, 2-3 days, the patients are coming, doing the perfectly, you are doing the maneuver, is not being cured. Perfectly doing the maneuver, not being cured. These are always, remember, to go for an MRI if at least 2-3 times the patient is not cured by your maneuvers, provided the maneuvers are thoroughly done. Next is the cerebellar vertigo stroke syndromes, where basically we'll be discussing on the importance of the superior cerebellar artery, anterior inferior cerebellar artery, and posterior inferior cerebellar artery, how simple history and clinical clue can give a diagnosis of it. First is the superior cerebellar artery stroke, where is acute short-lasting vertigo. Patient will be coming similar to a case of viral gastroenteritis. I remember a resident calling me at night around 2 a.m. Sir, there's a severe patient saying vertigo, severe vomiting. We have done the endoscopy also, emergency, everything done. Then we had a discussion. I shared the case with Srinivas sir, if he remembers, that this was a pseudo gastroenteritis patient. Then when you reevaluated the patient, it actually came out to be a superior cerebellar artery stroke. So any severe gastritis, severe vomiting patient, along with some imbalance and severe attacks, intoxication state, always go for an MRI. Anterior inferior cerebellar artery stroke, which yesterday we discussed in the panel, is basically a pseudo-labyrinthine stroke. So it's basically similar symptoms like we have in a cochleovestibular failure. We'll be having acute vertigo, auditory symptoms. This occurs basically during the lateral pontine part is affected along with the floccular lesions. How to identify is with the gaze evoke nystagmus will be there, downbeat nystagmus will be there, impaired smooth pursuit, which very easily can be found out by the VOG, and now with the more advanced COG system, which we had a glimpse yesterday. So this also should be confused. Yesterday what we were discussing in the panel, how whosoever was there, that we should always give severe ataxic patients, we should always go for an MRI. Always, we should not miss it. Even if the CT comes out to be normal, we should always provoke that to do for an MRI. Next is the pseudo-vestibular neuronitis, similar to the ICA. There is a pica stroke also. This is a posterior inferior cerebellar artery stroke, where we have the acute vertigo along with lateral medullary syndromes, which is basically the nodular sparing and nodulus involving lesions, where basically ocular torsion, this can be found out by the skew deviation tests and ocular torsions. Next, I'll not be going much into that. The lateral medullary syndrome is basically, everyone knows it, is a Wallenberg syndrome, where the spinothalamic tracts are basically been affected. So there is a hemifacial analgesia to one side, gag reflex, palatal palsy will be getting, and contralateral will be having loss of pain, touch, and temperature. Simple bedside test, simple some history, and clinical examination can highly give you a diagnosis of this. Next is the Millard-Gublach syndrome, is the pons part, the left part of the brainstem. Structures is basically the cortical spinal tracts are involved, so more of the motor hemiparesis in the contralateral side, and ipsilateral will be facial nerve palsies. Lateral midbrain syndrome is a higher part, that the third and fourth nerve palsy will be there, so there will be hemifacial loss, Horner syndromes, mainly affecting the red nucleus, so you'll be having tremor, decrease in arm swing problems. All these things, if are there with the acute vertigo, then there is a high suspicion that there can be a higher central lesion resulting in. Now, how to identify this, the brainstem lesions, is another part of a discussion, is the 222 test, what Srinivas yesterday was telling, where we test the cold and touch temperature, measuring both our face and the hands, and also the vibration sense. We can easily test it. I'll just take 2 minutes. So I'll just, before ending, I'll just discuss couple of interesting cases. This is a 65-year-old man, acute onset of head spinning lasting for 2 days without any CNS and ear symptoms, currently having severe ataxic gait. Neurologist seen it, no CNS symptoms were there. CT scan was normal, neurologist has sent back to me in the neuro-otology clinic. When I did a VNG there, I could see a small bits, if you can see there with the typical graph. These are the downbeats, these are the downbeat nystagmus graph, these are the downbeats typically seen in the vertical part of the VOG system. I requested the patient family members to at least go for a contrast enhanced MRI, and we did the MRI in our hospital. We have a radiology colleague which have started a MRI vertigo panel, where we basically teach the CIS and the Fiesta sequence. It was a large cerebellar stroke, and as the nodulars, floccular lesions and parafloccular parts were affected, the patient was diagnosed with, just came to it with the downbeat nystagmus, where we added baclofen, clonazepam, and delphenparidine, which gave a very good results. Case 2 is a 32-year-old female. Typical features of migraine, headaches, photophobia, phonophobia, tingling, numbness, left side facial, occasional double vision, and occasional gaze evoke nystagmus. MRI was done around 1.5 2 years back, neurologist repeated vestibular migraine treatments failed. During the VNG test, again typical gaze evoke nystagmus during saccade smooth pursuit gaze test. Provoked me to do again a repeat MRI with a vertigo panel, came out to be a left CP angle tumor, was affecting again the cerebellar part. So lastly, these are very important golden rules of central vestibular structures. If any vertigo patients comes to you with visual auditory areas, cortical centers must be affected. If it's a motion intolerance, photophobia, phonophobia, there will be more of a thalamic lesions. Loss of spatial memory affected is be hippocampal lesions. Room tilt lesion, you'll be once in a year, 3-4 years, you'll be getting patients with room tilt illusions. It will be central autolytic pathways, floccular, parafloccular lesions, downbeat nystagmus, anything. Key to it is the floccular lesions, perverted nystagmus, CPN, prolonged vestibular reflexes, recurrent BPPV not being cured with the maneuvers, will be most nodulous uvular lesions, hypermetria, pulsions, eye pulsions, which are we saw yesterday. Pulsions were basically in the fastigial nucleus and vermin lesions, pseudo-labyrinthitis, ICA, pseudo-vestibular neuritis is the pica stroke, and pseudo-intoxication features like the superior cerebral artery. So this chart, if we can have some idea of it, we will dare to miss any central vestibular structures, hopefully in our busy clinic, and send back to our neurology colleagues saying that possibly this is a vermin lesion. Please see and please do the MRI and treat it accordingly. Thank you very much for the patient sharing.
Thank you, Dr. Nilpal, for such a wonderful presentation. Vertigo, in fact, is a very difficult subject, and you tried to simplify it. And I must congratulate you for taking such a difficult subject. And thank you for the nice presentation. Our next presentation will be from Dr. Anjali Purva ma'am. Topic will be CCG as a tool for diagnosis and assessment of treatment outcome in vertiginous patients.
We are going to start the ASLP session in hall number 2. The speakers are requested to be there in the hall number 2, and anyone interested, please attend that session.
Meanwhile, I request rest of the presenters to kindly hand over their presentation to the preview person so that they can fix it beforehand, and we can save time.
Good afternoon, everyone. I'm sorry I'm a bit late in presenting my paper. So I am presenting a paper on CCG, A2 for diagnosis and treatment plan in vertiginous syndrome. I am a new entrant to the vertigo family, and this tool is very newly introduced in our hospital. So I am very new to the whole tool, I mean, examination part also. Then about the definition, CCG is a qualitative and quantitative neuro-otological test for assessing vestibular disorders and to investigate for a probable diagnosis as well as to get some treatment plan for programming the treatment plan. It's a very good tool for a quantitative, already I have said, and qualitative neurological test. So, brief history, about a brief history, the basic concept of vertigo and tinnitus and diploma in 1977 to 1982, Clausen, he studied about 30,000 neuro-otological patients, and the concept of equilibrometry and CCG was developed by him only, and later on he developed the whole CCG, then where he incorporated a light sensor along with the instant photographic camera, and he was the main person behind this CCG tool. Then about the anatomy and connection of vestibular nucleus, and that I'm not going to tell in details, but we all know the vestibular nuclei, the information goes to the vestibular nuclei from the motion sensors that are present in semicircular canal and utricle and sacule. And from the vestibular nuclei, information also goes to the oculomotor trochlear and abducens nerve through the medial longitudinal fasciculus. And this vestibular nuclei also, they have connection to the cerebellum, or central connections are for individual central connections are also there. Some also fibers go to the spinal cord through the medial and lateral spinothalamic tract. So this is about, I have already told, there's a medial and lateral spinothalamic tract in the medulla that we have seen here. And next slide. That now we are not going to tell you about the vestibular ocular reflex. So many persons have already told about the vestibular ocular reflex, and we use the vestibular spinal reflex in CCG tool. And these are the equipments or devices used in CCB test. The first slide, first picture is the camera above, and this is the headband with light sensors, and below this is the computer system for recording. Then test for assessment by CCG examination, we do the Unterberger test to identify the directional deviation and sway during stepping test. Tandem walking test, that for dynamic balance and coordination, and Romberg test we do to see the static balance with eyes closed. Next. Test for CCG functions, already I have described. Next slide, please. Next slide. Then Unterberger test. This Unterberger test is done. Patient stands upright, extends their arms in front and marches in place for 50. They take the 50 steps and take them step marching, and but they in such a way that the thigh should make an angle of 90 degrees. But before doing all these tests, patient must know the utility of the test, or also be careful, because by doing this test, the patient may fall down also. So marches, he or she has to marches in place, steps marches, he has to take 50 steps with eyes closed. And if it is positive, then he may show some deviation from the original position, either to the right or left, or sometimes he or she may even fall. Next. Tandem walking test, the patient is first asked to take 4 to 5 steps, heel to toe, without space between the steps, to get some idea of movement, and then take 10 steps with eyes open, and arrow was defined as taking a side step, leaving a space of 2 centimeters from the other feet while taking the steps, tandem steps with eyes open. This stage will assess the time taken to complete the task. Number of missed tests also we have to find out, and they give some information about the performance deficits, but not diagnosis. When it is not possible to assess visually or clinically accurately dynamic balance, then by addition of other measures are incorporated into it, if it is possible. Next. So the test, this test results are graded on a scale of 0 to 4. Grade 0, impossible to walk. Grade 1, less than or equal to 3 steps needs cane or assistance on a flat surface. Then grade 2, less than 10 steps, needs assistance on stairs. Grade 3, 10 steps but unstable to swaying from side to side, walks unaided but slowly, 10 steps is normal. A tendon test is positive when the patient falls in 2 attempts to take 10 steps, normally with eyes open. This is a Romberg test. It's a tool for assessing balance. It is a test for visual, vestibular, and proprioceptive senses. The patient is asked to stay on a flat surface with feet together and with cross arms in front of the body or placed on sides of the body. Stay in the position for 30 seconds or 60 seconds with eyes open, and followed by holding the same position for either 30 seconds or 60 seconds. First with eyes open and then with eyes closed without any support by the assistant. While doing this stay, we have to be very careful so that patient does not fall. So Romberg is positive when there is sway or fall, inability to maintain an erect posture over 60 seconds. Because of high specificity, a positive test is highly sensitive to diagnosing a deficit involving dorsal column and medial lemniscus, pathways of the spinal cords, even with eyes closed or eyes open. A positive test with a sway in all directions is probably due to loss of proprioceptive senses, but in vestibular dysfunctions, we do not get so much of sway, and sway is only towards the side of the lesion. These are the methods actually very new, tool which we have introduced in a hospital. Only 20 patients we have examined. Total number of patients were at 18, age 41 to 19 years old, and sex, female were 8 genders, female were 8 and males were 10 only. Then this is gender distribution we have shown in the bar diagram. There is distribution again in 41 to 60 years old, 13 cases we have examined, and 81 to 100 even we got 2 cases, 61 to 83 cases. Then results of positive and normal CCG finding. We have seen that VP, right and left, both. We got 6 cases in vestibular migraine, 5 cases, vestibular migraine with vestibulopathy with migraine, 2 cases, and vestibulopathy with inadequate central compensation in 1 case. So this is the results of observation which we get in our CCG tool. This is the first one is the Unterberger test. Second is the tandem. Third is the Romberg. Next. So we have seen the deviation from the outside. The green square is within the normal limit, but there is rightward angulation, deviation towards the right side. That is not normal. And this Unterberg, this one, second was tandem was normal, and Romberg was normal. This way we get the findings. And this is another test, but it is within normal limits. Next. This another test, normal. And so there are so many variables in the CCG test, but I have not purposely, I have not included in the CCG test all the variables. It is not possible for me because we have to investigate the case also accordingly, according the cause of the disease also, the nature of the disease also we can investigate, and only doing this, all 3 tests only will not do anything. So to get a proper way of proper research paper, we have included all the parameters of all the diseases, also the CCG test, these parameters which we got. Discussion in utility of CCG test. CCG test is an investigative tool which it can be utilized to diagnose a peripheral lesion, also diagnose the peripheral lesion, and also give some clues to differentiate a central lesion to some extent. But we cannot say that it is a diagnosis of this case. It is peripheral or central. That we cannot say like that in doing a CCG test. But we can get some idea that it is peripheral. It may be a peripheral lesion, or it is a central lesion. It hardly takes very few minutes to perform. once it is installed. It aids in effective treatment planning, and that can be also customized. It's a good tool for monitoring the process of the progress of the patients in vestibular rehabilitation therapy, and can be done as per the protocol laid down by us. So I'm very thankful to my sir who has provided me this, Dr. Srinivas sir has provided me this important tool to investigate the cases of vertigo. I'm thankful to him. Also, my sincere thanks to Nemke Hospital for procuring CCG on my request. Also to other doctors concerned, neurologists, they are physicians, they all helping me. Also to one person, he's an assistant manager, IT, Dr. Dibbajyoti Chaudhary, and it's Philarina Hospital for his help for completing my project. So these references, I have few references. I have not much studied. I'm thinking of study more on this CCG tool. So with this, I thank you all for your patience.
Thank you, madam.
Hearing.
That was a wonderful
Thank you
presentation.
so much.
And it is such an important tool, and you have talked on such an important topic. Thank you so much, ma'am. As per the suggestion of the organizing committee, the answer and question answer sessions can be, can be done at this end of the session only. So requesting the next presenter, Dr. S.N. Mukherjee sir, to kindly come up and deliver your presentation on role of curcumin in ENT patients.
আচ্ছা আচ্ছা এটাতে এন্টার করলে respected chairperson as well as my dear friend, my subject is altogether different because I wanted to do the effect of the curcumin in our ENT problems because curcumin is quite available in the market, maybe in the name of Cupivell or Carcosel, like that, and it helps in our ENT problems. Now, I think I will be discussing on the subjects. First of all, traditionally it has been used for last 4,000 years, this curcumin, and it has been used in different wounds to apply for the healing purpose. Now we know the molecular properties by which it helps this curcumin. First of all, it has got anti-inflammatory effect. It inhibits nuclear factor kappa. Actually, nuclear factor kappa B is the nuclear factor with light chain, which is activated B cells. Ultimately, it as a transcription protein, transcription factor for the DNA, from the DNA, and ultimately from the breakdown of the DNA, it causes deep breakdown of the DNA. Moreover, it leaves the cytokines is being liberated, IL-6 as well as T1 necrosis factor alpha. Now, thing is that this curcumin causes inhibition of this nuclear factor kappa B, And so it, rather in that way, it helps to control the inflammation. Moreover, curcumin also causes downregulation of cyclooxygenase and this lipooxygenase pathway, which is seen in TS2 pathway, inflammation, allergic inflammation. So it blocks these two. So ultimately, it acts as the anti-inflammatory. Nuclear factor kappa inhibition. Number two, it has also the antioxidant property, like phenolic property, or the phenolic structure of the curcumin helps to scavenge the free radicals which are being produced regularly in our normal process also. So it helps to upregulate the antioxidant enzyme like superoxidase dismutase and ultimately and also catalase, so that it helps to control the scavenging of the free radicals. Number three, it has got antimicrobial activity. Curcumin has been shown to be effective against various bacteria, virus, fungus, as well as biofilms, which we are seeing regularly in our day-to-day practice. Now, there are some clinical evidences. We are going to show it also. So, first of all, we are coming to rhinosinusitis. We are getting a lot of cases of rhinosinusitis in our day-to-day practice, causing nasal obstruction, facial pain, as well as hyposmia, anosmia. So it is a significant burden on the society. It is characterized by the inflammation of the nasal and paranasal sinus mucosa. Now there is inflammation as well as immune factor, biofilms are also involved in the inflammation itself. So it helps in CRS, it helps by inhibiting the nuclear factor kappa B as well as reduce the production of pro-inflammatory cytokines. So curcumin can help to modulate the inflammatory response in CRS. So also curcumin has got antibacterial property. So definitely it will help to control the infection part. Now randomized control study has been conducted by Karkos et al. In 2019, not far away. And he explored the efficacy of curcumin as a nasal spray in controlling the CRS symptoms. Patient using curcumin spray experienced significant reduction in the symptomatic score. Now, we have got another case where 45 years old male is a history of CRS and previously treated with intranasal steroids and antibiotics. And ultimately, incorporating the curcumin nasal spray, we found there is a definite improvement in the patient symptomatology. Marked improvement of the symptoms after 6 weeks. So definitely, we won't say it is a primary treatment, rather it can be as an adjunct treatment to our present regime. Now comes otitis media. Otitis media, particularly COM, is a common cause for hearing loss as well as other complications. Now, persistence of the inflammation and infection is probably because of the infection as well as biofilm, which we come across. Now, this persistent inflammation and bacterial biofilm, which protects the organism from antibiotics, and ultimately patient keeps on suffering. So, here in otitis media, curcumin acts as curcumin ability to disrupt the biofilm and reduce the inflammatory cascade. So that is again a new approach for our COM cases, particularly where there is a resistance to other antibiotics. Additionally, its ability to downregulate the pro-inflammatory cytokines can reduce also in chronic inflammation. There has been study, Smith et al. In 2020, not far away again. In laryngoscope, it came out, showed that the curcumin, when combined with standard antibiotic therapy, enhanced the eradication of Streptococcus pneumoniae biofilms in preclinical models of otitis media. The study was highlighted by curcumin's potential in reducing the effusion also. Again, clinical application, curcumin can be considered as an adjunct therapy potentially in topically formulation for or as a part of the combined oral regime. The development of the curcumin-based ear drop and systemic delivery might offer a targeted treatment with less side effect. And again another 7-year-old child with otitis media progressing to chronic otitis media. Addition of curcumin in a bioavailable formulation to the standard treatment regime. Decreased frequency of otitis media. Pediatric cases are particularly challenging due to the developing immune system as well as high risks of the deafness, and moreover, curcumin helps to adjunct could be significant in this population. Now, in case of LPR, laryngopharyngeal reflux, again there is a condition where we come across symptoms in the throat as well as chronic cough and hoarseness. Now, the reflux material irritates the mucosa of the pharynx and larynx, where the pH is different altogether, leading to chronic inflammation and potentially more severe complication, laryngeal granuloma and all. Now, how it helps in LPR? Again, it is the anti-inflammatory. Curcumin's anti-inflammatory action can help to elevate the mucosal irritation, inflammation, and potentially reducing the severity of the LPR symptoms. By modulating the expression of inflammatory cytokines in the affected tissue, curcumin may reduce the chronic irritation experienced by LPR patients. Jones et al. In 2021, again not far away, conducted a pilot study published in the Journal of Voice, where the patients with LPR who supplemented with curcumin showed improvement in throat irritation as well as voice quality. Now, practical application and case study, again 52 years female with persistent throat clearing and hoarseness, and they were put on proton pump inhibitor with limited success. Now, introduction of curcumin supplement alongside with the dietary modification, notable improvement was seen. Now comes head and neck cancer. Head and neck cancer includes the cancer of the oral cavity, pharynx, larynx, are most of the cases common malignancy, especially in our area. This cancer can often be associated with significant morbidity. Now, treatment typically involves combination of surgery, radiation, and chemotherapy, but recurrence rate is very high, and there are significant side effects associated also. The pathogenesis, of course, is complex. Genetic mutation, environmental factors such as tobacco, alcohol, and viral infection, HPV, is also known contributor. Now, in malignancy, curcumin helps in number one, induction apoptosis. We know there is an anti-apoptotic factor, BCL2, as well as pro-apoptotic factor is this catalase, caspase. Now, curcumin induces programmed cell death in cancer cells by activating caspase and downregulating anti-apoptotic factor like BCL2, BCL-XL. Now, inhibition of the angiogenesis is again important. Curcumin inhibits vascular endothelial growth factor, VEGFR, GRF, which crucial for tumor blood vessel formation, angiogenesis. So again, it helps to prevent that. Now, suppression of the metastasis, again it is important that it causes the modulation of the extracellular matrix by the help of matrix metalloproteinase, MMP. So then again, there is this MMP causes this regulation of the extracellular matrix, which is involving your proteoglycan and then collagen and linings. So if it inhibits the migration and invasion of the cancer by modulating the matrix by the metalloproteinase, activating the metalloproteinase, so it helps prevents the metastasis formation. Now, enhancing of the chemoradiotherapy, I have also seen that it helps in potentially improving the efficacy of chemotherapy as well as radiotherapy. Now, Patel et al. In 2022, again not far away, in Cancer Management and Research, reviewed several studies highlighting the curcumin's role in managing head and neck cancer. The review concluded that curcumin could inhibit tumor growth, reduce treatment side effect, and enhance the effectiveness of the conventional therapy. In clinical trial involving patients with oral SCC, those who received curcumin alongside with the standard chemotherapy showed a significant reduction in tumor size compared to those who didn't receive therapy. Curcumin should promise a adjunct to the cancer therapy. Its use in clinical practice is not yet standardized, but more extensive clinical trials are necessary to confirm these findings and to determine the optimal dosing strategies also. Again, 60-year-old man with advanced laryngeal cancer undergoing chemoradiotherapy. The patient experienced significant side effects, including, as usual, radiation mucositis and systemic inflammation. Addition of curcumin in the supplementary therapy taken orally in a bioavailable formulation aimed at reducing inflammation and improving the overall response to the treatment. So in summary, again, we have explored how curcumin anti-inflammatory, antioxidant, antimicrobial and anti-cancer properties can be harnessed in the management of the various ENT disorders, including CRS, COM, LPR, and head and neck cancers. The evidence suggests that curcumin could be a valuable adjunct therapy, potentially improving the outcome and reducing the side effect of conventional therapy. These are the challenges, its consideration. Firstly, the bioavailability remains a significant challenge. Formulation, the amount, the year, because nowadays we get QPL in the form of 500 milligram tablet. I am using it regularly. I am using not only for this CRS, I am using for the allergy cases also.
So if you could finish your presentation.
Because this curcumin is supposed to induce Th1 immunity, healthy immunity, and improve the immunity of the person. These are features, research, direction necessary, especially in pediatric, and large-scale clinical trials are also necessary, and curcumin as a combination therapy also. I think these are the takeaway message. While curcumin shows great promise, it should be viewed as a part of holistic treatment plan only, complementing the existing therapies. Curcumin should remain informed about the latest research. Clinicians should be informed and be cautious about the recommending curcumin. These are my references again.
Thank you, sir.
Thank you all.
That was an excellent presentation. And concept is very good, sir. Sir, one small query, sir. So how did you assess the outcome, like in this patient? What is the parameters?
Sir, let us come to it. Firstly, in case of CRS cases, fine, we do the snot score. With multiple questionnaire, you can find out what is the about each symptoms, and nasal endoscopy, as for that matter. Achha, regarding COM, fine, you can just do UM on endoscopy itself, autoendoscopy, you can find out. So also in LPR, you can do C for the reflux finding score as well as reflux symptom index, RSS, RFS. And you can find out what is the improvement you gain thereby. So for each diseases, we can follow in a proper way and we can know how much benefit you gain thereby. Curcumin looks very simple, but again, I don't know, in future it may come in a very big way. Because it is our natural thing. It is from the ginger family only. It is a natural thing. If you can harness that and helps in our patient, why not?
Thank you, sir. Thank you very much.
With due permission from the chairperson, we'll have a break in this session and we'll switch over to our oration, next oration, because Dr. Amitabh Roy Choudhury has reached just now and he is not well, so we want to he wants to give the oration now only. And to chair this session, I would like to request Dr. U.T. Bhuya sir and Dr. Subhamoy Chakraborty to steer this session. Now,
good afternoon, everyone. For our Dr. A. Hakim oration, we have our speaker, esteemed Dr. Amitabh Roy Choudhury. Now, I would like to say a few words about him. He is the professor and head of ENT, Vivekananda Institute of Medical Sciences, Kolkata. He is the visiting otolaryngologist, Manipal AMRI Hospitals, Kolkata. He is the president, West Bengal Association of Otolaryngologists of India, past president, Association of Phonosurgeons of India, past editor-in-chief, International Journal of Phonosurgery and Laryngology. His 33 years of ENT practice publications include co-editor Textbook of Laryngology published by J.P. Brothers 2017, chapter on benign mucosal fold disorders of the larynx in India, point of care, Elsevier publications, 38 publications in international and national peer-reviewed journals, workshops and conferences. He has been a keynote speaker at World ENT Congress, IFOS Dubai 2023. He has been an invited speaker at European Otolaryngology Congress, CEORL Brussels 2019, a mentor surgeon for cochlear implantation program in medical colleges and private institutions in 5 eastern Indian states and Dhaka. He has delivered orations and keynote address at many state and regional conferences in India. He has conducted more than 100 hands-on workshops on various branches of ENT since 2003. So it's our privilege to have Dr. Amitabh Roy Chaudhary among us. With due permission from the speaker and our chairpersons for this oration, I would like to request the granddaughter of Dr. A. Hakim to kindly come forward and give a presentation on Dr. A. Hakim. Let's welcome on stage Ms. Nafiza Jannat Hakim. Ms. Nafisa Jannat Hakim, please welcome on stage. Granddaughter.
A warm good afternoon to one and all present here. Myself, Nafisa Jannat Hakim, granddaughter of Dr. Abdul Hakim. Today I stand before you honored to say a few words about my grandfather. Dr. Abdul Hakim was a great teacher, a renowned and excellent ENT surgeon of Northeast India in his era. He was born in Mankachar, then in undivided Gwalpara district of Assam, in the joint family on 1st of April 1927. He did his schooling from Mankachar High School and completed it in 1944. He later joined Carmichael College of Rangpur, now in Bangladesh, which was famous in those days, and completed his 12th standard. He was selected for MBBS at Assam Medical College when he was in the 3rd year of BSc at Cotton College in the year 1949. After completion of MBBS, he joined as the registrar in the Department of ENT at AMCH, Dibrugarh in the year 1958. He worked in the Department of Surgery with Dr. B. Dauka, Professor of Surgery, from the 1st of October 1961 to 13th of March 1962. He was then transferred to GMCH in the year 1966. As there was no vacancy in the ENT department, then he was posted in the anatomy department, where he was given responsibility to teach anatomy of head and neck to the undergraduate students, where he used to slice the temporal bone to study the inner ear and vestibular apparatus. During his post-graduation, the topic of his research was acrylic resin implants in the surgical treatment of atrophic rhinitis, which was published in the Indian Journal of Otolaryngology in the year 1967. Thereafter, for the second time, he joined as registrar in the Department of ENT at AMCH in the year 1969. He retired from AMC in the year 1985. As a teacher, he was always a favorite amongst the postgraduate students of the ENT department, and it was thought to be a privilege for the students to work under him. For a house surgeon, it was tough to work under him as he was very strict and particular in nature. And on the other hand, he loved his students and had soft corners for them. He was always stressed over learning the subject by its basic facts, and his most favorite subjects were otology and head and neck surgery. During the 70s and 80s, he performed a huge number of laryngectomies with block dissection of neck and the entire northeast region, and most probably in the eastern part of India too. Moreover, he was the pioneer in the northeastern region in doing tympanoplasties and stapedectomies. In those days, as the operating microscope was not available, he performed these surgeries with the help of a simple loop. The last apidectomy he performed successfully was 15 days before he left us for heavenly abode at the age of 75 on 4th of September 2002. He was a great reader. He was always up to date in buying books and reading all the recent editions of otolaryngology books. He was a regular reader of all types of magazines, religious books, storybooks, biographies of great personalities. He was a great lover of music too. During his undergraduation, he was music secretary twice. He was an amazing singer who loved Ghulam Ali, K.L. Saigal, and many more. He was selected in All India Radio too. His work was appreciated and he was felicitated by different associations like NEBOI, Neuro-Otology, Otology, and IMA Dibrugarh branch. He was awarded with Radha Govinda Borua Bota for his excellence in his field of work as well as social services. That was my grandfather. Thank you.
Pointer, only pointer lagi.
Good afternoon, everybody. The next session, the Dr. Hakim oration will be presented by Amitabh Roy Chaudhary. Before you proceed, I'd like to say that I've had a personal experience of being a student of Dr. Hakim right from the first day I joined medical college. He was my hostel superintendent, so he's the first teacher I officially met. In due course, he was my undergraduate teacher, and when I joined ENT, learned a lot from him. In addition to his teachings, we used to always look forward to Eid and the invitations for the sumptuous pulao and chicken that was made by Baido. Fauzia here was a little girl then. Then on the day he died, I was in Gangtok taking examinations, and the person who was sharing the chair today, Shubhamay Chakravarti, was a faculty of that college. Amitabh Roy Chaudhary, came across him when I was a young registrar in Assam Medical College. He had come to do his postgraduate diploma. One thing about him, he's a third generation doctor who has received their whole or part of their medical education in Dibrugarh. His grandfather was a student of the Berry White Medical School. His father was a student of Assam Medical College, the erstwhile Berry White Medical School, which was upgraded to a college, and Amitabh himself received his postgraduate diploma in ENT from Assam Medical College. Of course, he has now moved out of the state, doing very well. So let's proceed with the oration. Kindly go ahead, Amitabh.
Good afternoon, respected chairpersons. Thank you for the
elaborate introduction of Dr. Hakim. I am really honored and humbled today to be able to deliver this oration. By the name of such a person, we have just heard the entire life history of this great person, teacher of the teachers. He is teacher of many teachers here, and indirectly I would say he is probably the teacher of everyone present in this, because teaching is normally gets transmitted through generations. So though I have not met him personally, but I have also heard about all his activities, all his things, so much from all the colleagues, and especially Dr. Fojia, who was with us when I was in the department. We all have imbibed a lot of things from the great personality. And I was amazed to know that the amount of research and farsight and the vision he had in those days when he published his work that has been shown. So I am really honored and humbled to be able to speak on a oration by his name. So I am going to talk about anterior skull base defect. Why I am calling it conquering skull base defect? Because as an ENT surgeon, what we have done over the years, that we have actually conquered beyond the region of nose and throat, like what Dr. Hakim and his colleagues would have done. We have conquered beyond that, and skull base is one of the region. So when I was a student, when we used to get a case of CSF rhinorrhea or a skull base defect oozing, we used to just pray that we can get this patient referred to a neurosurgeon, and pray that this patient will get operated and through a craniotomy approach with all the potential complication of craniotomy. But today the neurosurgeons refer the CSF rhinorrhea patients to us, saying that we do not want to open the skull. Interestingly, recently one patient who had third time recurrence after a CSF, spontaneous CSF leak, repair endoscopically elsewhere, and obviously we thought that now it should be time to open up and repair. But then the neurosurgeon said that even if it is fifth time, endoscopic approach is the best. So I think this is where we stand today, and that's why I am calling it that we are conquering the anterior skull base. So I have already talked about this. So why transnasal? Because the approach is straight. If you come from the skull, if you do a craniotomy, if they do a craniotomy, first of all you have to travel all that much, because this is the skull base from anterior part to the posterior part up to the sella here and planum here. So lot of brain retraction which causes a lot of morbidity, and also olfactory filaments can be damaged, and also there is a lot of distance that the surgeon has to travel to reach the defect, and the defect can be seen in a tangential manner. But here, if we go from the below here, we can actually see the defect end on, and therefore it is better, and it is documented that this kind of a repair is the best option to repair any skull base defect. Now there are lots of reasons where the skull base defects occur. Primarily we deal with spontaneous leaks, and also iatrogenic, which can be accidental during face surgery or any other tumor surgery in the nose, or as a part of the surgery. If you are doing craniofacial resection, which was earlier done like this from here, but now it can be done all endoscopically, and you have you create a large skull base defect, remove the whole crista gala and everything for an olfactory neuroblastoma, then you repair it. So you create the defect and you repair it. So either it's a surgical accidental defect, or it's a created defect, or it's a spontaneous. Just 1 minute spending on the CT scan, the imaging. Obviously imaging is the gold standard to find out where is the leak. Unless we are talking about a refracted neuroblastoma or something where we are operating and creating the defect. So if you see a plain CT scan which is very properly done, 1 millimeter section, then you can actually, even a plain CT can very well say that there is a defect here. But CT cysternography also in same situation will show you that the CSF signal has stopped on this side, but CSF signal has continued into the nasal cavity, and the dye has gone into. So this is, but over the years actually people are gradually drifting away from CT cysternography to MR cysternography. Why? Because MR cysternography is just a dye given just like a contrast study. It's not a true cysternography. It's by subtraction technique they can differentiate between dura and CSF and everything. So it is not having much complication like the ionic dyes which is given intrathecally have. But MR does not show us the actual bony defect. So in an ideal world you should have a MRI with a plain CT. MR cysternography with a plain CT is the best, because MRI will not only tell you the CSF signal, but it will also tell you whether the brain is affected, whether there is thickening of the brain, whether all those things. And a plain CT without a intrathecal dye will tell you the size of the defect and everything. So you can have defects from spontaneous leaks can be from medial lamella, from lateral lamella, from the frontal area here, and sometimes from the sphenoid. What I'm going to do, I'm just going to show you a few situations and how do we handle them. Now what are the graft material that we use? Obviously fat and fascia, all these things are age-old things. Sometimes cartilage can be useful when we find that the leak has been very high pressure to sustain this and to prevent brain herniation. But today I think gradually we are moving away from cartilage reconstruction. But today the talk of the day is vascularis flap. You take a nasal septal vascularis flap based on branch of sphenopalatine artery, and that gives a fantastic healing, very fast healing. And middle turbinate is also a vascular structure which gives a thing. Then we can have combination of all these. So we can have types of repair, like we can, but I'll show you that also. But we can just, if it's a very tiny, less than 2-3 millimeter weeping leak, we can just plug some fat and put some fascia over there. That will do. We can also, for a small leak, we can just do an overlay. Just put a rotated middle turbinate mucosal flap or any flap, just put it overlay, that's all. We can give 2 layers like this. You can either give an underlay and then overlay into the nasal cavity. We can give 3 layers repair like this, an underlay. I'll show you examples of those. And we can also, for a sphenoid sinus or frontal sinus leak which are large, you can obliterate the sinus by taking the demucosalizing the whole sinus. First of all, bath plug repair. See, here is a defect. Here we can see pulsating, the dura is fully exposed. So in bath plug what we do, this fat has been tried with a small vicryl string, and once we plug it, after we plug it, we just pull the string to create a watertight seal, because then it tight, and after that if it is optional to give some tissue glue, that will hold. So it's a very simple and sure success technique if the leak is small, and it works very well. But it does not work very well for and obviously after a bath plug you can give whatever material you want on top of it. Then a 3-layer repair. You can see this is the small mucosal projection which happens many of the time because of the CSF dripping through the, but it does not mean that this is the area of the leak. In this particular case, this was the area where it was dripping through, but the leak was here. So you will see it in a minute. I'll just flip through some portions of it. So once you confirm that it is CSF, washout sign, you can see high flow CSF pouring in, very high flow reasonably. So next thing is, now we want to create a very good bed for the repair and elevate the mucosa, and once you elevate the mucosa, we can actually find where is actual bony defect. Instead of blindly finding, we prefer to, as you have seen, that mucosa has been elevated or is being elevated, and you can see that this is the mucosa which is being brought down, and we can now see the bony defect very clear. And the mucosal projection was here, so it was trickling from there till here like this. So once you have seen that there is a large bony defect here, you can practically see the there is a dural defect also, and then you make sure that there is bony bed has to be created very well. So anterior, posterior, laterally, it's like a tympanoplasty, you elevate the flap. In this case, a cartilage has been taken. I'll just flip through this. So first of all, we put a underlay fascia lata here. I'll just flip through a little bit. This fascia is going. So the actual bony defect is quite big. As you saw, this entire fascia, it's like underlay tympanoplasty. It's just going in the whole fascia. Now, because this fascia is bulging and that may not hold properly the CSF pressure, and therefore we decided to put a cartilage in this case. This is slightly quite a few years old video, and you can see that this is quite secured, and always we like to put some fats around the repair, just like we put gel foam in a tympanoplasty to secure the graft all around. That's the first layer, and because it is a high pressure and it's unlikely to hold, we put this cartilage, small septal cartilage, which will stabilize the repair. Just trying to push gently, it will just get it locked there at one stage. You will see in a minute that at one moment, now it has got locked inside. Just snapped it, and you can see that this is absolutely locked. And after that, you can put a layer of fascia, which you can see now. This is the fascia again. So it's a 3-layered repair, and it works quite well. And always it is the option, or it is the choice of the operating surgeon to use a tissue glue or not. But tissue glue is always helpful to hold this repair for the next few days when the repair, when the healing starts there. Then you can do a vascularized flap. Here, what we do is we cut the middle turbinate from here, but not remove it, keeping the axilla intact, keeping the landmark intact. We do for most of the cases nowadays, and put the middle turbinate backwards and park it in the nasopharynx. So we are not destroying the middle turbinate, which can cause atrophy in the future. And once you have done that, I'm not showing the repair here, it's just a clip to show that after you have done, after we have parked the middle turbinate into the nasopharynx, we are elevating the vascularized flap, which is based on the branch of sphenopalatine artery, which is a Hadad flap. And that flap, depending on the size you require, you customize. You can take a very large Hadad flap also for a repair which needs to go up to the sella turcica and pituitary fossa and the plenum sphenoidale, all those posterior and superior areas. But for this purpose, probably this slightly small thing was enough, and I'll just quickly show you how to elevate the flap. And as you have seen, that this flap is being elevated from the septum, and it is pushed on top of the original repair of fat or whatever. So this is the last layer always, the vascularized flap. Sometimes a small leak, as you can see, sphenoid sinus, you have a small leak here. So for a small leak, again, you can either do a bath plug, or we are just putting the fat without this is also a bath plug, and on top of that we put Surgicel, which is holding the fat, which is also going to help in forming a collagen in the future, and then more layer of fat, and finally either if it's a very small, we can stop the repair here itself if the pressure is not very high, and then whatever the need of the patient and the choice of the surgeon, you can put a fascia. Always either a mucosalized graft or a fascia on top of fat is better, because fat will get absorbed and this will the mucosalized graft will stay, and this is tissue glue which is going to keep it support, so you do not have to obliterate the sinus for this. Now nowadays lots of artificial sealants have come out which neurosurgeons are very fond of. This is very common item that is used by all of us is something called Duragen, which is a bovine collagen extract, and it has started with neurosurgical because they intracranially they use a lot of this bovine collagen extract strips for repairing of the dura, and endoscopically also. So this is again mucosal projection or protrusion, which is sorry, you will see that this is the area which is, so you try to find out the bony defect around this, and once you puncture it you can see. So this is the piece of Duragen or the bovine collagen extract sheet, which you can place as an onlay or even underlay, because intracranially it is regularly used by neurosurgeons. And once you do that, you have to put cotton or patty or something to make it dry and free of blood, so that it already sticks to the bed where you are putting it. So this is the cotton strip which is given, and we leave it there for 2 minutes. After 2 minutes, suction on the cotton. This is actually at the area of the anterior ethmoidal artery, and this is frontal sinus. That's the anterior part of the skull base where the defect was. So this is sealed. A second layer is going on in the same way. Again, this is frontal sinus, this is the anterior ethmoidal artery, and this is the area. So second layer of the same thing is gone, and after this you will see that the vascularized flap was ready. We just put, so no fat here, just no scar in the thigh or abdomen to get fat. So only artificial sealant followed by a vascularized flap, and it's a very robust flap and it stays there lifelong, and it creates a very good seal within a very short time. That's all. Preventing blockage of the frontal sinus drainage. Make sure that is not blocked by the flap. Frontal sinus leak. This is a leak where you would see that we had to divide the anterior ethmoidal artery and then find the leak, which I have not shown here, but you will see the stump of the anterior ethmoidal artery. This is the stump of the anterior ethmoidal artery which we divided, this one. And only when we divided the anterior ethmoidal artery, we could see the defect here, which is nothing but in the frontal sinus floor and in the junction of the anterior ethmoidal artery and coming to the anterior skull base. And as we have read in the literature always, that the weakest point of the skull base is at the region of the anterior ethmoidal artery. So this is the example of that kind of an area where there is a leak. Iatrogenic leak site, this is the commonest, and so you can see that brain material, there, that's actually the material brain, and then That's the CSF pouring in there, small defect, and this is how it is repaired. Finally, repair after hypophysectomy or any other skull base surgery. Again, this is, as you can see, this star-shaped incision for a pituitary surgery. Surgery completed, and then the Huddard flap is also ready here. So what we do, we put a piece of Duragen, which is the synthetic bovine collagen extract sheet, and make the repair secured. After that, it's optional to give fascia lata, but here the third thing here I would like to show, this is a second layer of the same thing, Duragen, and then the vascularized flap, because this case had a quite a severe CSF leak at the end of the surgery, and therefore you have to be, and this is the middle turbinate which was parked in the nasopharynx, and this is brought back. It not only restores the structure, anatomy of the nose, and eventually after 6 months the physiology of the nose, but it also provides another layer of vascularized support to the graft, to the repair that we have done. Last but not the least, we have navigation today to help us show the leak. So when we have, for those of those juniors or those who are not familiar with navigation, what we do is, this is the navigation probe, and the patient has to be done a CT scan on navigation protocol first, and then we match the image here. So once we point it here, we match the areas where we are going. In this case, this is the posterior wall of the sphenoid sinus, and as you can see, we are just seeing that whether we are in the right place. It is more important in case of tumor surgery, more important when the tumor is engulfing the carotid, because then you can go laterally. For example, these two are the bulges for the cavernous portion of the carotid, internal carotid, and therefore if you go laterally, you will be able to see how far close you are to the carotid or not. So that navigation always helps to be safe when you are dealing with. Post-op care is very routine, except for cases where we feel there is a high pressure leak. A lumbar drain has to be done, and the lumbar drain needs to be every day about 120 ml in an adult needs to be drained. After 3-4 days, once the pack is removed, then the lumbar drain is removed, patient can go. So if the lumbar drain has to be given, then the patient ideally needs to go to HDU setup. If no drain is given, patient goes back to normal ward, but Diamox or acetazolamide is given for all these patients for 2 to 3 weeks, and all the precautions that we give for normal conservative care for CSF leak patients that we get. Now, this is one thought that we have devised, that to grade the leak, we are working on it, and to find and create an advisory of how to repair, what kind of a repair to standardize the repair. So for a spontaneous leak, grade 1, when there is no leak visible on the table, but if you give Valsalva, there is weeping. Grade 2, there is a small leak and there is a small washout sign the moment you enter the endoscope. Grade 3, very active leak visible with a very small mucosal protrusion like I showed you. And the grade 4 is pulsatile high pressure leak on a pseudo-meningocele. Actually, it appears like a meningocele, but not true meningocele. Brain matter is not inside the brain, but there is meninges falling in. That's grade 4. So this is a endeavor that we are trying now to kind of come to a conclusion of creating some standardization for repair material. So these are some of the things I am going to skip. Main thing that I want to share is that success rate in the literature is 92 to 96%, which is which is probably true for every center that anywhere is doing. But when we are doing it a larger defect, then we have to be very careful. For example, as I said, if you do a craniofacial resection, the success rate, the second time, chance of second repair requirement is higher than a small leak that we do. So finally, key to success, first of all, is localization. Whatever the radiology has shown, first of all, we should be able to see the leak before we start poking in the nasal mucosa. So do initial nasal endoscopy, we may see a pseudomeningocele or meningocele or mucosal protrusion, then we are more or less sure we can just poke it there like I showed you, you confirm, then you embark on your surgery. Obviously, this is guided by the anatomy, whether it's medial lamella, lateral lamella, sphenoid, obviously that's the area. Middle turbinate, as I said, okay, I'll talk about that. Next, even if you then cannot see the leak, then you have to do Valsalva. Anesthetist will do Valsalva, and most of the time, if you cannot see, the leak will appear. Next is intrathecal furosin, which we do not use, but this is very much given in the literature, and if you cannot find a leak, rather than abandoning, it is recommended that you can give fluorescein, and with the filtered endoscope, you can see the color change and you can pick up. Now, preparing the bed, again, depending on where you are doing, if it's as I said, middle turbinate is always an hindrance to reach the site. So either you have to resect by debrider ruthlessly the middle turbinate and pay for this in the long run, having a bad anosmia, bad crusting for 6 months, and lifelong problem, or what I have shown you, that you can preserve the entire middle turbinate, but you can just cut the middle turbinate, put the whole thing in the nasopharynx, finish the repair, bring the middle turbinate, put a drop of glue, it will stay there. And second thing is that the bony bed, main key thing to success is not about how we repair, what material we use, is how well the bed has been prepared. If, just like tympanoplasty, if you have not demucosalized the perforation of the pars tensa, whatever fancy technique you use, the graft will not take, because at some stage there is fibrotic band, then that graft will not take. Same thing appears here. There has to be an adequate amount of raw area. Next is, we have to achieve a watertight seal on the table. We cannot afford to say, oh, it's leaking a little bit, I think it will stop. It will never stop. It has to be watertight seal. If you are not happy, remove everything, do a repair again in afresh, think afresh, make it dry, and no irrigation preferably, because irrigation confuses whether it's leaking or whether it's saline. And finally, additional support is tissue glue, which is always good. It does not help in repair anyway, but it helps to support the repair what you have done, because eventually many things of this repair will not stay. There will be a fibrous capsule which forms. So that capsule has to be formed, and during this period, this will prevent the brain, prevent the CSF to come down. And lumbar drain as and when appropriate. So with all these philosophical and planning, I think success rate is very high, and we should be able to, I think all of us should be able to do this on a regular basis. Any surgeon who does endoscopic sinus surgery should be able to do it. I'm sure all of us do it, but there should not be any fear of doing CSF leak repair. But it's not just we plug and come out. We have to think what is the problem, what is the mechanism happening, what is the, and it depends partly on philosophy of schools that you have brought in, because every school has different thought. But I have given you our experience and my insight on whatever we have learned in 25 years. Thank you. I am again grateful, once again, I am again extremely grateful to the organizing team for giving me this honor today, for having delivered this oration. Thank you.
Thank you, sir. Excellent presentation and thorough discussion about this ESF repair in your lecture. And in oration, there is no question is allowed. No question is allowed. If any one of you have got any queries in your mind, you can discuss with Professor Amitabh Rai Chaudhary during the lunch session. Thank you very much, sir. Thank you.
Thank you, sir.
Thank you so much, sir. If I may request you to kindly proceed towards our felicitation corner, and I would like to request Dr. Fawzia Shireen Hakim and Ms. Nafiza Jannat Hakim to kindly come towards the felicitation corner and felicitate Dr. Amitabh sir. Please give a huge round of applause. Now, I would like to request Dr. Anjana Sarma to kindly felicitate Dr. Amitabh sir on behalf of NEBOI. Please give a huge round of applause, everybody.
Now it's time to declare the winners of Swami Vivekananda Award paper. And the winner? Oh, we are here to felicitate the chairperson. I was too excited to declare the winner of the Swami Vivekananda Award paper, and I didn't see the chairpersons were not felicitated. So the winner of Swami Vivekananda Award paper is Dr. Priyanka Chetia. She is from SMCH, Silchar Medical College. I call upon Dr. Biraj Das, Professor Dr. Biraj Das, to give the honor to Priyanka Chetia. Priyanka ta. The winner of poster presentation, the first prize goes Dr. Quddus Ahmed and Dr. Asbi Fukan also given her some award for her motivating all the PGs. Now the winners of the poster presentation is, first prize goes to Dr. Bijit Nath, second prize goes to Dr. Shivangi Sahu, and third Injumani Payeng. Will you please come over? The winners of poster presentation are Dr. Bijit Nath, Dr. Shivangi Shahu, and Dr. Rinjumani Payeng. Will you please come over to the felicitation corner? First, second, third. First prize. College kita na jano? Shall we postpone the distribution of poster prize? We'll give their prize later on because other two persons were not informed during the valedictory function.
We'll continue the invited talk session. Dr. Lutha, kindly call upon the next speaker.
Okay. We will continue the previous invited talk for. The next speaker will be Dr. Supriya Chindam. The topic will be benign paroxysmal positional vertigo in vestibular migraine. Please take the time.
Hello. First of all, a very good afternoon to all the delegates, faculties, guests, and all the organizers of NEBAOICON. I am very much honored to be a part of this platform and to present before all the great ENT specialists here. Thank you so much. To start with, my topic is on benign positional vertigo in vestibular migraine. We have heard about so many plus syndrome in vertigo, like migraine along with the benign paroxysmal vertigo, migraine with menias, menias with BPPV. So my topic today is benign positional vertigo in vestibular migraine. To start with, this is the clinic where I practice. This is my humble clinic located near the airport of Imphal. Migraine, as we all know, is a reversible primary brain disorder characterized by recurrent attack of head pain associated with autonomic nervous system dysfunction that result due to the maladaptive behavior response to stresses affecting a genetically determined migraine threshold. And vestibular migraine is a subtype of migraine headache characterized by episodes of vertigo which are accompanied or preceded by migraine symptoms such as headache, visual disturbances, or sensitivity to light and sound. The causal link between the two is controversial because possibility of both migraine and dizziness or vertigo can coincide by chance, since the prevalence of migraine has been shown to be increased in patients on dizziness, and conversely, patients with migraine reported more dizziness frequently than other type of headache. This might explain the statistical link of other vestibular disorder such as BPPV and Meniere's disease. To start with the epidemiology of the vestibular migraine, it can occur at any age but more common in the late 30s, and female to male ratio is 3:1. Both migraine and vertigo are common in general population with a lifetime prevalence rate of vestibular migraine 1%, and recent study shows 10% of the attending patients of vertigo clinic are vestibular migraine, whereas 9% in headache clinic has vestibular migraine. Vestibular migraine is the thing which we have to remember is vestibular migraine is different from vertigo symptoms that is seen in a basilar type of migraine, as the migraine seen in this case occur as an aura symptom lasting between 5 minutes to 1 hour and should be followed by migraine headache, and in addition at least one or more aura symptoms from the posterior circulation is required.
Audiovisual kindly.
We all know that since the criteria of the vestibular migraine, probable vestibular migraine, how it differs is that इसको निकालते थे नीचे इसको निकालो ये जो लैपटॉप नीचे सपोर्ट में pen drive also. Yeah, pen drive hai.
Which slides? Slides number? For starting cells?
No, I just want to, she will,
No, ma'am, which slide number? Then
no, she will. This one, no, I will write to the presentation. Hey, podium change kara, podium change.
I get it.
So the difference between the vestibular migraine and probable vestibular migraine is, in a vestibular migraine, both the history should be present as well as the clinical feature along with the vestibular symptom, like history of headache, pulsating headache, photophobia and phonophobia, and visual aura should be present. And in probable vestibular migraine, either of the two, that is either the history should be present or the clinical feature of migraine along with the vestibular episode should be present. The vertigo symptom in the vestibular migraine has been attributed to various theories. The first theory is the symptom complex of aura, which is seen in a vestibular migraine, and this is not accepted. And the other theories are the vascular theory, where there is activation of the trigeminal vascular system leading to increased vascularity of ICA and neurogenic inflammation of the cochleovestibular vasculature. And another theory is direct activation of the trigeminal nerve and activation of the cochlear nerve and the superior olivary complex. Last but not the least, the theory of dysfunction of central processing of vestibular input. The vestibular symptom, as defined by the Berani Society, can be present as spontaneous vertigo, positional vertigo, visually induced vertigo, head motion induced vertigo, and dizziness. The studies have shown that although there are no specific diagnostic criteria for vestibular migraine, the most common finding in the lab test is central ocular motor disorder, showing a percentage of 66%, where both the saccadic as well as the abnormal saccades and the smooth pursuit findings are combined. And the second common presentation is the saccadic pursuit, attributing about 57%. The third one is the spontaneous nystagmus. The unilateral caloric paresis are also present. Last but not the least, central positional nystagmus. But although we know that the central positional nystagmus is very common in vestibular migraine, my topic is on benign positional vertigo in vestibular migraine. And these are all the references which I have noted. BPPV has been reported in association with migraine-related dizziness. The possible coexistence of a correlation between BPPV and migraine dates back to 1998, when two scientists, Bello and Henurubia, described 3 members of a family who developed BPPV before the age of 13 years. Other studies by Breben and Texido reported about percentage of about 34 to 35% correlation of migraine with BPPV. In a recent study, Bello has published an article on a persistent direction changing positional nystagmus, another variant of benign positional vertigo. Ischemia et al. Postulates that repeated vasospasm can affect the microvasculature of the inner ear, which in turn causes stress and damage to the vestibular cell, leading to the displacement of otoconia from the macula. This is one theory. Recurrent vasospasm is also associated with the oxidative stress of the endothelial cell, which is a possible mechanism common to migraine and BPPV. In a study of oxidative stress with BPPV, levels of the pro-inflammatory mediators were studied, and it was found that it was reduced after the repositioning maneuver. Another possible mechanism postulated by Asperella libonati gessanto is that a localized fluid diffusion from the labyrinth microcirculation due to migraine could generate a transitory cupular dynamic disorder such as a light cupula and a heavy cupula mechanism, which result from the modified density ratio between the cupula and the surrounding endolimb, where cupula works as a graviceptor. That is, the cupula works as if it is the otolith in the cupula, but it's not exactly the otolith which is causing the positional vertigo, but the change in the specific gravity between the cupula and the surrounding endolimb. So in a vestibular migraine, positional vertigo is seen. Here I'm talking about a benign positional vertigo, which is seen is as a result of three pathogenesis: due to the otolith in the semicircular canal of the cupula, due to light cupula resulting from modified density ratio of endolimb and cupula, cupula being lighter than the endolimb, and due to heavy cupula resulting from the modified ratio of the endolimb and cupula, cupula being heavier than the endolimb. So a study was conducted in my clinic from 2022 to 2024. Here I took only the patient with a definite history of migraine and satisfying the Berani's criteria of vestibular migraine and having vestibular symptom, and also complaining of acute attack of positional vertigo, and findings were noted in the positional test, and the positional test done were McClure-Pagini test for the horizontal canal, Dix-Holpike and Simmons diagnostic test for the vertical were noted. And in the study, out of the 19 patients, 7 patients had a symptom of persistent direction changing nystagmus, which were not responsive to maneuver. So this were likely to be because of the modified density ratio between the cupula and endolimb rather than the otolith itself. So I have taken, due to the lack of time, I have taken only 2 videos. One is the horizontal and one is vertical, which were not responsive to the treatment. In the initial sit to supine position, there were no nystagmus, but as soon as the position was changed to right roll, we can see intense left beating nystagmus showing aposiotropic pattern. When the patient was brought back to sit to supine, there were no nystagmus again, and when the patient was brought back to left roll position, then again the nystagmus started to beat on the opposite side, that is the right beating, showing an aposiotropic pattern. This type of nystagmus was equally intense. Both the left and the right roll, they show equally intense nystagmus, and this, the maneuver done was not effective in this patient. Another patient is a case of posterior canal involvement. A patient was, Dix-Holpike test was done. When the patient in a sit head right position, there was no nystagmus. And when the patient was brought back to supine head extension, we can see upbeating torsional nystagmus towards right, and not very intense, and it lasted for more than 2 minutes 30 seconds. And when the patient was brought back to again to sit head right, a slower nystagmus, a downbeating, less excitatory lesion can be seen. This patient was also not responsive to maneuver. So the pie chart presentation, the graphical presentation of my study is this. This blue section shows those patients who were not responsive to maneuver, but to my surprise, were responsive to anti-migraine therapy for 2 weeks. So the conclusion of my study is BPPV in vestibular migraine, which is believed to be due to repeated vasospasm caused by migraine, and which leads to inner ear insult and damage to the vestibular epithelium, which in turn leads to the dislodgement of otoconia from the utricle to the semicircular canal, leading to BPPV. However, those atypical type of BPPV which is not responsive to treatment may be due to the modified density ratio of the cupula and the endolimb rather than the otolith, which is presenting as a persistent direction changing nystagmus. This type occurs due to the acute perturbation of the labyrinthine function due to vestibular migraine. The positional features of the evoked nystagmus are therefore essential to make a correct diagnosis and realize which scapula is involved in each patient. Further studies are needed to test the effectiveness of therapies and localize the pathophysiology involved. And with this, I end my presentation. Thank you so much for being with me.
Thank you, Dr. Supriya Sinta ma'am, for the excellent presentation. Our next presentation will be from Dr. Monish M. Chetri, and the topic is rigid bronchoscopy with limited plethora of equipment and infrequent cases in a remote tertiary care center, insight, pitfalls, and our experience.
pen drive यहाँ पे है व्हाट्सएप पे आप डाल सकते हैं सर यहाँ पर इंटरनेट है यूएसबी नहीं है ना मेरा टाइप सी नहीं है ना आईफोन है आईफोन 15 नहीं है 14 है इंटरनेट में कर लेगा मेरा इंटरनेट है afternoon, ladies and gentlemen. Sorry for the delay. It was in the cloud and it took time to come down. So I'm just presenting a small presentation on rigid bronchoscopy, the pitfalls and our experiences in a remote tertiary care center. So we know that rigid bronchoscopy is the transoral or the transtracheostomy procedure of rigid instruments in diagnostic or therapeutic purposes in the tracheobronchial tree. And right from 1897 until 1967, this was the only way to visualize the airways. Then we got our flexible scopes, which have actually now taken precedence, and most of us are doing flexible scopies. So most of us nowadays, we are preferring flexible scopies for multiple airways, foreign bodies also, and then other things also. So going through the literature, what I saw that in the 21st century, rigid bronchoscopy still should hold the upper hand in airway, especially for complicated foreign bodies or other things like that. And so a lot of studies where it still is considered the gold standard. Then nowadays, because of the Hopkins rod, our older scopies have become much better with the optical forceps and everything. So coming briefly to how to assess a rigid bronchoscopy patient, mostly we are doing, although our Chapler-Jackson says we are done a deep sedation, I think all of us will prefer to do it under general anesthesia only. And we will do some tests and then we will take up the patient. So out of all the indications, one of the common and indication where we cannot say no for a foreign body, it would be a foreign body retrieval in the airway. And coming to contraindications and complications, we all know that rigid bronchoscopy can cause some serious complications. So some factors will complicate our rigid bronchoscopy, and we have to take care to see those before we take up the patient. Mostly we go for a closed system ventilation nowadays, but jet ventilation can be tried, and apneic oxygenation previously. Nowadays, I think most of the places we have ventilating bronchoscope, so we don't go for apneic oxygenation at all. I'll not go into the assembly and all this one. I'll just share a few of our experiences in the past year or so. I have the only center in the state with facility for rigid bronchoscopy, but still then I have a very limited number of cases due to sparse population of around 6 lakhs, and then this actually affects the operator skills. And on top of that, the limited plethora of equipment, especially, I'll come to that a little bit. So first one, this one was a straightforward case. They had swallowed a cap of a toy, and it's a straightforward, we took it out. The only thing here was it was not visible in any of the imaging because it was radiolucent. So it's a strong clinical suspicion that what we should have. And this second one, okay, the second one had a nail. So the second one had a nail, and then I took up for bronchoscopy, and I thought I'll take out a nail. When I saw inside, there was some blue thing, and it was moving around, and then nail I could not see at first. The later on I found out that it was something like a pin, and this was the blue thing, which was actually radiolucent and not seen. So this was also, it was not a problem. And this was also interesting. This guy came from another hospital after 1 week of bronchiectasis, and then he gives a history of aspirating supari, some sweetie supari or something kind of supari. So when I see the CT, there was a supari there, so we took up for bronchoscopy, uneventfully took out a supari, and then I remember I did a recheck also, and then after doing a recheck, it was clear. So I kept the patient that day. I thought I'll discharge the next morning. Next morning, he had a violent bout of cough. He took out another supari. So I went back and then I checked the CT very carefully in the console. Then I see there are 2 suparis there only, but it was a faint line in between which I missed out. And after removing the first supari, the second supari fell down. So it came out next day. So this one, and then okay, one more I have here. So this was ugly one. This was just happened few months back. My pediatrician from the state hospital sent me a WhatsApp message early morning, so showing a foreign body bronchus. So I said, yes, doable, please. I didn't know, I didn't ask much how big. And then this is from a week back. Then I asked her, and then she says it's around 6 years, 7 years old. When the patient landed up in my hospital, the patient was already dyspneic and then all those things. And then the child was very small. He was like 4.5 years, 5 years old only. And then now I've already called the patient, so my instrument sets were not very adequate. So I took up, and then it was we didn't know what it was also. There was no history. So it was a tamarind seed. So I could see a tamarind seed there for the last 1 week, maybe more than a week. So first all the coverings came out, then the tamarind seed stays there. And then after repeated trial also, I could pull it up to the subglottis, and then it doesn't pass the subglottis. Then patient goes into desaturation, anesthesia asks me to take it out, then we will again try to do somehow, and then, so we attempted 3 times, not taken a consent for tracheostomy before that, and then I didn't have any other instrument other than this one instrument that fits into my scope. So after repeated trials, after 3 trials or 4 trials also, I could not take it out. I took out all the coverings, and then the thing was there. So patient party wanted to take to another center, and they took to another center where they took it out piecemeal, which I don't know whether it is accepted or not accepted. Ideally should be removed as a whole, no, organic foreign body. So this was the last one which I was trying to take out, and then it comes up till the glottis, and then it goes, then it doesn't pass through. Then everything is stuck. Then saturation is down, then after that anesthesia asks us, and again I push it back to the bronchus, then again I wait. So let's skip this one. So post-procedural takeaways, we should always do a repeat airway survey. So even after doing that one, I missed one foreign body. So I think we should read our imaging more carefully and complete ideal bronchoscopy equipment. So I was going through like what all we should have, what can we have everything or not. So this is mostly for pediatric, because adult we will have the same set for everything, but pediatric they have recommending 3 sets of equipment, 0 to 6 months, 6 months to 6 years, and 6 to 14 years. So I have these scopes we are supposed to have, and with all the forceps in all the sizes and the accessories and proper and safe storage options, because you realize you go to the OT and the equipment was there but it is not working because it got damaged in storage or something like that. So where do we stand, or where do I stand with infrequent cases, sometime 1 in a year, sometime 2 in a year, and mostly as emergency with limited instruments in life-threatening emergencies. Thank you.
Thank you, Dr. Mohanish. It was really nice. Like you have shared your experience with us. We all come across all these problems during our day-to-day time. Our next presenter in today's presentation will be done by Dr. Jarin. She'll be talking on audiological profile in COVID-19 recovered patients. I invite her to present her topic.
A very good afternoon to all present. Firstly, I'd like to thank the organizers for giving me this opportunity. And today I'll be talking about our findings on the audiological profile in COVID-19 recovered patients. It's a study we've done in the ENT department in NIGRIMS. So my talk will be divided into these 4 sections. That's a little bit about the background. Then we'll be talking about the methodology, then the results and findings, and finally I'll conclude with discussions and conclusions. So starting with a little bit about the background. I think we are all still very familiar with COVID-19. It is not so in the not so distant past. We all went through a global crisis with which affected millions and was overwhelming the health system. And then there was then the lockdown with the economic disruptions. And finally, there was long-term effects also in the patients. So it necessitated research on various fields. So the common symptoms and clinical spectrums of COVID-19, as we all know, affects the respiratory system. Then it had systemic manifestations and neurological and sensory effects. What most interested us was the neurological and the sensory effects. Okay, and as we all know, in our field, anosmia was synonymous with COVID-19, but we also had seen a few studies. There was research of viruses affecting the hearing mechanism. So we went ahead and we did this research on effect of COVID-19 on the hearing of the patients. So coming to the objectives and methodology, the primary objective of this study was to study the audiological effect of COVID-19 in patients who got infected and recovered from the disease by testing the pure tone audiometry, that's the PTA, and distortion product autoacoustic emission, that is DPOAE. And secondarily, the objective was to assess if vaccination had any effect on the hearing level of the people. So we included all patients above the age of 5 years who had recovered from COVID-19, and we mainly included asymptomatic, mild and moderate COVID infection, and we excluded all the patients with severe COVID-19 infection and all those who had pre-existing hearing loss, giddiness, vertigo or tinnitus. So the audiological test we had done was pure tone audiometry in the frequencies of 250 to 8000 hertz, and we had taken all patients with PTA average of 25 dB, below 25 dB as normal. Then autoacoustic emission we had done at we had done the DPOAEs were assessed at 2000, 3000, 4000 and 5000 hertz, and we had done both the signal to noise ratio and the amplitude. So sample size, we had taken a sample size with reference to a previous study by Tan et al. We calculated the sample size to 106. We had 2 groups, the age group, that's the healthy group, and the C19 group, that is the COVID-19 affected patients. We had 53 patients in each group. So after collecting data in structured questionnaires and doing the audiological assessments, we had put in our input into the Microsoft Excel, and using unpaired t-tests, we had done the statistical analysis to compare the 2 groups, and the p-value less than 0.05 was considered significant. Now coming to the results, a little bit about the demographic. The median age of our patients was 29.36 plus minus 9.6 years. Gender, they were mainly female patients. There were 60% female patients and 40% male patients. And the health background, there was no significant pre-existing health issues. So now coming to the results, on comparison, we found that comparing the pure tone audiometry, we did not find any significant hearing loss. As you can see in this graph, there was no difference on the right side PTA of the patients, and even on the left side, except for a little bit of difference in the 250 Hertz, the rest was more or less, there was no significant difference. Then coming to the distortion product, autoacoustic emissions, that's DPOAE. In the right side also there was, the right side signal to noise ratio, there was no difference. And the same was with the left side DPOAE. And then coming to the amplitude also, we did not find any significant difference, both on the right side DPOAE amplitude and the left side. However, we did find some differences when we compared in the test groups, in the patients, among the patients, we did find a male preponderance and also a poorer DPOAE in patients who had prolonged symptoms. So in this is a table showing the comparison between the males and females in the test group. We found that there was a amplitude difference in the right 3000, left 2000, and left 4000 amplitude, DPOAE amplitude. And similarly in short C19, that is patient who had less than 7 days of symptoms and patient who had more than 7 days of symptoms, we found some difference in the right 2000 and 3000 and right 3000 DPOAE signal to noise ratio. When it came to patients who, who were vaccinated, we did not find any evidence of hearing loss linked to COVID-19 vaccination. Now coming to the discussion, after going through literature, we found that there were varied results across studies. There were some studies like by Mustafa et al., Mehmet et al., and Osturk, which found no significant, significant hearing loss, but only in the higher frequencies. Overall, they had normal hearing. And systemic reviews, there were some studies which said there were hearing loss, tinnitus, and dizziness, but still the results were inconsistent. And Dorobis et al. Also said that there was sensory neural hearing loss, but there were other studies like Bhatta et al., Maharaja et al., and Broad et al. Who found no significant changes. So these were similar to our audiological findings, these which showed no significant hearing loss. When you compared the severity of the disease, that is symptoms more than 7 days, we found some differences, as I had shown you in the earlier table. This was inconsistent with Young et al., who had found similar findings. And then when it came to gender, males showed poorer DPOAE, I had showed you earlier. That was something which was new in our study. We had not found this in any other in literature. However, Matsuga et al., they found that the number of patients who had, male patients had more hearing loss during the COVID period. So the potential mechanism could be hypercoagulation as suggested by Tan et al. Then there could be ischemic effects, that is ischemic events after binding to ACE inhibitors. This is more in favor for our findings also because ACE inhibitors are more common in males. It has been genetically proven. So that may be one reason of some of our findings. Then there were others who suggested that it could be due to damage to the cochlear hair cells. So the further research and recommendations, while our study did not find any significant hearing loss, but we still found some differences in the male gender and in patients with prolonged COVID-19. So that could be an area we could search more. So we recommend that screening of COVID-19 patients should be done for hearing as well. Thank you for your patient listening.
Thank you, Dr. Zarin, for the nice presentation. Now the last speaker, we will give time to the last speaker, that is Dr. Jyotirmoy Sharma, the topic on concept of otology in Ayurveda. You may kindly take the time. I hope the speaker is around. Please, yeah.
Om Dhanvantaray Nama. Namaskar. Respected chairpersons and very accomplished dignitaries of ENT present. Should I go to that side? If I Before I begin, it's a privilege and honor for me to be here as an invited speaker. So I am thankful to NEBAOICON as well as especially to the ENT surgeons of Shivsagar. For the last 13 years I have been presenting free papers. This time I am getting the chance to present an invited talk, so I am very much grateful. What I have done in my paper is I have collected the different references connected to otology from the various texts of Ayurveda, and I have tried to correlate in modern terms. This was not possible, it was not an easy job, but I have tried to correlate as much as possible. There may be some mistakes and many things might be almost impossible to present in terms of modern otology. So my paper is about the references of otology, that is Karna Roga, mentioned in the Ayurveda literature. It's inappropriate for me to speak about otology in front of all of you. I'll jump to Ayurveda. Yeah, the physicians of Ayurveda had rich knowledge about diseases of ear, nose and throat and head and neck, like other parts of the human body, even more than 5,000 years ago. And this has been included along with ophthalmology and dentistry in the branch called Salaikya Tantra. So Salaikya Tantra is one among the 8 original folds of Ayurveda. It is mentioned in the oldest literatures of the system. Over time, otorhinology, ophthalmology and orodentistry have been able to establish their separate identities, as I am now representing in the otolaryngology people along with them. And Ayurveda has also undergone tremendous modernization into many subdivisions in the line of its contemporary medical science. Otorhinolaryngology and head and neck related topics, they have been included under the subdivision of Karna, Nasa and Kantha Roga of Salaikya Tantra, and the otology part can be embodied in the Karna Rogas. Coming to history, if we see the Vedic Kala in the Vedas, that is pre-Samhita, before the Samhitas were written, that is 6000 BC to 1000 BC, in the Atharva Veda, we find mentioning of some diseases of otology. In medical terms, like otalgia, tinnitus, deafness, otoria, these have been mentioned in the Atharva Veda in different Sanskrit terms. And also some plants have been described to treat diseases of ear. This is etymology of the Karna, because otology is Karna Rogas. Basically, if we see the definition, it is about relating to hearing. So mainly the function of ear has been deemed to be that of hearing. These are many synonyms of Karna. We can see most of them are associated with hearing only. Sravan Indriya, that is the organ of hearing. Embryology have been told under the heading of Karna, Garbha, Bakranti. And I have got references from Susrut Samhita, Sarak Samhita, etc. Anatomy of ear has been studied under Karna, Rachana, Charir. And these are mentioned in all the major classics of Ayurveda. So in the Karna, Rachana, Charir, Pancha Mahabhuta have been told, and among the 5 Gyan Indriyas, that is sensory organs, this is important, Karna is important. It is one among the 9 external orifices of the body. Location of the Karna has been told, it is said it is 5 angula, 5 fingers from that of the lateral canthus. As such, it is nije curious. As such, different measurements have been told. That is, the measurement of the ear is 4 fingers. Different parts have been told. Karna saskuli, we mean that the whirlpool shaped part of the ear surrounded by helix. Karnapali may be ear lobule. Karna latika again may be ear lobule. Karnapit may be the bottom of concha and base of ear. Karnaputrak may mean tragus and pinna. Karnaprustha may mean the posterior part of the ear, that is mastoid portion. Karnamula means the parotid region. Karna Sidra, Karna Srota and Karna Vivara, they means the external auditory meatus. Sabda Baha Srota, the external auditory canal, as well as internal auditory meatus. Sabda Baha Nari may mean the cochlear nerve. Karna Asti, cartilages of the pinna. Sira means the veins of the ear. And Dhamani either means arteries or nerves of the ear. Vital points have been told, we call that marma. Sankha marma, Vidura marma have been told in relation to Karna. It is said there are 2 pesis, that is muscles, and only 1 sandhi, that is joint in ear. Prasasta Karna Lakshana, features of well-developed healthy ear. It is said a person whose ear is like this, they will live a long life without diseases. So the ear should be thick, large, smooth from back, equally elongated to lower side, bent from back to forwards, well-developed, and the hole should be large. This is told by Sarak, Acharya Charaka. If we see Karna Sarira, that is means the physiology of ear, most texts have said the hearing is the main physiology of ear. And this is again, if you see Srota, Buddhi, Sabda, etc., everything is related to acquiring the sound and the knowledge of hearing. But we also get a mentioning that Disha is the Devata of Karna. It means the deity of Karna is the direction. This might means the knowledge of ear in relation to equilibrium, maintenance of balance was also known at that time. So they said the direction is the deity of Karna. Nidan and Samprapti, we means the various etiological factors for ear diseases. So I tell only modern terms: exposure to cold, swimming, itching and giving injury to ear, unskilled instrumentation either by the doctor or by the other persons, exposure to noise and sound pollution, trauma in ear, rhinitis and related diseases of nose and oral cavity, chronic systemic diseases, congenital factors, infections, ototoxicity. All this I can correlate in terms of modern otology, autoimmune disease as well. Types of Karna Roga, Acharya Susuta has mentioned about 28 types, and some other Acharyas have mentioned different types. So these are the various types. I can correlate them as otalgia, tinnitus, hearing loss, otorrhea, itching in the ear, wax, perforation of tympanic membrane, fungus or any pathogens, this bacteria, virus, etc., furunculosis, suppurative otitis media, abscess in ear, oral polyp, edema or swelling, tumors in ear, and some diseases of external ear related to pinna and external auditory canal have been mentioned. Samanya Karnaroga Sikitsa, what are the different measures for treatment of ear diseases? First is we should avoid all the etiological factors. Oral intake of ghee has been advised. We should take ghee with lukewarm water. Rasayana is a special Ayurvedic treatment with antioxidants properties. They have been advised. We should avoid excessive strain and take rest. Avoid head bath. Sexual abstinence. Avoid excessive talking. Some specialized local therapies have been advised where we remove wax or any foreign body, dry mopping, fumigation of the ear canal, dusting of medicated powder, filling of ear canal with medicated oil or liquids, medicated smoking, as well as some surgical procedures. So these are some of the local therapies. Karna Vyadhan is a sanskar which was told in Ayurveda. It is now also performed in the Hindu. It is one of the 16 samskaras performed in the Hindu traditions. Unfortunately, in the male it is now stopped mostly, but in the females it is being done. Even foreign countries are doing this. Should be performed in the 6th or 7th months, but again can be delayed. Karna Sandhan, Acharya Susuta was the father of plastic surgery, and he said about otoplasty, how plastic surgery of the ear was done, specially for diseases of the external ear. Alongside, he also told about rhinoplasty and plastic surgery of the lips, etc. He said 15 methods of reconstruction of the ear, that is Karna Sandhan. In the conclusion, the physicians and surgeons of ancient India had good knowledge about diseases of ear. Anatomical knowledge of the ear was mostly restricted to the external ear and middle ear, might be because of absence of your sophisticated instruments like endoscope, microscope, etc. Many of the corner rogas I have mentioned are only chief complaints in context of modern otology, like Karnasula is only otalgia, Karnasraba is only otoria, rather than any diagnosis. This may be attributed to lack of sophistication at that time. Embryology, anatomy and physiology of ear in Ayurveda is difficult to be interpreted in the light of modern medical science. Also, it's not correct to correlate all the Karna rogas in modern times. Although many of them have been done, might be many diseases have got eradicated and many new diseases have appeared over the years. Etiological factors and thus preventive measures and principles of treatment have many similarities with those of modern otolaryngology, and large variety of Ayurvedic medicines are time tested and yield desired response when properly administered. Similarly, various types of local therapies for ear are not only beneficial but also curative. We have limitations in the surgical technique. Having said so, Sandhana Karma was explained by Acharya Susuta, and he is considered as the father of plastic surgery globally. Karna Vyadhan is prevalent in modern society, both as a tradition and also for ornamentation. Ayurveda says Karna houses the vital srotra in the organ of hearing, and it is important for Sukh Ayu, that is happy living. As such, ear should be always protected for having a happy living. Bulk of the ear diseases can be attributed to lifestyle, occupation as well as environmental factors in modern industrial world. The age-old teachings of Ayurveda for proper lifestyle, that is Dinacharya, Ratricharya, Ritucharya, Paitha and Yoga, these all can help prevent Karna rogas in many ways. As the first and foremost aim of Ayurveda is Swastasya Sasta Rakshanam Aturasya Vikara Prasamanam. That is, in the healthy we should maintain the health, and only in the disease we should try to cure the disease. This is God of Ayurveda, Lord Dhanvantari. On 29th of October, Dhanvantari Jayanti is there, which has been declared as National Ayurveda Day. I welcome all of you to Government Ayurvedic College on that day. Thank you.
Thank you, Dr. Sharma, for the interesting presentation. I'm sure most of the delegates are not familiar and aware of the topic, and I'm surprised, but it's interesting to know that Ayurveda is also having an extensive study on otology. It's interesting to know. I'm sure many of us will be learning more in the days to come. We have come to the end of this session. Now over to the management. Yeah, there will be a time for question and answers, if there is any.
As there is no question in this round, so I think we can conclude this session and hand over the mic to the organizers.
Yeah, we are directly going for felicitation. And whoever has question, they can directly ask the speaker after, whenever they are free. So I ask the speaker to come forward for the felicitation, and I ask the chairperson to felicitate the speakers. Speakers, please come forward to the felicitation corner. Dr. Nilotpal Datta, Dr. Anjali Barua, Dr. S.N. Mukherjee sir, Dr. Bhavan Chaudhary, he's not there. Then Dr. Supriya Sintham, Dr. Monish M. Chetri, Dr. Zareen, Dr. Jyotirmoy Sharma.
उसके बाद जब ये वीडियो आएगा ना तो मैं इन्वेस्ट करके यहाँ पे डायरेक्ट वीडियो खुल जाएगा। कहाँ से डालने का? डालना नहीं है, यहाँ से डायरेक्ट प्ले कर सकते हैं। आपको कौन सा वीडियो चलाना है? मैं सबको सब पता है, मेरे को दिखाई नहीं है तुम लोग क्या कर रहे हैं। सर कट मत करिए, डायरेक्ट यहाँ से पीपीटी खोलिए। हाँ वही पहले फर्स्ट वीडियो इधर किधर है? वीडियो ये वाला इधर ही आएगा। ठीक है, अनाउंस नहीं किया है। तो अभी ठहरेगा। अभी जो कॉपी किया इसमें है ना? हाँ इसी में होगा। इसको कॉपी कर दो तो 1 नंबर 2 नंबर कितना बजे आएगा? तब बाद में आएगा। उसमें लोड करेगा, आएगा डिलीट कर देना, नया से रखना।
I request Dr. Professor Hiranyabara to felicitate the chairperson. And the postgraduate students who are allowed to join the quiz are the trainees. PGT means trainees, postgraduate trainees, not those who passed their MS. PGTs from AMC, please give your names for the quiz. We are now going to start the session of sponsored by Sanofi. It is the rhinology session. I request the chairpersons, Dr. S.B. Fukan, Dr. Biman Fukan, and Dr. Milan Kumar to take the chair. The first speaker of this session is Dr. Pradul Hajarika. He will be talking on face, when it started, what preceded, and where it is going, our experience in Manipal and beyond. I request sir to come over to the podium.
Very good afternoon. We three had been entrusted to share the session. Actually, Sanofi is a multinational company, mainly deals with allergy. We have got first 5 sessions. I think Dr. Pradul Hajarika's session is for 20 minutes, I think, no? Others are 15. Am I right? Yes. 20 minutes. Pradula, your time is, though you are son of the soil, still your time is 20 minutes. And I think the first paper also interesting, the last two was very interesting. I'll tell. Actually, Dr. Pradul Hajarika is from Shivsagar. He is the son of the soil. When he has done the MS, I was in Dibrugarh house surgeon. And he very jolly guy.
Yeah.
And we have enjoyed a lot in Assam Medical College also, with Kailas Datta, you, Midullas, and everyone. But after he is nice giving MS examination, Professor Santosh Kakar has taken him to AIMS Delhi. And he has done 2 years field audiometry. Am I right? Actually, make the CB like that. And after that, he has been posted to Manipal, Kasturba Medical College, Manipal. After that, he has not seen behind, always forward, and became the HOD and director of the PG studies of Manipal. He has got many awards. 9 and after actually, yesterday in cochlear implant session, I mentioned in Mohan Commissioners in 2020, I think you also do not know. Then he is the first man to put the cochlear implantee in South India.
That's true. That's true.
And though Sandra D'Souza was the first from Mumbai. And after that, he finishing all the studies. He has got a nice group in Kasturba. And after that, he went to Kuwait and many places. He is a great personality. Though the organizing committee has not given me any CB, I made your CB of my own. Thank you. I think you will start.
Thank you very much. This is what I am going to talk about, is overview of endoscopic sinus surgery. What is the scenario and what was the scenario. So what this is basically, it also want to inform you that we are the Manipal Center, is the first center to introduce the endoscope in sinus diseases. So this is when we started and what proceeded and what is going to be in our experience in Manipal and beyond. We started this endoscopic sinus surgery in Manipal in 1988. There are a few more people along with me. There's a Professor Rajamarajan, PNS Murthy, who is a very active member of AOI, Dr. Nayak, Bala, and Dr. Anand. So we first workshop we conducted in 1993, and first manual we brought it out in 1995. So this is the first manual introduced, showing the different technique of doing the endoscopic sinus surgery. When we conducted the workshop, initially we start with only the head part. So then I realized, once you give only the simple head, you're doing the surgery with endoscope, you don't have the feeling of a surgeon. Then switch over to the full body, where you can have an experience with that, and you get a better knowledge about it, anatomical structure. How we have started. So what has happened, I'm very fortunate in a sense. Our neurosurgeon and me are very close friends. And he also wanted to start that transseptal hypophyseectomy. And he has asked me to help him to do the septoplasty. And with septoplasty, we did microscopic septoplasty. I never used to go for other things, do the elevate, remove the vomer, and expose the anterior of the sphenoid and give it to him. So that is one thing. Then microscopic identification started before endoscopic identification. The second thing is what we have done with the CT scan. When people come to our hospital, we ask for a CT scan, it becomes very expensive. So many of the people refuse to undergo CT scan for a sinus disease at that time. So we requested the management people to subsidize that cut and get a less cut in the CT scan. Then we got a many number of patients, and that helped us to develop the center. We are first person to start that bipolar while doing the endoscopic sinus surgery. I still remember I was invited to the CMC Vellore. I gave a endoscopic sinus surgery demonstration, just a simple fast, and I'm using the bipolar. From the audience, people are, "Oh, sir, what are you doing?" I said, "What happened?" He is going to develop synechia, develop atrophic rhinitis. That I just told you, don't worry about it. You just have a look at the procedure, how bipolar helped us. Then we have started using KTP laser, an introduction of drill and bar, drilling that hard bone, vomers and all, we used the drill. Then, of course, we have to use some ablation. What preceded is DNA, and first we started diagnostic endoscopy, then middle metal antrostomy, then swiftly go over to septotribunoplasty, then endoscopic excision of DNA, then CSF rhinorrhea reduction. We are the first people to start the CSF rhinorrhea after Kitani from Bombay. He also has come and all. You got quite a good number of CSF rhinorrhea repair endoscopically, and control of nasal bleeding, endoscopic rhinoplasty. One of our own faculty member is George Varghese in Cochin. He is doing the endoscopic rhinoplasty. Endoscopic odontogenics we have done in Nemcare Hospital. We have done a very new technique of calcifying odontogenic tumor, dental tumor, and we published in the European Journal of Allergy and Allergy and Nose Diseases in 2023. Then endoscopic management nasal fibrous dysplasia. This is sometimes very difficult. Dysplasia was a middle turbinate. Endoscopic ligation of then showing some of the videos, very fast video, just to show that this is odontogenic cyst, which is done in Nemcare Hospital with endoscope. Nobody else has reported the endoscopic excision of the odontogenic cyst. Next. This is what is angiofibroma. Angiofibro endoscopic removal in the 20 years back. We have done that, and we have used the laser. You can see the tumors. We are cauterizing bipolarly, middle turbinate, excising clearly without having much of a bleeding, and remove it, then expose the tumor well, then use the bipolar or laser to reduce the bulk and slowly remove the tumor. You can see that we are Now we are removing, cauterizing the secondary attachment of the tumor around the nasal cavities. And this you can see the center of the tumor has been vaporized with a laser, KTP laser, reduce the bulk, the size of the tumor, and you can easily deliver it out. Then, this is timeline. We can go to the next. Okay. Yeah, there's anything in these. This is what. This is endoscopic repair of the CSF rhinoria. Here also, most of the time we divide the middle turbinate, not excise it. And you see that. So this will give a better view, and they sometimes do the uncinectomy also, so that you can see there's the roof. You can see that. And once you do that, you can see the leaking in a vague way. There are so many places it's coming, and we do the surgical, we need abdominal fat, we need gel foam, we need fascia lata sometimes. So various material are using. This is another patient of CSF rhinoria. This is exercise. You can see that it's coming, that fluid is coming from there. It is a sphenoid. The roof of the things, and remove that thing, you can see the whole big fistula here, and it is leaking. Is anything? Here is the graph. It is the temporalis fascia. It was done 20 years back, and it was published in American Journal of Otolaryngology. This is a meningocele. You can see the meningocele, the white one. Here where the fistula is very big, while repairing you have to take a septal cartilage. Bipolar helps a lot to reduce the bleeding. This is the cartilage, septal cartilage. We are taking that, putting that. It is a composite graft. Then put the fat. This is the sphenoid. You can see that it is coming from their post-operative patient of endoscopic sinus surgery, developed the fistula from the sphenoid roof. Then I mean, one thing is very interesting here. When you identify the fistula or CSF leak area, it is not necessary to do an extensive mobilization for a flap, and most of the time you cauterize a little bit of elevation of the mucosa around and give a proper packing, it will stop. Yeah, an innumerable number of grafts is putting there next to this. Next to that. I did take one to there. It's mother and me. No, video. What is that? This is the fungus. This is one of the worst things one can happen to the rhinologist. The fungal, extensive fungal disease of the, recurrence of the ethmoid and the sphenoid and frontal and all. And this is a Nigerian patient, and he was operated 3 times before. And unfortunately landed at our hospital in Abu Dhabi, and I did this job, and you can see the amount of fungus one can have. I never seen in Manipal, I have never seen in now Nemcare hospital this kind of fungus. In the time of COVID also, I have never seen that. It's extensive disease, but the worst part in the fungal disease is that you keep on bleeding from in the area. So one has a lot of patience to remove that. I say one more thing, what you realize, how do you prevent so much of bleeding while doing the fungal sinusitis? They used to always use the warm water saline, irrigation, irrigation, irrigation. Then there's the suction. So irrigation is the best way in addition to your bipolar cauteries. So the problem is that if too much of bleeding, there's every chance that you may end up with a problem. complications. So to avoid that, your irrigation, debrider, and suction, these are the two things you should have with you. Next slide. This is endoscopic septoplasty, done in Nemkar Hospital, Guwahati. Here you can identify that vomerocartilaginous junction, make a small incision, not necessarily need a knife, you can do it elevator also, and this elevate the mucosa and slowly take it out, the deviated part, and this extra, this is a complication will be much less. It is very good procedure, endoscope to do the septoplasty. Okay, next. Go back to the P. Yeah, next. Yeah. Okay, we go to the next list. Then a few of the very interesting complications, I don't know how many of you have encountered. So one of the worst complications that I have encountered in Abu Dhabi, one Lebanese young girl, he has gone to almost all the hospitals, where somebody recommended my name for the, it was for the septoplasty, I think. It is a septoplasty. So what I did is everything went on so well endoscopically. Then what has happened when you went for a round in the afternoon, you could not recognize the lady. The whole head was fallen up and everywhere is a surgical emphysema. I was just wondering how it has happened. There are two possibilities that, something leaking there in the nasopharynx or something like that, so they lead to the leaking. Then it is a big procedure and their complication in foreign country is very, very difficult. Then we take a CT scan. The CT scan shows that posterior wall of the trachea have been eroded while intubation. So that have to lead to the so much of emphysema. I can see the chest wall everywhere, emphysema. But fortunately with conservative treatment, we could manage it very well. But patients understand what is the problem and explain. But this is a very, very unusual complication. I think the literature only 2 or 3 cases has been published. One of mine, it has been published, this one, just for awareness of the endoscopic surgeon. This is, this is the guided, video. This is a fast forward. It was done in Abu Dhabi in my hospital. You can see that is image guided endoscopic sinus surgery. It's very expensive equipment, but if you have it, probably be more, more courageous to do the extensive job without making much of a complication. Next. और कहाँ है? नहीं और ठीक है P. Now this is skull-based surgery. When we started in Manipal, we never used to use the endoscope. Everything, open technique, and we extensively remove everything. But now it is slowly replaced by the endoscope, and the skull-based surgery, so many places you can go with endoscope. It is a very successful outcome result on performing the post-operative procedures, and endoscopic surgery has greatly reduced the mortality and morbidity. Endoscopic surgery is cosmetically acceptable and cost-effective. It is a very nice tool to do the skull-based surgery. Now where are you going? We are going to now robotic surgery and artificial intelligence. This is robotic surgery, and this is we have done in this. Yeah. This is an extraluminal foreign body. You can see that there's a big one here. And this we have done all clinical examination, even X-ray, CT scan, we can find it out. Then it is endoscopic surgery. Robotic intelligence, it found out the tube there. And it is yeah. This is done in Nemcare Hospital by the radiologist, doctor, and they could locate that hidden, it was lying somewhere here. You can see that they have rotated to different places because it was extraluminal. That's why. Then they located by, you can see that, leveling different places, and ultimately they found it here. You can see that the foreign body, extraluminal foreign body here. Next. PP. Okay, so this is it's a new horizon, and it is going to come in a very big way in the future in the practice of ENT surgery. In the summary, initial goal of the functional and endoscopic sinus surgery in the treatment of sinusitis are to enlarge the sinus ostium, restore the adequate aeration of the sinuses, improve the mucociliary activities, and now, however, it has gone beyond to the skull base, exploring the unexplored and researching new technique. What is the research? Research is seeing what everybody else has seen and thinking what nobody else has thought. Also, it is a research means that you do not know, but you are willing to find out. So this is the thing you can research, go to find out the proper things, and if you keep on move, you put on rolling around, and once you find that your things what you're looking for, and that one put it in your place, then publish and use it for your benefit. Thank you very much. Hopefully, it is not a hardcore research paper, but just what is the overview of the endoscopic sinus surgery, where I am standing, where I'm going to go. Thank you very much.
Thank you very much for your journey on endoscopic sinus surgery and some cases, starting from Manipal to Abu Dhabi. But it's a nice presentation. I think the question. You can take the question. I think any questions and 2 questions. Guest lecture? No, I do.
Okay.
There is an announcement from the food committee. We are going to close the dining hall for lunch. So if anyone left out, we can go and have.
Any question? If there is no question, I will conclude the session.
Next speaker is Dr. Rupanjita Sangma. She will be talking on the topic reducing incidence of recurrences in nasal mass.
A very good afternoon. I would especially like to thank the organizing committee for giving me this opportunity to present a paper. So my teachers, they are here, or my seniors, my colleagues. So, okay. So thank you so much for this opportunity. When we first, just a minute. When Rinkuba told me that I've been asked to present a paper, I just randomly gave her a topic, reducing recurrence in nasal mass. Then I thought, what would I say? So I thought that better I have a retrospection of my own work. This is just a representation of what I've been thinking. So I thought I would just retrospect what I've been doing on nasal masses. So actually it's the cartoon on the left is a representation of how long it takes to acquire new skills or knowledge. Before I start my topic, I would like to read a quote which is, I think, applicable for all, at least for me it is. So regardless of what we discover, we must understand and truly believe that everyone did the best job he or she could, given what was known at the time, his or her skills and abilities, the resources available, and the situation at hand. So everything together, we can move forward. So maybe when I started, I did not have the skills. I did not have the resources, what were actually needed. So slowly, of course, I think I have improved a lot on myself if I go for my retrospection. So my first case of FES, so to say, was in 2008. So I had just done a hands-on training with under Dr. Kirtane sir. So I was all like, yeah, I could do FES for everything. That was what I was thinking. So the question that comes to mind when you start your journey with the nasal masses is, which is the nasal mass which is most notorious for recurrence? So I think for everyone what would come to mind is ethmoidal polyps. So we think that ethmoidal polyp is really notorious for recurrence. But as we go along, let's see what we really end up with. So my first patient, there. 46-year-old female, she had a right nasal mass, and on CT scan it was diagnosed to be a antroconal polyp. So I did a FES in 2008, and bang, on histopathology it came out to be inverted papilloma. So, but still my confidence level was quite high. I thought I had done a very good job and the patient won't come back with recurrence, and interestingly she is a known patient to me. She attends the same church as me in Guwahati. So I was waiting. I thought maybe she won't come back with a recurrence. But then this was inevitable. She came back with recurrence in 2014. So she had faith on me. I did a medial maxillectomy. And till date, she is free of disease, doing well. And I meet her whenever I attend the service. And she's quite happy. So thank God, at least the second operation was okay, and she's doing fine till date. Okay. So my next case, I was a bit more wiser this time. So my next case came again with a unilateral nasal mass, looked like a polyp, and on CT also they reported it to be a antroconal polyp, but then I did a punch biopsy and the report came out to be malignant melanoma of the maxillary sinus, which is I think quite rare. This is the only case of malignant melanoma that I've got till now. So, so this time I was well equipped, and so we planned for a near total maxillectomy. We spared the zygomatic arch and the orbital plate, and Dr. Jutima Fukan, he along with Dr. Jutima Fukan, we did this case, and later on the patient was given an obturator, And she was doing fine as long as I was there in Guwahati. I had a follow-up. Till 5 years she was doing fine. After that I lost her to follow-up. Now, as the years have gone, I have also become a bit more good on archiving. So in the last, say, around 4 years, minus the COVID period, these are some of the cases that I have done, and I have had a follow-up of these patients. So I'm presenting the 28 cases of nasal mass. Among the 28 cases, unilateral cases, I got 19 unilateral cases of nasal mass. So out of that, there were 5 antroconal polyps, and again, interestingly, we usually think that antroconal polyp is only for the children, so in the childhood. But 3 of the patients were under 25, but the other 2 were more than 30. One was in fact more than 50. We did a punch biopsy for all the patients, and in the histopathology post-op also, it came out to be a polyp. For inflammatory polyp was the histopathological diagnosis. Then there were 5 cases of bleeding polypus. Inverted papilloma, 3 cases. Nasopharyngeal angiofibroma, I got 2 cases. One was a recurrent case. The patient was operated twice earlier, and we got it for the 3rd time. Then there was a case of rhinolith with fungal sinusitis. 1 malignant melanoma, which I have already described. 1 case of olfactory neuroblastoma, and 1 case of invasive fungal sinusitis. So 19 cases of unilateral nasal mass. And bilateral nasal mass, ethmoidal polyposis in 8 patients. 1 patient was a case of recurrence done elsewhere, and 1 was a case of non-Hodgkin's lymphoma. Again, a very rare presentation. The patient came with bilateral nasal mass, and on the HPE, we got the result was non-Hodgkin's lymphoma. Then regarding investigations, we did a DNA for all the patients, a CT scan, the one which is done in the college. Whatever slices they do, we take up those CT scans and read those properly as much as we can. And MRI was done specially in the cases of nasopharyngeal angiofibroma. We did a MRI. Punch biopsy, after my first experience, I routinely do a punch biopsy even if it looks like a benign polyp. So, and other relevant investigations as and when required were done. Now I would like to show a few CT scan images of the rare presentations of nasal mass. So this is the CT scan of the patient with malignant melanoma. It was reported as a unilateral antroconal polyp, and then, as I told, it was diagnosed to be a malignant melanoma, and to confirm we did S100 and HMB45 as well, and it confirmed the diagnosis. So this is another rare case of olfactory neuroblastoma. This was again a unilateral mass, and on punch biopsy it came out to be a papilloma, squamous papilloma. So we thought maybe it would be an inverted papilloma, and we did a medial maxillectomy, but later it came out to be on a histopathology it was a olfactory neuroblastoma. The patient was referred. This is the CT scan of the non-Hodgkin's lymphoma patient. This is another interesting case. It's a case of invasive fungal sinusitis. The patient was immunocompromised, and the lesions came up to the skin as well, and the typical appearance of the maxillary sinus of fungal sinusitis. This case, the CT scan is a case with bilateral ethmoidal polyposis, and there's a breach in the lamina papyracea on the left side. We'll come to that later. So regarding medical management, all patients with inflammatory polyps were given pre and post-op systemic steroids. Local steroids in all inflammatory polyps was given. Post-op antibiotics for minimum 3 weeks, preferably clarithromycin was given. Budesonide nasal douching to be continued for all the post-op polyps. So we've got really good results after using budesonide nasal douching. And the patients are counseled beforehand that post-op they'll have to use the nasal douching lifelong. Even if the polyp is not come up, we've asked the patient to continue with the budesonide nasal douching. For allergic fungal sinusitis with rhinolith, the patient was followed up with itraconazole 200 mg for 2 weeks. The patient with non-Hodgkin's lymphoma and post-op olfactory neuroblastoma were referred to the cancer hospital. Liposomal amphotericin B was administered to the patient with invasive fungal sinusitis, which could not be completed due to deranged LFT. She was a moribund patient and immunocompromised. So the patient, we lost this patient because of the comorbid conditions. Now regarding the surgical management, endoscopic excision was done for the bleeding polypus. That's a simple thing, nothing much to be said about that. So there were the 5 cases. Then we did FES on antroconal nasal polyps, 5 cases, ethmoidal polyposis in 8 cases, rhinolith with fungal sinusitis, 1 case, and endoscopic debridement was done for the invasive fungal sinusitis patient, that was 1 patient. And an endoscopic ablation was done for the recurrent juvenile angiofibroma patient. And medial maxillectomy for inverted papilloma, 3 cases, nasopharyngeal angiofibroma, 1 case, olfactory neuroblastoma, 1 case. And a near total maxillectomy for the malignant melanoma of the maxillary sinus. Now regarding complications, the most common complications as of all was hemorrhage. And recurrence, I got recurrence in 1 patient of inverted papilloma. And then orbital hematoma, we've encountered 1 patient with orbital hematoma, and a lateral canthotomy was performed. We lost 1 patient of invasive fungal sinusitis. Now this is a picture. I've put 2 pictures together. The upper one is the patient who developed an orbital hematoma. So, and the lower one is normal swelling which we usually encounter after a FES and after we give an antinasal packing. So I've put these together so that we can appreciate that when the bell rings. So if it's the upper picture, then of course you have to run immediately, and that's what our whole team did. We gave a call to the ophthalmologist, and thankfully she came in time. And in the evening, lateral canthotomy was done, and the patient was immediately relieved of pain. So, and next day, the edema was almost gone. So, and this is the same patient I had shown a CT scan who had a breach in the lamina preparatia. The surgery was uneventful, did everything nicely, did a packing, and I came off. In the evening, my PGT gave me a call that there is swelling. I said, give me a picture. So when they sent me a picture, I knew that I had to run. So actually it was not bleeding, but maybe because of the pressure of the pack. So immediately the pack was removed, and the patient was at least relieved of the pain that he was having. And then after the lateral canthotomy, the patient was fine. So regarding follow-up here, I would especially like to thank my PGTs who did a great job by calling up all the patients. It is very difficult when the patient is, fine. It is difficult for them to call them back to the department and get a endoscopy done. But my PGTs, they rang up all the patients because they had the number. And so in the later cases, I have not had a recurrence till now. But there is still time. This would be around a follow-up of 2 years. There is no recurrence as such, except for the first case which I had, and did a medial maxillectomy. Now she is doing fine. And the important thing is, cosmetically, the scar of lateral rhinotomy is quite acceptable. So I have put a picture of that lateral rhinotomy scar. This is when the stitches were removed. It looks quite well, and that patient which is known to me, who's known to me, she is having a nice scar. I mean, it cannot be made out. So, and the other picture is of the patient who had a lateral rhinotomy. So all the patients done are doing well. And to conclude, the points that I would like to highlight, which I have been practicing, are punch biopsy for all the patients with nasal mass, to study the CT scans properly, MRI wherever necessary, not to hesitate to go for an open approach, that is lateral rhinotomy, and to continue budesonide nasal douching for polyposis, for all cases of polyposis, and steroids to maybe a 1 month period, and antibiotics for bilateral nasal polyposis we continue for 3 weeks. So that is regarding the cases which I could collect and have a follow-up. To conclude, another quote: the point of retrospection is to focus on continuous improvement. People who can rely on each other and have the same drive towards technical excellence create best performing teams. So the teamwork is important everywhere in surgical field. Thank you.
Thank you very much. Any question from the audience? Questions?
I may not be able to answer, but anyway, I'm here.
Yeah, excellent paper, ma'am. We have a, in our setup, I don't know, we have a AC polyp has a...
Your mic, I think it's not for,
So AC polyp has a recurrence, highest recurrence is all these
yeah,
cases.
even I thought so, but I don't know why they have not come back. And we've been inquiring actually over phone.
Ma'am, do we adopted any
Yeah?
surgical techniques? Do you have any adoption of surgical techniques, different
Surgical technique, I try to clear out like maxillary sinus, enterocornal polyps. It is best to use your 30 degree, 45 degree to see up to the base of the maxillary sinus. Each part has to be removed. You cannot leave behind any polyp. That is what I practice.
Yeah. So what we have found that I have a video also. I don't know this because of the height. I have a video also, ma'am. What we have found when we approach with a medial maxectomy expose or enterostomy wider. Hello, am I audible?
Medial, just a minute.
Not medial maxectomy.
Yeah.
I am going for an extended enterostomy. If you go, then it is very difficult because you see the most of the polyp originate from anterior thread and most probably anterior wall, and it's very difficult with our so-called forceps also, or also with the...
It is difficult, but then what you can do is you can put in your suction. Ball suctions we have, put in the suction and then you can pull out the polyp.
Still, I think we have left some attachment there. That's the cause of
recurrence.
Recurrence.
As of now, AC polyps, I haven't got recurrence.
AC polyp has a less recurrence rather than ethmoidal
AC has
polyp.
less recurrence.
Less recurrence. And
Ethmoidals have more.
And
For ethmoidal polyposis, actually, I haven't done full house FES for all the cases. Only those where all the sinuses were involved, there only full house FES was done. Otherwise,
yes. Madam, but we have AC polyp recurrence.
The allergic polyposis is a process, not the surgery.
That is why I think budesonide is helping.
Yes, that is steroids is the sole drug to give.
In my observation, I do not know whether it's true or not. In my observation, enterocorneal polyps in children tend to recur more.
Yes, that's correct.
And number one. Number two, I just wanted to point out in your last slide, you said punch biopsy in every nasal case, not in JNA definitely. Not in JNA definitely. You have written,
not in JNA, yes. CT scan gives the confirmatory diagnosis. We do not do, we do not touch, yes. Sorry.
After your learning over the years, have you adopted any particular sort of follow-up regimen for these cases?
Follow-up, that is what, it is really very difficult to follow up the patients. Actually, when my PGTs, they were calling up the patients. One patient was from Dergaon. So it went to the limit that she was calling up the patient again and again, and at one point of time, the patient didn't pick up the phone, gave the phone to his wife. So he did not want to come up. And another patient from Arunachal, she also did not want to come up. So it's like, she did not want to travel.
Follow-up is actually a big problem
Yes.
in our scenario, but we have been trying to sort of educate the patient in the very beginning, especially inverted papilloma,
Yes.
nasal polyposis. We have structured a follow-up just like malignancies, post-operatively every 3 months for the first year, every 6 months for the next year, then every year for 5 years. This what
That
we are
regime
doing
is
nowadays.
always there, then the patients hardly turn up.
What the best technique is pre-lacrimal approach, endoscopic.
Thank you, sir. I'm about to say, we recently adopted in every recurrence cases the pre-lacrimal approach. This is a very good. It's designed by Professor Harvey. I can go to the YouTube. He has a very good demonstration of pre-lacrimal. Thank you, sir.
But my comment is the main process is, but you have used clarithromycin for 3 weeks. That means that polyp may be neutrophilic. If it is eosinophilic, doxycycline works better. And another thing is that you give a pathway. You put your patient, I think, put a very nice steroid spray.
Yes.
Therefore, there's a main steroid. And
Not
nothing.
only sprays, we ask them to do douching.
Douching do you surely?
Yes.
Your malignant melanoma case is very dangerous actually.
Yes, that is
I have got in the wrong back and nose.
Huh.
Ultimately, patient died.
Actually, back to back, I got 2 cases of malignant melanoma. One was this maxillary sinus, and then another one of submandibular gland, malignant man. That's also very rare.
I think we'll conclude. If any question? No. So
Actually, nebulizer means over the years, like initially I used to give 1 liter of NS and 7 respules of budesonide.
Yes.
Then improvised it to 500 of normal saline with 4 respules of budesonide. And now that naso wash that comes, so 200 ml, 2 ampoules of respules. So that is easy for the patient. Thank you.
Thank you. Thank you very much.
The next talk is by Dr. Kalpana Sharma on the topic Navigating the Facial Pain Particles.
Good evening to all. First, my thank you note to the organizers for giving me the opportunities to stand before you, to stand before all the allied delegates, and to speak about.
by the way, she is a professor in HOD of the Guwahati Medical College. Is a customary actually when some speaker speaks in a platform, and she is very academic, and she is a cochlear implant surgery also, and very interested in thyroid. Now, Kalpana, start.
So being in medical college, we sometimes need to do all the surgeries, not about the ear, not about the nose, but what we have seen from right from the beginning. I'm sitting here, listening to all the lectures. This is one condition you must have heard in all the speakers speaking. Even the last speaker, she told you about the hematoma of the orbit where you are getting the facial pain. So this is one subject we are just ignoring, we do not know. This idea came to my mind when my registrar, Dr. Rijuana, who has got a prize in this NEBAOICON, she came to me one day. She told me, there is a lady, ma'am, I don't know what to do. She has facial pain. All the time she comes, we are giving too many things. She has gone to a dental surgeon, but it is not going away. Now I have referred the patient to the neurology. So this is the idea came to me, why not we study the orofacial pain? So anyway, the pain is a sensation caused by a noxious stimulus. And from the face, this is transmitted through the spinal tract of brain to the spinal tract of brain. And it is mainly via the trigeminal nerve. So here who are sitting here, everybody knows about the trigeminal neuralgia. That is the first thing comes to our mind when we talk about the facial pain. So apart from the trigeminal tract, the few fibers are going through the 8th nerve, 9th nerve, 10th nerve. And even the facial nerve also carries the pain sensation. So when we see the facial pain, sometimes we are getting a very sharp pain which is caused by the superficial structures of the pain, and this is innervated by the myelinated nerves. The deeper structures of the face tend to be very dull and poorly localized pain, and these are because of the non-myelinated nerves. So problem comes to make a diagnosis. In our mind, we need to frame the thing that there is a different causes which are causing the facial pain. So we are getting few conditions which are commonly giving rise to the facial pain. The first thing comes is the rhinological conditions, then the dental conditions. It can be a vascular condition or the neurological. Then it can be a pain caused by a tumor, or there is a mid-facial segment pain. This is very interesting. We don't get anything, but all the time the patient tells us about the mid-facial pain. Or there can be some atypical pain. So to evaluate the patient, the history taking is very, very important. So in the history, we are supposed to see what are the medical problems the patient is having. There, including from the chronic diseases like diabetes, will go up to the dental history. The chip complaint and the pain history. This is very important to take the pain history in elaborate way. So what we see is that many patients, they go to the dental surgeons first, second, third, fourth. When they don't get the benefit, then only they come to the general practitioners or to a ENT surgeon. The pain history, when we are taking it, it can be, we are supposed to go for the quality, whether it's a throbbing type of pain, whether it's a burning type of pain, whether it's a shock-like pain. Then we go for the duration. That means how many episodes the patient is getting. Then the site affected, like any other disease, we'll go for the site affected, then the precipitating factors, or if there is any relieving factors. Along with the pain, we'll go for the associated symptoms like lacrimation, vomiting, nausea, rhinorrhea, photophobia, or fever. Then we need to inquire about the previous investigations, what are being done. So that way we can avoid some of the investigation already been done by the patient. Then the previous treatment, this is very important. Then effect of pain in the daily life. Physical examination in a facial pain is easy. We'll see the intraoral examination, we'll do it properly, we'll do the nasal examination, we'll do all the head and neck examination, giving importance to the TM joint, and we'll do all the cranial nerve examination. Then the question comes, is it necessary to go for any imaging or investigation, special investigation? According to the patient history, that is why I said the history taking is important, we'll go for the special test. We can go for the nerve conduction test, we can go for electromyography, we can go for CT scan, MRI, or the bone scan. But that will depend on the patient history. So once the history is taken, when the physical examination is done, the first way will go for the classification of the pain by origin. That can be a somatic pain, that can be a neurogenic pain, and that can be a psychogenic pain. So the neurogenic pain, it usually comes from the somatic pains, it usually comes from the superficial structures like the skin and the mucous membrane, and it is a burning or a piercing or a localized pain. So this is due to an ulceration over the face. As we have seen many slides beforehand, some pain coming from the ulceration over the face. It is a superficial somatic pain. And these pains are acute, and this is usually localized. The patient can give us the idea where the pain is originating from. Then comes the bone and muscles pain, which is a very dull aching pain. Sometimes this is referred. These bone pains in the facial region, we are usually getting from the TM joint. We are getting from the other articulating structures. Then this can be a referred pain, it is a deep-seated pain, and these pains may be from the eyes and the ears also. So once we can talk about the somatic pain, let us go to the neurogenic pain. The neurogenic pains are usually, is again divided into three parts. It is a neuritis. As we all know, the diabetic neuritis. As we all know, the Bell's palsy giving rise to neuritis. Then comes the neuralgia, which is a trigeminal neuralgia, is a very common thing we commonly speak about. So this can be a trigeminal neuralgia. Post-herpetic neuralgia, this is also an important phenomenon we have to keep in mind when we are talking about the patient. Then it can be a vascular neuralgia, neurogenic pain, which is usually migrainous pain or some, and it is a poorly localized chronic type of pain, this vascular pains. Then comes the important thing, is it a psychogenic one? So this is one factor. In all other diseases, I do not know, but this facial pain, sometimes this factor comes into our mind very first. But before going to the diagnosis, we have to think about other somatic, neurotic, all these things. Then we can talk about the psychogenic pain. This psychogenic pain is a atypical odontologia. This is very interesting. As I had already mentioned, the patient is going to dental surgeons. We are referring the patient to dental surgeons because the patient says, I have a pain, I have a caries tooth, so again referred to a dental surgeon. But this is a atypical odontologia. The actual pain is not there, the patient is being referred to one point to another. Atypical facial pain. So what happens is that the patient gets a mid-facial pain. It's a band-like a pain. The patient says that, suppose a ribbon is being tied tightly over my face. Actually, when you examine the patient, you do not get any findings. No findings in the orofacial region, no findings in the joints, no finding in the teeth and gum, but there is a atypical pain. Then there is a burning mouth syndrome. This is usually happening with chronic diseases. Then dehydration also, sometimes we are getting a burning mouth syndrome. So here I saw some pictures. These are few patients who had given idea where from the pain might come. The first picture I am showing about the infection of the ear. The patient has a tremendous pain coming up to the TM joint. The second picture is it's a gangrene type of ulceration over the ear in a young female patient who had severe intractable pain over the half of the face with, this is the left side, and the left half of the face she had tremendous pain. The next picture, this we can avoid actually. The patient had a trauma, and this is improperly sutured pinna. Because of the sutures are fallen over the cartilages, the patient had tremendous pain over the pinna. So instead of doing something good for the patient, we had done everything wrong. So this can be avoided, so that is why I have kept the picture here. So this is an iatrogenic pain the patient is getting apart from the pain what he was getting from the trauma. This is a small boy who had come to us with left-sided lymphadenopathy, who had severe pain in the left side of the face, who was not able to open his mouth. The patient was taking only liquid. So, but this pain was referred from the cervical lymphadenopathy to the orofacial region. These are the pictures of a patient, herpetic neuralgia. This patient had post-herpetic neuralgia, the patient condition you can see. This is a patient following a cellulitis. There were pictures we had already seen about cellulitis, so they also give rise to pain. So this pain has occurred, this cellulitis has occurred, the patient has used some herbal medication. At this time of the year when we are talking about the skull base and everything, the patient we are getting here with herbal medications. This is another patient with facial cellulitis with herbal medication. So these are some avoidable and awareness program where we need to start the awareness program. The patient was on tremendous pain because all these things has happened to him. This is a patient who had come to us with tumor of the mandible. It was a huge tumor. There was a exophytic growth over the mandible. She had tremendous pain. So this is another condition, that pain occurring from tumor. This is a patient who had shown us, who had come to us with parotid tumor and he had come with tremendous pain again. So we had to treat the patient. First, we had given the antibiotics and all. Later on, the patient had gone for a total parotidectomy. So this can also happen to a patient. These are the patients we are getting in medical colleges. So what to do? This patient also had come with oral ulceration, oral tumors, and whatnot for how long, and he had also very much pain in the face, and first thing he had come to us, reduce the pain. He was not worried about the tumor, but reduce the pain. So these are the conditions we definitely can treat as early as possible. C is a patient who had come to us with PNS tumor with fungal rhinosinusitis. So now we are very much aware of the fungal sinusitis, and we know the pain and the bleeding and whatever we are getting from the fungal sinusitis. Then this is a small boy who had come to us with a foreign body, that's an air gun pellet, in the infratemporal fossa. And the pain and the situation you can imagine. So the key points of today's presentation, I want to say that history taking is the key to the diagnosis of a orofacial pain. And what we think is the sinusitis, but sinusitis alone is a rare cause of chronic facial pain. The sinogenic pain, This sinogenic pain may be intermittent or it can be chronic. The CT scan, when we are doing the CT scan, if we find a mucosal thickening, this is not the conclusive of sinogenic cause of facial pain. Because another thing is that rhinorrhea may be associated with vascular pain, maybe migraine or chronic headache. The rhinorrhea, watering from the eyes, these can be associated with. And many patients are getting benefited by neurological medications. Coming to the drug therapy for orofacial pain, we are using the amitriptyline. Sometimes we are using the gabapentin or pregabalin. Then sodium channel blockers and anti-epileptics are used for orofacial pain. There are some self-care medications that over-the-counter, ibuprofen, acetaminophen. Then people are using the warm or cool compression, whatever is comfortable for the patient. Then antidepressant, muscle relaxant. Some of these drugs are over-the-counter, they can use. Some injections are sometimes given by the doctors, like the peripheral nerve block, occipital nerve block, sphenopalatine nerve block, or these days, Botox therapy is also used for facial pain. The newer thing coming up is a stereotactic radiosurgery. It's a very new treatment. But the thing is that if somebody can localize the exact nerve very precisely, then only one should go for a stereotactic radiosurgery. And the repetitive transcranial magnetic stimulation is one thing coming up in a bigger way with focused magnetic pulses. It is given in the orofacial pain. There are some holistic approaches, like a happy face, tack jaw, brow furrow, eye squeeze, and nose scratch. Because holistic approaches is coming up in a big way in all the medical fraternities. So these are some exercises. These are there in the thing. Anybody can find. There are foods for pain relief, like cherry juice, berries, seasonal fruits, nuts, then darker leafy vegetables, food containing omega-3 fatty acids, and plant-based diet. So these are some nerve pain reliever, while some avoidable foods are there: highly processed food, dairy products, gluten, or excessive alcohol. This can be avoided to get rid of the facial pain. So the best clinical practice is a careful history taking, nasoendoscopy. Given that the majority of the patients of orofacial pain will not have sinusitis, surgery is very rarely indicated. Then one should be familiar with the various medication used by the neurology, OMFS, or the psychiatry. But there are some deficiency. Orofacial pain is a relatively under-recognized, under-discussed subject specialty, and research in the nerve physiology of facial pain is required. A randomized trial, because many people are using amitriptyline, so randomized trial should be there to see the efficacy of amitriptyline, and the psychological aspect of the orofacial pain should be taken care of. With this, I end my session. Thank you.
Thank you, ma'am, for your nice presentation. Now I would like to hand over to the audience if they have got any question.
I would ask Kalpana one question. But facial pain is really interesting and very common in OPD practice. If you know actually how you can give relief to the pain, you are really, it's alarming, but you can give a great relief to the patient and he will never forget you also. But I think it's a very wrong concept for the ENT doctors that all facial pain are sinogenic pain.
Yes.
Very bad.
Yes.
All the people doing face, but no other way, no,
Yes.
nothing. You should not do anything. Because mostly it is a migrainous type of pain.
Yes, that's why I said that's orofacial pain also needs a teamwork. Whenever we are talking about cancer, we are talking about teamwork. When we are talking about the surgeries, we are talking about the teamwork.
Yes.
But here also we need to talk about the teamwork. We should make the dental surgeons aware that all the cases are not your case. The neurologists should also know that all the cases are not their case.
Yes.
We also know that all the cases are not rhinological causes.
Therefore,
so this team should be a proper team.
Multidisciplinary approach is the best thing.
Yes.
One incident, I get some patient like ear pain, only earache. When we examine, there is nothing in the ear.
Yes, nothing.
You take the dental cause, everything you exclude. Yes. Ultimately take the history.
Yes.
He or she usually see he has a photophobia, phonophobia,
Yes.
and typical family history.
That's
of
an
migraine.
atypical. That's an atypical pain. That there you need to take care of the patient with amitriptyline maybe, and you
Yes.
need to take care of the patients. You need to send the patient to a psychologist to
Yes.
make them aware that this you have to go through a
Yes.
counseling.
Or
That is
everything,
important.
Or gabapentin, or
Yes.
nortriptyline.
You cannot use gabapentin also for a long time. There are side effects are also there.
Side effect
So-
there, but you have to counsel the patient.
Yes.
That you may feel giddy,
Yes.
will be little more sleep, therefore for 3 to 4 days, and you will be accustomed.
Yes. So that is why they also feel very bad. Ki I am not looking after my family, and the females are very much affected with atypical pain. That's what I forgot to mention. So they also feel psychologically they feel bad. Ki I am not taking care of my family. I am not doing my job what I am supposed to do properly. So they go back to amitriptyline again. But that should not be the course.
Not only medicine, but
It's a proper
lifestyle modification is the
Yes.
most important.
It's a proper counseling and a lifestyle modification. Thank you.
Thank you.
Next speaker is Dr. Akriba Ahmed. Our topic is house dust mite sensitization in allergy and efficacy of HDM slit.
Very good afternoon to all. Thank you, NEBAOICON, for giving me the opportunity to give a talk. So I'll be speaking on house dust mite sensitization in allergy and efficacy of house dust mite sublingual immunotherapy, my personal experience. And through my talk, I would like to highlight the sensitization of house dust mite in allergic rhinitis and allergic diseases, efficacy of sublingual immunotherapy in allergic rhinitis, and role of sublingual immunotherapy in asthma control as an addition to pharmacotherapy. So house dust mite is a major perennial aeroallergen associated with a significant cause of allergic rhinitis and allergic asthma. So by a major perennial aeroallergen, we mean that more than 50% of a geographic population is sensitized. So 1% or 2% of the world's population might be affected. So this means a huge number, 65 to 130 million persons. Globally, 11 major species of house dust mite has been identified. The main ones are Dermatophagoides steronesis, which is the American house dust mite having a 85% occurrence, and Dermatophagoides farinae with a 47% occurrence. That's a European house dust mite. And in India, we do allergen testing for 3 mites. They are Dermatophagoides steronesis, farinae, and Blomia tropicalis, which is a storage mite as well as house dust mite. So how do the action happens on the immune system? It's by production of cytokines, chemokines, promotion of Th2 polarization, increased permeability through disruption of the epithelial tight junctions in the epidermis, smooth muscle proliferation as we see in the lower airway, eosinophil and mast cell proliferation, as well as airway remodeling. So patients were selected for my skin prick test in my allergy practice in 2021 to 2023, and a total of 100 patients were randomly selected from various allergic diseases. Positive diagnostic test results to house dust mite were included, which were skin prick tests with a wheal size more than or equal to 3 millimeter more than the negative control, to the farinae, steronesis, Blomia, or all 3. The patients were included on the basis of a clinical history consistent with allergic rhinitis according to area guidelines, suffering for more than equal to 1 year, and a clinical history of allergic rhinitis with asthma, suffering for more than equal to 1 year. 20 patients for slit were taken from 2022 to August 2024 who were sensitized for house dust mite. Interestingly, 4 patients also had associated urticaria, which were allergic contact urticaria to house dust mite, and 5 patients also in my studies had concomitant asthma. Patients had moderate to severe disease, and despite having received adequate pharmacotherapy, they were not getting control in the slit group. And for allergic asthma, FEV1 in spirometry was more than 70%, and patients were selected with moderate asthma. Then that means they had budesonide 400 microgram or less in that group, and the patients were above 12 years old in that group. Male to female ratio 12:8. And in polysensitized patients, allergens causing the major impact on the quality of life was chosen. The patient's base scoring was done with total nasal symptom score, and for asthma, GINA assessment of asthma control, urticaria control test was done for urticaria, and rhinoconjunctivitis quality of life scoring was done. So GINA assessment asthma control is a wonderful tool. You know, there are only 4 questions, simple questions. You ask the patients and you come to know whether it's well controlled, partly or uncontrolled. Urticaria control test is also a very simple tool. It's for only with 4 questions. Total nasal symptom score with mild, moderate, severe, we can classify. So I could see that when I was doing my test, I could group these patients into around 5 groups. So allergic rhinitis being the major group, and the allergic asthma, urticaria, chronic rhinosinusitis with nasal polyps, and also allergic rhinitis with adenoids. Worldwide data showed that allergic rhinitis had a 80% house dust mite sensitization, asthma 60%, sinonasal polyposis 30%, chronic urticaria 50%, adenoids 50%. And I found a similar kind in a 1-year study, but then it was 76% in allergic rhinitis, 66% with asthma, allergic rhinitis with urticaria 60%, while in the adenoid group and in the polyp group was also good, 60%, when adenoid had a less sensitization. So as you can see in the diagram, house dust mite was a major sensitization in allergic rhinitis, 76%, followed by pollen. I also tried to find out sensitization in 2 allergic disorders. See, when I took persistent allergic rhinitis with asthma, I found again house dust mite 47%, followed by pollen and then cockroach. And all the fungi was a small number. And few patients had food allergy symptoms. We might test it, that were also sensitized to a small percentage, nuts and legumes. Then with 3 allergic disorders, chronic rhinosinusitis with nasal polyps, with allergic rhinitis with asthma, it was an interesting finding, you know. I found house dust mite and cockroach equally sensitization, 60% house dust mite sensitization in this group, and even pollen and aliment lander were good sensitization was found, 40% each. So try to compare the pharmacotherapy effects in allergic rhinitis with sublingual immunotherapy. So when I took the total nasal symptom score in the allergic rhinitis group, there I found that in the baseline the symptom scores were around 11, but after 3 months of pharmacotherapy, the total nasal symptom score came down, but again it came up to 6 months and after 1 year. But when I introduced slit, it was found that after 3 months there was a very good improvement of scoring, and 1 year of time period, the symptom score was 0. It was a good control. Then in the quality of life questionnaire, then I found that in 12 months time there was a wonderful control of the quality of life too. In the GINA assessment of asthma control with pharmacotherapy at 1 year, there were 5 patients and they showed partly controlled asthma, whereas with introduction of slit in addition to pharmacotherapy, 4 patients had well-controlled asthma, while 1 patient had partly controlled. The urticaria control tests were also good in all the patients with slit and pharmacotherapy. More than 12 shows a good control of urticaria. So it was almost more than 12 and almost 16 in other 3 patients. So here I want to emphasize that polysensitization means sensitization is more than equal to 2 allergens or 1 allergens, and it is not equal to polyallergy. So when you find on the skin prick test that you're sensitized to a lot of allergens, it doesn't mean that your patient is allergic to a lot of allergies. So you need to actually correlate with the history and actually find out what the patient is allergic to. I want to just present a case. This patient was a persistent allergic rhinitis with asthma on sublingual immunotherapy for around 1.5 years now. The 16 years old male. The skin prick test is shown here with the polysensitized, but patient was only having house dust mite allergy clinically. The video. There's no sound. Sound is not playing. কি করবে লাগবে
sound.
From current slide, Baba.
I'm Rituraj Bhoya. I'm 17 years old, lived in Majoli. I have been dealing with allergic rhinitis, sinusitis and asthma since 2012. And despite of trying various medication and inhalers prescribed by different doctors, I wasn't able to find my lasting relief. In November 2022, I underwent a skin prick test with Dr. Akriba Ahmed, which revealed that I have dust mite allergy. I started dust mite sublingual immunotherapy after advice of Dr. Akriba Ahmed in April 2023. And now, after a year, I am completely off medication and inhalers. My peak flow is at my personal best, and now I am able to practice martial art without any needs of any inhalers.
So this is Rituraj, and he's a national karate champion of inhalers now, and a wonderful result, polysensitized with house dust mite allergy. So to conclude, the house dust mite sublingual immunotherapy was found to be very effective in even polysensitized patients. Allergen selection in monotherapy is very crucial. Detailed clinical history and correlation to patient's environment helps in choosing the allergens. Cross-reactivity also needs to be considered. And sublingual immunotherapy has a disease-modifying effect in contrast to pharmacotherapy. My study was only limited to 1 year, but it should be continued from 3 to 5 years to have the complete control. So take-home points, adequate treatment of the allergic disease is very important before starting allergen immunotherapy. By adequate treatment, I mean proper allergen avoidance, adequate pharmacotherapy. It is very important. Once the patient is been well controlled, then only you need to start sublingual or SCIT. Choosing the correct candidate for allergen immunotherapy is important as well. The correct candidate, I mean you should choose a patient who is very young with a milder disease and with no comorbid conditions. SLIT for house dust mite gives good results in monosensitized as well as polysensitized patients, as I showed you. Dust mite sublingual immunotherapy reduces the need for intranasal steroids and inhaled steroids. An early institution of SLIT appears to be most effective for asthma in children and young adults. So the references, I had taken the reference of Middleton's and International Consensus on Allergy Immunotherapy. Thank you all for a patient listening. Thank you. Yeah.
Thank you very much, Akriba. Actually, I was supposed to introduce you, but actually, she is a very dynamic and very academic woman. She works in Excel Care Hospital, Guwahati, and even she's got training in allergy, asthma, also immunotherapy. With Gayatri Pandit, I think, no?
Yes.
Yeah, yes. And from Bangalore. And she has recently started a clinic, actually, in front of downtown, allergy clinic. That's great. Any questions?
Yes, sir. Yes, sir.
Very interesting paper.
Thank you.
You go to the depth of the subjects, which is very, very important. Because I was in Borpeta and there are so many cases of angioedema because people are playing Holi. After Holi, the attack comes. This is angioedema. It goes to anaphylaxis. So what should be the drug of choice for angioedema to manage emergency?
So angioedema, first of all, we need to find out whether it is like H1 mediated or it is not H1 mediated, sir. So if it is H1 mediated, then you will have a lot of itching. And also we need to find out whether it is hereditary angioedema. So there are some clinical features. So for H1...
When is angioedema, it goes to larynx with distress.
Yes. So it must be H1 mediated, sir. So we need to actually find out whether it is wholly or is it something different, which is some respiratory allergen or some food allergen they are taking during that time. And angioedema is associated with urticaria, sir. So whether it has been an acute urticaria or whether it is like, we actually need to evaluate it, sir.
I had 3-4 cases. I did steroid,
Okay,
admission
sir.
of the patients. I was supposed to go for even tracheostomy, but I didn't do. But I started omalizumab, is a drug of choice. Omalizumab is a drug of choice. Periodically, you'll have to give tail of it, and you'll have to follow for 6 months to 1 year like this. That way, I got 3-4 cases, and that's why when you say allergy, the dreaded cases are angioedema. Okay.
Okay.
Thank you.
Okay. I'll try to see these cases too, sir. Thank
Actually,
you.
omalizumab is a monoclonal antibody. And it's mostly used in asthma and asthma. Not in angioedema. There's the main road. Any questions from the audience?
Is there any way to know the drug allergy beforehand without exposure?
That is a very difficult topic actually.
Yeah.
So drug allergy main is a history.
Any test?
Any test?
Any test to know drug allergy?
Drug is a drug challenge test you need to do. If you are suspecting, say, I have very less knowledge about whatever I know. Suppose you're having penicillin allergy, you suspect, you need to take a very proper, good history where how the history was. Was it a mild one? Was it a severe one? And then you can actually go for a drug challenge.
Okay.
That is how it is done.
Okay.
The provocative test actually.
Okay,
Yeah.
that's what I was eager to know actually.
Yes.
Just like food allergy, we know that what are the foods you may cause. Is there any test which can see any allergic drug for you? Means I am safe for this drug or not?
For
before taking the
injectable,
drug?
we do skin test for everything.
Intradermal
But for
test.
orally, we don't think like that.
It's not yet come up.
Not yet
No, for
come, but
aspirin, you can do a aspirin challenge.
That
for
is
example,
for the treatment, I guess. That is for
Sorry?
the that is for the aspirin challenge for the treatment, allergy treatment.
No, aspirin
Aspirin
challenge and
desensitization.
desensitization. That is there.
That is a
There is a
treatment,
proper
yes.
protocol for that.
Yeah,
And even for penicillin, there is a proper protocol. Mainly penicillin, cephalosporins, they are the main ones, and sulfur. So
That-
these
that-
are.
that I know some people because there are some people who are allergic to some allergic to say ibuprofen. So whether this patient is allergic to diclofenac or not, is there any way without taking that medicine to see?
I have Dr. Taha is doing a great job actually. He's in Srinagar SKIMS, so he has around 90 papers on drug allergy. So I mean, I have
Next
to.
time
really-
I will be.
Yeah,
I
yeah.
will hear from you.
Okay, okay.
for
Thank you.
injectable,
Thank
we do skin barrier. But for oral, actually, I don't have. Yes.
Just one short question. Regarding the slit sublingual immunotherapy, if you find that some very common food allergens are there and which food cannot be avoided also, do you go for slit or not?
Sir, if the patient has a history of food allergy, you mean to say, or the skin prick test, sir?
Skin prick test, yeah.
A skin prick test, routinely we do not do food allergens at all. Only if there is a history of food allergy, food intolerance, only then it is advised. Routine food testing is not advised, sir.
Not advised.
Not
No.
advisable. Thank you.
Thank you, sir.
Any questions from the audience? Abu यहाँ खुदा क्या होता है? If there is no question, I think the last paper will be really interesting paper. Actually, I also do not know what Dr. Pranamballabh Bora would present. Pranamballabh Bora, his topic is the fast of NEBAOICON and NEBAOICON. Fast of NEBAOICON and NEBAOICON. Akriba, thank you very much. What a nice completion.
Thank you, sir.
But you have rightly said, HGM is the commonest thing. Dr. Pranamballabh needs no introduction actually. He's a great man. And Pranamballabh is from Nalbari. He has started from the legacy of his father, and he has a nursing home. Recently, he has started a very big nursing home on the highway in Nalbari with 6 modulated OT and everything. I think And he was organizing secretary of Mulberry Conference. You'll come, I think.
I got a surprise call from megastar Amitabh Bachchan. He inquired me, Borua, how is your preparation? Oh, that's okay, it is going on. He advised me one thing. Why don't you present the paper in the theme of KBC, Kon Banega Korpati? You ask questions to the audience, give some prizes in course. If they can answer, give that money to the audience. I was surprised because I don't have course of money. Then he told me one thing. You go for one thing. Instead of KBC, you go for KBH. Kon Banega Hajarpati. So today's preparation is KBH. Kon Banega Hajarpati. There will be some questions, not to all. And yes, you know everything, he was master of all. Then, fastest finger first. Those who raises the finger first, he or she will get the money. And I have appointed our young dynamic ENT specialist, Abhinav Ghosh, to judge. Those who raises the finger for few questions, not to all questions, he or she will be given prize in this show. Here, unlike KBC, no lifeline, no fun and friend, no audience friend, and other things. So, let's start the game. Let's start KBH because time is short, otherwise our chairperson will ring the bell. Which was the first venue of NEBAOICON at Guwahati in 1985? Regional College of Nursing, Guwahati Medical College, and Regional Dental College. Yes, Dr. Vidas is current, but unfortunately there is no prize money. Who was the first president of NEBAOI? I am preparing this slide not to our old generation, mainly to the young budding PGs and who have joined recently, because we are in the association since last 40 years, since his birth. We are the founder members of the association. As you are the part of this, our associations, you should know this. Who was the first president of NEBAOI? No, you are wrong. Professor S.N. Sharma, sir, in 1985. So you give the... Who was the first honorary secretary of NEBAOI? Professor Anand Dutta, sir. Anand Dutta, who was present yesterday. Professor Dr. N.K. Dutta. Who was the first secretary? Honorary secretary. Dutta, sir. Who was the first lady president of NEBAOI? Prabhati Purkasta Vaidya? Our Anjali Burwa? Or yes, Khanna. Yes. She was a very powerful woman in our association. Since last few years she is not coming. That's why our beauty of our association has gone little low. And our Silchar people, they must try to bring these icons to our association frequently. There is prize money of 1,000 rupees. When and where first issue of NEBAOI journal was released? When and where first issue of NEBAOI journal was released? Abhinav, you just judge, and whoever raises the finger, give him the prize. This is simple question. Where? Time pass. Time pass. I am not asking the editor where and in which year and where it was released. Sir, you should know because you are editor. It was Itanagar. Who was the first editor of NEBAO journal? Professor Dr. Ibohal Singh, Professor Dr. Madhumangal Singh, Professor Dr. IKK Singh. Who was? Dr. Madhumangal Singh, Ibohal Singh, Professor Dr. IKK Singh. Who was first editor? Which one? Huh? No, it is Madhumangal Singh. There is an interesting question. World Cup is over. Hat-trick. Pat Cummins, he made hat-trick. Not once, he made twice hat-trick. In NEBAO, there is price of 1,000 rupees. In NEBAO, up till now, only one member has made hat-trick. Who is he? In which heaven he has made the hat-trick and which years? In NEBAO, who was the only member who did hat-trick, in which event and which years? Any idea? I am asking the old generation, not to the new generation. Who? Kalpana? I have increased the prize money from 1,000 to 1,500. For your interest, again I have increased the prize money to 2,000 rupees. And for the last time, I have increased the prize money to, at a time, from 2,000 to 3,000 rupees. Professor Siddhas sir, even this presidentship, he was president consecutively from 1988, 89 and 90. These things we should know. Now come to the first international achievements of the NEBAO members. That's interesting prize. Who was the first NEBAO member to attend the Politja Society meeting? Which one? Huh? Yes, it is correct. Abhinav, you give the prize to the madam. And interestingly, S.C. Goswami sir was member of this society. Next question. Who was the first NEBAO member to attend the Berani Society meeting? Who is the first member to attend the... I request one member who is present here not to answer that question. This question is open to all the members except one member. Sorry, you should give that question because it is often coming in our newsletter, in our website, everywhere. I want to give the prize. If you don't take, that is not my fault. Except Gautam Khan, all can. I have given sons to all except Gautam Khan. Who were the first NEBAO members, their father and son, who presented two individual scientific papers at the European ENT Congress held in Madrid, Spain in 2018. If it is correct, Abhinav, give the prize. Huh? Give the prize, it is correct. I am not above the judge. First national achievement of NEBAO members. who was the first member of NEBAOIC to occupy the post of president of AOI. Unfortunately, there is no prize. Our beloved friend, Pavan Chaudhuri. This is important question. What is Uti Devi Sud Memorial Trophy? Which NEBAOIC branch first received it? What is Uti Devi Sud Memorial Trophy? Which NEBAOIC branch first received it? First and only one time it received it. So, because you divide half 500 to SB Fukman and 500 to Bidas. This is the best local branch of India. Most of you have not know that there is a prize for the local branch in the, and this is very prestigious branch. In 1999, Nalbari branch was adjusted as the best branch of India, and our Bombay was second and Bangalore was third. And I'd like to inform you that I was the secretary of the Nalbari branch at that time. We did lots of works. I have given this question here. Why I have given the question, not to show my this thing, but I have given the question here. You should take an inspiration from here. If Nalbari branch can do it, why do we other ones we can't do? You get aspiration from it, prepare from today itself, and I think next AOI, not this AOI, next AOI, any of our member branch will get this prize. Okay? This is the real hero of life section. There is no prize, but if the real hero is present here, we will honor him in this session. Who is that great NEBAOIC member who had delivered an excellent oration at NEBAOICON few hours after the cremation of his mother? Who is that member? Yes, because there is no prize for the audience. This is Hazarika sir. We will felicitate Hazarika sir, and I personally request all the present here in the house, kindly stand up and give ovation to the Hazarika sir. Because it is not a joke. After the cremation of his mother, he came direct to this NEBAOICON at Shivsagar. We were there. Marshal was there, and he gave a beautiful oration. Yeah, he came with Dhiti. Dhuti and power. My friend Marshal has indicated me by his eyes that time is going to be out. This is my last question. Jito jackpot का सही जवाब. Pay and win rupees 3,000 rupees. 3,000 rupees. This is a historic jackpot, and it is related to our NEBAOIC. If anybody can give the correct answer within 10 seconds, he or she will be rewarded. Name of this eminent person, that is the Swami Vivekananda, is related with the name of one NEBAOIC member. Who is he? Yes. Yes. I salute you. Because it is a tough question. If there is no answer, then I would have given some hints. He is a senior citizen. He is a senior. Abhinav, you give 3,000 rupees, not 1,000. Yeah. So there should be a party. He is a senior citizen. These are hints if nobody is able to give the answer. He is from Guwahati. He was president of NEBAOIC in 2002. Owner of this hospital at Dispur. Owner of this university. Correct answer is Dr. N. Doctor. So there will be another question in relation to this part. How he is related? There must be some reasons. Because I am Dr. P.M. Bora, I am not related to Swami Vivekananda. Gautam Khan is not related. Yes. The original name of Swami Vivekananda was Narendranath Datta. Important thing. And in Anpur, in Christmas Eve of 1886, name of Narendranath Datta was changed to Swami Vivekananda. Swami Vivekananda is respected all over the world. Similarly, our Datta sir, I had a breakfast with Datta sir in the morning in our hotel. We also respect Datta sir, just like Swami Vivekananda, we respect Swami Vivekananda all over the world. Datta sir is respected from our heart by our NEBAOI members. So give a clap for Narendranath Datta sir. I don't want to make the talk lengthy because you have heard so many interesting talks during the last 2 days. With this, I like to conclude my historic talk here. I started the historic talk with one view dance of Oru Khazai. And I like to conclude this talk with another historic dance, the dance of Barbados, West Indies. This is also history. With this, I conclude my talk. Thank you very much.
Thank you very much.
Thank you.
Always you place something, a peculiar presentation, historic presentation, this time with the KBC and not KBC, but rather KBH. Thank you very much.
Thank you.
With this I conclude the session because we have got quiz also, GBM also.
The audience is requested to be seated for the quiz because we are the one who should motivate the PG students. Now, if you are there, then they will be motivated, and the quiz is a program of maybe 45 minutes to 1 hour. Please be seated. We try to finish everything on time, so we are late only by half an hour the sessions.
There is another announcement. Those postgraduates who require logistic support to go to the venue of the banquet, that is, a bus will be starting in front of ONC Colony. From there, they can. There will be a stoppage at Hotel Siddharth. Then next stoppage will be at Hotel Shiva Palace, and third stoppage will be near before the Dikho Bridge. Then we'll go to the venue. So if because the venue is about 12.5 kilometers from so basically, I mean, if you want some logistic support, kindly let the reception counter know, because already some students have sought for that, but they never contacted me. So there is some kind of confusion. So I request all of you to kindly let us know.
Local hero of NBI is the son of the soil, 2004, now is 2024, after 20 years. And his all family members came. It's to India. Okay. Georgia. Thank you very much.
I request the speakers, Dr. Pradul Hazarika, Dr. Rupanchita Sangma, Professor Dr. Kalpana Sharma, Dr. Akriba Ahmed, Dr. P.M. Borwa to kindly come to the felicitation corner. I request the chairpersons to kindly felicitate them. I request the chairpersons to kindly felicitate our speakers, Dr. Pradul Hazarika, Professor Dr. Rupanjita Sangma, Professor Dr. Kalpana Sharma, Dr. Akriba Ahmed, Dr. P.M. Borwa. I request Dr. Kripamoy Nath to kindly felicitate our chairpersons.
Excellent. Moda, you are always unique. God bless you.
We are very thankful. The organizing committee is very thankful to an important announcement. Our organizing committee is very grateful to Maitri Dev and Gayatri Goswami, who came all the way from Dibrugarh, stayed with us for 2 days, and through number of video sessions, we coordinated with them, and they were great anchors who supported us. We thank you both. And we just want to, a token of thanks from us in a way of giving a memento. all the members who have joined, all the students who have joined for the quiz, please come forward. We have to start the quiz soon. I request quiz master and co-quiz master Dr. Navajyoti Saikia and co-quiz master Anupam Hazarika to come forward.
Participants, let us be sportsmen. Pick your own chairs. Make groups of 3 or 2. Group of 3 or 2. 2 or 3, whatever is, whichever combination you have made it. One of you come here? No, don't go too back. Just follow agot thaga. Just. Scorekeepers. No, good.
Sir.
Hello. Hello.
Dr. Manasi Sharma. Dr. Manasi, you are here. Please come here. And Munmun also, come. Dr. Munmun. Hey, Nahani. Dr. Bhaskar Gogoi, please come over. Come here. You will do the honor of being an watchkeeper. And Manasi, you be the scorer. Come here. That was that.
Hello. Do you have the team from Agartala Medical College? Tripura Medical College, Agartala Medical College, Dr. Hruday, Dr. Sripathy, Dr. Amlan. Agartala Medical College. Okay, fine. Three chairs you leave it here. And the last is Assam Medical College.
Sakina Nigar, you are from?
Okay. Final call for Agartala Medical College and Tripura Medical College. I think they won't be coming. Over to Dr. Navajyoti Saikia, sir.
Hello everyone, good evening. We have come to the most awaited session of today actually. Okay, let them come anyway. So good evening my seniors, my friends and my juniors. We are shortly starting the, give me.
Agartala Medical College, pick 3 chairs. Pick 3 chairs.
Pick your own chairs. Be quick. So we have 11 teams today. and over the years, I think it is one of the very big numbers. That's a success itself for the organizing committee. Congratulations, Baidu. And all the team members. So, because the time is short, we will have basically 2 rounds for the preliminary group, okay? For 11, and 6 of the teams will be eliminated in the first round, and the final round will comprise of only 5 teams. So, we have teams from, give me the list. List condition. We have teams from GMCS 2, A and B, RIMS Imphal 1 team, Tezpur Medical College 1 team, Downtown Hospital, where are you? Yeah, 1 team, Silchar Medical College 2 teams, then Jorhat Medical College 1 team, Agartala, you are from Agartala I think. Okay, Agartala Government Medical College 1 team, Negrims 1 team, and Dibrugarh 1 team I think. Okay. So, we will directly go to the rounds. Anupam, can we have the first question here? It is for starting, to be quite high, code dila group kita, Anupam. Anupam.
We'll start, since this is the first round, is going to be the elimination round. We'll be starting with group. The first question starts with group A.
How much time we are allowing?
We'll be allowing them
30 seconds.
5 seconds. 10 seconds.
No. Scoring will be like the first team will be awarded. One who answers the first question will get a. If you answer it on the first time, if it is your question, then you will get it as 10 points. Is it okay?
Yes. And
if the question is passed to the successive rounds, the successive groups, they will score 5 out of it. Okay? And it will apply to all groups. If everybody fails, then it will go to audience, and surely the experienced persons like Gautam Da here and Hemanto Da, they are already very eager to answer the question. Anyway, so we start. Can we have question number 1? This is an identification round actually. You have to identify the person. It is for no murmuring, please. If you can say the answer, start the clock. 10 seconds.
Direct question to group 1. Group A.
Group B. Oh, good. Group C. No. D. E. F. G. H. I know there will be a roar from the audience. All are waiting. And the first roar will get the prize. And J. Baltimore Eustachius. What is his actual Latin name? And what was his contribution? He described the Eustachian tea first. Okay. When? You will get bonus.
5 marks.
5 marks to group J.
Group J. Group J. Direct question.
So, direct question to group B now. Identification. No. Next group. What about my one? Next 5 seconds. Here. Next round. Next group. Next. No. E.
F.
F. Z. H.
Correct? Stemberger?
Yes, yes. Who said Stemberger? Okay. They said it.
Who said
earlier.
it? You have to be bold and very confident in answering. You cannot murmur. It has to be loud. There is no negative marking. Right?
What should I do? Yeah. Tumak to question no speaker di bole. They said Stemberger. You said Stemberger.
They get 5 marks. Group A, B,
Okay,
C.
okay.
Group D get 5 marks.
Okay, it goes to you then. Okay. No unfairness. Okay. Anyway.
Next question.
Tomorrow, tumi yada thaga. Mic to. The next question for group C, na?
Group C.
Yadi pass paise de. Next. E, group E. F. G. গলাটো মই ভাল পাওঁ দাদা H. I. Z. K.
L.
L. Audience? Okay. Manuel Garcia.
Chocolates. Sugar-free chocolates. Sugar-free chocolates.
Sugar-free নাই নহয় Marcel da.
Sugar or sugar-free?
খায় গৌতম দাই নাখায় নহয় Oh, sorry, sir. Okay. Manuel Garcia, what he is famous for? You do not know the name, that's why you will not know perhaps. Garcia was, huh? No, he designed the laryngoscope, isn't it? In fact, he was known as the singer teacher. He wrote orchestras himself, in fact. Okay. So next. Group, kuntu group koi thaki.
Direct question to group D.
Group D.
Direct question to group D.
Yeah. Yes. 10 seconds only.
Group
E. F. এইটো লোৱা তুমি এইটো ঘূৰি ফুৰিবা I. J. K. Huh?
Ashley Cooper.
No. H. Good. Group A. Yes.
Prosper Menier.
Yes, yes.
Correct.
Correct, correct.
5 marks to group A.
5 marks to group A. 1872, yes.
Direct question to group E.
So direct question to group E.
Direct question to group E.
E. Identify the person. A, B, C, D, E. Your question. F. G. H. Tak dia.
I. J.
J.
K.
A again.
A.
B. C. D. Kripamo has raised his hand already.
Audience. Yes, audience. Yeah, Professor Mohaz Tanabisi, godfather of endoscopic ear surgery.
Sugar or no sugar? Sugar. Please.
From
please,
Dubai.
yeah.
He's the one who popularized endoscopic ear surgery across the globe.
Anupam's godfather.
Direct question
to
direct
F.
question to group EF.
F. Where is F? Yeah. Yes.
G.
H.
Yes, speak loud. Speak loud.
Tatkwa.
Emil Theodore Cocker, sir.
Correct.
Correct.
So your group?
So who was Coker?
5 marks to group H. 5 marks.
Sir Emil Theodore Coker. What he was famous for?
He was famous for?
Thyroid surgery, isn't it? In fact, he was the father of surgery, and he got the Nobel Prize for writing the physiology of thyroid after he realized that all his previous surgeries ended up in being cretins. He cried about the incident and then wrote. He went back to the books, studied the physiology of thyroid and wrote it and got the Nobel Prize. Next.
Direct question to group
Z.
Who was the last? It was the last question was direct to
F.
F.
Why don't you volunteer? You should say yourself, na?
G. Group G.
Z, na? GMC. Identify the person.
H.
I. J. K. L. K lagi sir ni ba?
K. A.
B. C. D. E. F.
No. Over to the
To the
audience.
audience. Ari? You should all know this, all the student friends. Chevalier Jackson Jr. actually, what he was famous for? He designed all the endoscopes. In fact, he was, before Chevalier Jackson, everybody, if he had ingested, if a child ingested as, no, it was Jackson. If before Jackson, if someone swallowed something, he was doomed to die. And on his grave it is written, the epitaph reads it like this: here lies this person, if you swallow anything he will take it out. Remember that line. Anyway, next. Yeah.
Direct question to
H. Yes, tell me.
Sir, Jatin Shah.
Yes.
Yes.
The great surgeon Dr. Jatin Shah from MSKCC, Memorial Sloan Kettering Cancer Center. Jatin P. Shah.
Direct question to group
I.
No.
Hey, Mike. Pass. Yeah. I go to direct question. IJ. Kennedy.
No.
Z.
Shambhu.
No. A, B, C, D, E, F, G, H. Over to audience. Yes, somebody said something I heard. Yeah.
Who said it? Take moi mukha Shambhuda iman dei mone mone ase. Yeah. One more from my side. Thank you, Dada.
Direct question to next group J.
Pass. I. JK. A. B. C. D. E. F. G. E. F. G. H. Mario Sana, Professor Mario Sana from
Correct.
Italy. Professor Mario Sana from Italy. He heads this group called Gruppo Otologico. Two of my students have visited his institute. Very costly, but it is worth it. He is basically now attached to it lateral skull base. And for all the house to know, I think, and he is the one who has proposed only tympanoplasty type 1 for safe ears. No cortical mastoid. He has a series of at least more than 400 patients where he has shown a success rate of more than 95%. Only tympanoplasty type 1. Anyway.
Direct question to group K.
K. Direct question. This is the last direct question in the first round. Group K.
Group K.
This is the last question. Yeah.
Last question.
Nicola. Okay.
A.
Pass to A. B.
No.
C. D. E. F.
G, H, I, J. Over to audience. Yeah.
I think they speak. Yes, yes, yes.
Who said?
Yeah. You should speak loudly.
You
no?
should speak loud.
I am giving you the credit. Mic to asay na dhori ase. You should speak loudly whatever you speak.
Sorry.
Nine.
There is no negative marking.
So we are adding 5 marks to which group? F. George Van Bekesi, I think he got Nobel Prize, no? Yeah. He got Nobel Prize for physiology. Yes. And Bekesi is known, but otherwise Nobel laureate, no?
This time we start the round from group
No,
K.
just we'll have a...
The next round starts from group K backwards.
Okay, group K and backwards. Can we have a calculation? Score?
Can we have the
please?
scores?
Scorer. Mate.
Scores.
No, score it.
So team H is leading with 15.
H is leading with 15.
Yes. Okay. Direct question 10. Okay, sorry. So direct question 10. Okay. So team H is leading with 20, followed by team A with 5 points, D with 5 points, F with 5 points, and J with 5 points. The other teams are yet to open their accounts.
Okay. Well done, group H. So next we have anatomy round. You have 11 questions. Do we have?
Yes.
Okay.
I made it last moment.
No, I put actually 8 questions.
You put 8, I did 3.
So
start
it
with group
starts
K.
from
Group K.
Group K.
K. Direct question. And we turn
L.
JK L.
L. K, by the way.
K. It's K.
K. Okay, what is direct question?
From which cartilage malleus and incus stapes are developed?
এই কামটো ইমান ইজি নহয় গৌতম দা
Meckel's cartilage.
কেনে কৰি থাকে আপুনি আকৌ এই কুইজ মাষ্টাৰ কামটো ইমান
Meckel's
ইজি
cartilage.
নহয়
Yes. And?
Meckel's cartilage.
Yeah, one is Meckel's cartilage. And?
Okay, then?
What about the stapes?
We will not pass this question. We will give them half credit, that is 5 marks, okay? And anybody... No, they have already partly answered the question, no? So we'll give them half credit, okay? And we'll the other goes to the stapes, develops
to the audience.
To the audience. Huh? Eto to answer ahiboi jano. Please. One to SB Fukan sir, Marcelda.
Direct question to group
L.
Group J.
J, yeah.
What is Donaldson's line?
Pario.
Donald.
On koi thought me.
On koi thought me.
Hello. Donaldson's line is horizontal line in the left.
Speak louder.
Donaldson line is line dissecting the horizontal semicircular canal, which is landmark for endolymphatic sac.
Correct answer.
Correct.
10
marks to group
J. All are good in anatomy, it seems. Anyway.
Direct question to group
I.
Hammer and Redberg classification of sphenoid sinus nematization.
Hammer and Redberg classification of sphenoid sinus nematization. হৈ গ'ল নেকি বেছি সোনকালে মাৰিলা নেকি নেক্সট গ্ৰুপ
H.
So cellar, supracellar.
অনুপম নাই শুনি থাকিবা এই মাৰি থাকিলে অনুপম
Partially correct. Please repeat what your answer.
Cellar, supracellar, and precellar.
Half.
Yeah.
It's conchyl.
So
precellar and cellar.
Marco quiz master wants to award half point to it.
Half points.
I mean 5 points to it.
5 points.
Okay.
To group H.
Group H. Or 2.5. Half of half. A past question it.
Half of
so
half.
we have a direct question to now. H. I think you are lucky. What is perseverance is?
Direct question to group H.
It's a direct question to group H. Pick up the microphone. Are you answering it?
No, they have already elapsed time.
No, key hole.
Sir,
It's over. Time
Sir,
over. Time
Time
over.
up. Next group.
It's a mucosal elevation surrounding the isthmus, connecting the nasopharynx and the it is the
Take the microphone near to your
Speak loud and
mouth.
clear. There's no
loud and
negative
clear.
marking. No negative marking.
Sir,
Speak freely.
It's a mucosal elevation surrounding the isthmus from connecting the nose and the oropharynx in between.
It's not a mucosal elevation. Next.
It is caused by the palatopharyngeus
No,
muscle. It is
let
an
them speak.
elevation that helps demarcate the oropharynx from the oropharynx from the nasopharynx while swallowing.
Partially correct.
It's a fibromuscular ridge.
It's a fibromuscular ridge. Super. Okay. Give them 2.5.
2.5.
Your group F. Okay. So you have a direct question to now Z. Group Z.
What
Another
are the
very
hidden
easy
areas of the
question.
larynx? Direct question to group?
Dia, mic to dia temi tanda.
Group to direct group.
Dia.
What are the hidden areas of the larynx?
So called, but it's no more these are hidden. Actually they were hidden once. Anyway, it's difficult. Next group. Next group. Time over.
Pre-epiglottic space, paraglottic space, piriform sinus, and postcricoid area.
Next.
Posterior commissure, piriform sinus, and postcricoid region.
You are actually no this
Not
at
all.
least
Not all are correct.
no at least 3 have to be.
At least 3 has to be correct.
Pass.
So piriform sinus, postcricoid area, and ventricle.
This is the same answer they said. I said no. Yeah.
Anterior commissure, subglottis, ventral aspect of the vocal cord, laryngeal lingual surface of the epiglottis. Ventricle and saccule.
Yeah, they got at least 4 correct.
At least. Okay. Good.
2.5.
2.5.
Group?
I think
Group
we can give them 5, I think.
Infrahyoid epiglottis, anterior commissure, subglottis, ventricle, and apex of piriform sinus.
Apex of piriform sinus. You said whole. PFS is quite visible, like we can see it have laryngeal mirror also now, isn't it? The apex is a bit difficult to locate.
Now direct question to which group?
And how much do we award them?
2.5.
2.5, okay. Group?
No, they get 5.
Huh? Yeah,
They,
yeah,
4
yeah.
out of 5, they
Yeah,
got
yeah.
get
That's
5.
what,
They get 5.
5.
Group B gets 5.
You are troubling the scorer.
Next, direct question to group
F, sir.
F.
Group F.
What is Broyles ligament?
Cover there.
Cover there.
Broyles ligament is an area of the vocal cords starting from the anterior arcuate line to the posterior arcuate line. Sorry, it is an area in the anterior commissure. It's a ligament in the anterior commissure. It helps prevent the spread of laryngeal cancer.
No.
Pass. Pass. Heti pass ekoi lolo time diba. Microphone to mukhar osor loi thakib diba already.
It's a pre-epiglottic space. Pre-epiglottic space formed by.
No.
Mortondo.
It's a ligament connecting the anterior commissure to the thyroid cartilage.
Correct.
Yeah, yeah.
Group A gets 5. No, you didn't. You didn't put it right. Next direct question is to group E. What is Bayes triangle?
Kuna katisi ekon question paper. Bayes triangle.
Sir, it's a triangle between the anterior aspect of trachea and stylo.
Pass. Pass.
It is the triangle formed by the inferior thyroid artery, the common carotid artery, and the trachea on the medial side.
Yeah, correct.
Trachea is a physical groove actually.
Physical groove,
Actually, we will take it. We will take it.
5. 5 marks to
5 marks to group
C. Group
C. Okay.
The next question, direct question goes
direct
to
question
group,
to
group
D. And the koyu ni diye boy thake.
What are the boundaries of the facial recess?
Sir, facial recess. The vertical segment of the facial nerve, chorda tympani, or sinus condition.
Pass.
Sinus tympani, sir.
No.
Pass. Kobo.
The facial nerve, the chorda tympani nerve, and the incus buttress.
Fossa inquiris.
Fossa inquiris. The buttress, fossa inquiris.
Okay, they get 5 marks. Group C.
Group C, 5 marks. It's a direct question to group C now.
Now direct question to group
C.
It is formed by the posterior canal wall, the supratemporal line.
No, you have to write the price. Easy question, no? Posterior canal where?
Sir, I'll tell. Sir, the superior temporal line, superiorly, then antero-inferiorly is the posterior canal wall, and the tangent joining the both the lines.
Correct.
Okay.
10 marks.
10 marks.
To group C.
Group C. The direct question to group B now.
Other name for hiatus semilunaris superioris.
The other name?
Direct question to group B. Group A. K.
Sinus of Gunwald.
Correct in a way. Sinus lateralis of
Lateralis of Gunwald.
They get 5 marks.
Okay. Now, direct question to?
Direct question to last group. Group
A.
A.
Okay.
This is the last question of the elimination round. Marginal zones in larynx.
They have passed it. K. J.
Postgraduates used to fail in these zones.
Next to Joai Kania Manutu. Science. I H. No, goes.
Supraglottic, glottic, and
Marginal zones.
suprahyoid.
These are confusions between hypopharynx, larynx, like that. Pass. I gave a hint.
Ventricle. Ventricle, sir.
Speak clearly.
Ventricles?
No, no. You do not understand the question actually.
The areas where there is transition from the columnar epithelium to the squamous epithelium, such as the vibratory area between the vocal cords and the anterior and posterior arcuate lines.
No.
The question doesn't ask you that.
Sir, from lower border of vocal cord to 1 centimeter below that area.
Pass.
Pass.
Sir, is it the zones between the rima, glottides, the ventricle?
Pass.
Epiglottis and ariepiglottic fold.
Pass.
Okay, no marking, no.
Actually, the question was not understood by even the
Question.
audience.
This question basically is not about histological demarcation. It is an anatomical demarcation
So
and of oncological
this was a
significance.
very common question of Professor Dilip Bora sir actually. Stanisha Bora sir,
Yes, well.
Dilip Bora sir also. So
And in fact, this was one of the dangerous question that time too.
yeah, okay. Chocolate no one will get this time. It remains in the treasury anyway. So these are basically the marginal zones you all can see. Huh? No, one will not do, no. Superior border of AEF. No, you see, free edge of the true vocal cord. Just learn the things. It's not about getting points. Free edge of the epiglottis. Anyway.
This will be of significance throughout your
So
career.
we'll have the scores. I think, are we slow? ठीक है ना? At least 2 rounds. Do we give them another question? Yeah, I think there should not be confusion, no? Okay, you will get another chance. Who? Yeah. Skip this question.
We skip this question, omitted. We direct question. Who gets the direct question now? The last group. Okay.
K.
No,
A. Group A. To bad date. Your question is there. Yeah.
Is the olfactory area?
We skip it.
No, there.
There was a mistake. I double clicked it.
Okay, you double clicked it. Okay. Anupam. Saurabh dai tomak kiba digdai korise ni
Just one second. I will put another question from
চাবা দেই গোটেইবোৰ ওলাই গৈছে গোটেইবোৰ ওলাই গৈছে চাবা তুমি চাই লোৱা ফাৰ্ষ্টত এইটো অফ কৰি দিব পাৰি নেকি কেনেবাকৈ HDMI-টো খুলি দিয়া তুমি অনুপম সেইটো খুলি লোৱা খুলিলা মই জানো সত্য মই সেশন চলাই আছো কিয়নো পিছত ফোন কৰিম হ'ব 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 দুটা ৰাউণ্ড চলাবই লাগিব যে ছাৰ উপায় নাই এনাটমি ষ্টক নাই যদি বেলেগ এটা দি দিয়া না আছে আছে বেলেগ কুৱেশ্যন বহুত আছে
Group A, what is this? Group A. Direct question to Group A. What is this?
Sniffing. No.
Next, K.
Allergic salute.
Yes?
Allergic salute.
Yeah.
Okay.
That's allergic salute.
They get 5 marks.
5 marks.
K. So there is round 2.
Elimination round.
And it is elimination round rather. We'll wait for the scorer to give us the scores of different teams. And now we'll eliminate 6 teams. 6 teams we are eliminating. And the best team out of the 6 teams will get something. Scores please. Manasi. Yato hotata ani bohai disu sir. Audience for ani bohai disu.
So team H is leading with 22.5
Team
score.
H is leading with 22.5.
Followed by team C with 20 points.
Team C with 20 points. Team C. Okay.
Team J and K both have 15 points each. J and
K both have
15
points each.
Team A, then Team A with 10 points.
Team A with 10 points.
Then followed by Team F with 7.5 points.
Team F with 7.5. So you have 5 teams in total for the next round? No, we will keep 5 teams.
Okay, 5 teams.
So F is the last.
F is eliminated, sir.
But they scored best out of these eliminated teams?
Yes.
Okay. Any prize announcement for the eliminated team, organizer? They will get a everybody should get a participation certificate. I am giving them chocolates. Team F, where are you? Yeah. But you were awarded points even after you had spoken very slowly, isn't it? Anyway, good done. Well done. All the teams, please leave your seats now. Leave the seats. The 5 teams remain
Who are
here.
the 5 teams that remain behind?
They remain behind. All of the 5 teams, please come this
Microphone
side.
please give to the scorekeepers.
And the score moves on from here. I mean, like, this is add-on only. Whatever you have scored thus far will be carried forward. Yeah, obviously.
We are left with now 5 groups, I guess.
We have 5 groups.
5 groups.
Yate bok. Yate bok. Ekelage. Uju hobo. A mic to karne easy hoy jay. Now keep one seat gap. Okay. Yeah, there is a gap already. It's okay. So we have 5 teams now. Do we name them again or A, B, C, D? No. I think we should name them A, B, C, D. Yeah. Mark it quickly. একো নাই ইহঁতৰ পিছফালে লিখি দিলে হ'ল না ABCD.
Okay. You just write name A. Group A.
নাই নালাগে নেকি না এই স্কোৰিঙত দিগদাৰ হ'ব ন হা স্কোৰ কৰিবলৈ দিগদাৰ হ'ব anyway
You
okay
remain as it is.
what you are in order as you are C you go there shift here K your group J is after H no and K okay come in fill up the gaps. So we have the final round here. Everybody ready? Come here, fill up. Sequential A here kita. Moi to pasta nai, duta group ase tat. Oikhane duita ase dala. Total pasta ase. 1 2 3 4 5 thik ase.
Fine.
So we start from group A.
No, you start from that group.
Yeah, that is A only.
Okay.
A. What is Lyer's sign?
Carotid body tumor. The two divisions.
Very good.
Correct.
Very good.
Correct.
Full score.
10.
Your group. What?
Next group.
C. Group C. What is Ram Haran's sign? H.
Sir, it is seen in juvenile nasoangiofibroma.
Very good. Can you exactly define what it is? I'll give you credit for that, don't worry.
So the increasing distance between the pterygoid wedge, lateral pterygoid wedge, sir, and
basically it appears as a quadrilateral.
Quadrilateral, sir.
Okay. We get you get it's a past question. 5 marks. Yeah. So it's a direct question to now group H.
So the disappearance of the Muir's crackle, sir, in case of post-cricoid carcinoma, sir.
Okay.
Correct.
You do not get that crepitus, laryngeal crepitus. Anyway, good.
Group H.
Group H scores 10 points.
Direct question to next group.
J. Yeah. To kotha kole mic to mukhot logai diba. What is Bryce sign? Pass.
Seen in laryngeal CA.
Pass. Dur, Baba.
Hissing sound in external and internal laryngoscale.
Yeah. Correct.
5 marks.
5 marks to group A.
Group
A. Group A scores 5 marks as a past question. Now group.
Who gets the direct question now?
K. Group K. Double ring sign of or target sign.
CSF rhinorrhea.
Kak?
In
CSF rhinorrhea.
Autosclerosis.
Correct.
In cities if
তুমি নিজে কবা দেই পাস কৰি আমাক কিবা এটা চাই আছো
CSF rhinorrhea in handkerchief we'll get.
Correct.
Yeah, correct.
Was that a direct question? Pass. That was direct.
It's a direct question.
Direct.
Yes.
We have a question for the audience now.
Nicola. He's running here and there. Chocolate ka.
It's a question to the audience.
What is battle sign? এইবোৰ কৈ লাভ নাই দিয়া 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 okay okay just throw chocolates all around so
Again a question to the audience.
Again a question to the
I have
audience.
lots of questions, 130 questions.
Okay. Pemberton science. Ever Rugus. Huh? I call it. Rupanjita, Dr. Rupanjita. Dia. Horoke dibatai. Huh?
One more question to the audience.
Itu jane bhai itu sobe kobo yeah
Okay, we go to the next round. We start with
group K purno koriba dei manasi
diseases in ENT. The question is, what is AHI in OSA and what is the grading?
Apnea hypopnea index, sir. In
Yeah. And the grading?
Grading, sir. 20 था ना?
Next group.
You have to say all passed. You passed this question all.
You also have to say about the grading.
Less than 15 hypopnea episodes, 15 to 30, more than 30.
How do you grade it?
No. Pass.
Less than 15 mild, 15 to 30 moderate, more than 30 severe.
Correct.
I think I can award them.
They get 5. They get 5. They said apnea index. AHI they get A.
If they get 5, yeah, okay, we'll award them.
They get 5 for the
Amar
AHI.
kiya hai jai bhai pocketer pra diya de diya pass 5 hobo baido passe loksun ki nu di diya
2.5 yeah yes.
It will মই হিসাব কৰি থকা নাই কোন পিছত দি দিম তাই হলে ভাঙিবলে বহুত বস্তু আছে Okay, next direct question to
this group, white shirt. Which branchial arch is postulated with one of the theories for pathogenesis of juvenile nasopharyngeal angiofibroma?
5th, sir.
Pass.
So, second branchial arch, sir.
Pass.
First branchial arch, persistence of maxillary artery.
Correct.
First branchial arch artery.
First branchial arch.
Correct.
From which it is thought to develop ZNA because of the presence of estrogens, androgens, progesterones. Okay.
They get
5 marks.
5 marks.
Direct question to group
H.
H pass question asil niki etu
Direct question na etu
direct question
agoto pass question asile etu direct question pabo.
Which class of Lefort's fractures is craniofacial disjunction?
Sir, 3, sir.
3. Good. Yeah. They get full credit.
Next question direct to group. Name your group. Name the group. C.
Group C.
Sir, it is the classification for maxillary carcinoma. There is an oblique line going through the maxillary sinus and
and the
tumors above.
From the angle of the mouth to
it is an oblique line from the maxillary sinus.
Pass.
Sir, above it is
pass. Pass.
Ogren line is the oblique line. Above it is the more danger variety.
Pass it, pass it, pass it. You have to say the line from where to where does it go.
It is an oblique line which we use for prognosis of maxillary CA, extends from ear lobule till the angle of mandible. Above one is the poor prognosis, below carcinoma will be with
Pass.
better prognosis.
C says no. C is coming with the
The
yes
line is
answer.
from the medial canthus of the eye till the angle of the jaw. The cancers that occur above, these are like they will have poor prognosis. Below it, they will have better prognosis.
Correct. Okay.
5, I guess.
Prognostication of maxillary tumors. Anyway, on Grant's line. So,
have we finished with the direct question in this round? 1, 2, 3, 4.
No, last A.
Direct question.
Chandler et al. Staging is used in which disease?
Preseptal cellulitis.
No. No.
Nasal bone fracture.
Speak loud.
Nasal bone fractures.
No.
No.
Okay. Answer is?
To me, audience क्यों नहीं दिला भाई?
Oh, sorry. We have a lot of questions. Next question we'll put it to the audience.
Okay. No, we
the
have
audience.
One for the audience.
In diagnosis of nasopharyngeal carcinoma, which antigens are most sensitive and which are most specific? It's to the audience.
Sub medical college बहुत अथोय আছে আজিকালি. Screening is done for NPCs, and we have these available in our labs nowadays.
We go to
I
the
have been a
answer?
part of that study.
We go to the answer?
Yes. Ayurveda did the audience, okay? Viral capsid and early antigen.
What is Merkel-Rosenthal syndrome?
Audience.
Audience. Question to the audience.
Something to do with facial nerve. Nicholas says, half a chocolate? No. Kiel Sambura Monda Mukherjee sir?
Yes, Gautam Dai said about 1 point, recurrent facial paralysis.
Yes. Anjana Vaidu. Dia, next round,
Okay.
Next direct question, isn't it?
Direct question?
Now we start from this side now?
No, from that round.
Yeah, from K.
No, we start from group B.
No, we started from there. Direct question from this side now?
No, we was finished the second round.
Oh, okay. Is it? Oh, yes, yeah. A.
This is nasal douching used after FES procedure.
No.
Monitorization.
No, you cannot take 2 senses. Once gone is gone.
Antral wash.
No.
Polygization.
Yes. Actually, we have 2 types of polygyr bags. This is one which is smaller, which you can put directly to the nasal cavity, and another
They get 5 marks.
to the eustachian catheter.
5 marks.
5 marks to group H. So, name the incision. পুৰণা মানুহবিলাকে ক'বৰ কাৰণে মুখ লিকলিকাই আছে.
Liver.
Itching. Pass. McPhee incision. Correct.
Direct question to
Direct
group
H. H.
Name the procedure.
Name the procedure.
Enteral lavage.
No.
No. Pass.
Pass.
Balloon siloplasty.
Correct.
Ko pai bahiror pra koi ase. Na na hona nai tan kintu koi ase karon.
5 marks.
5 marks to group K. Okay. So direct question to group J. Yat ahise to name the incision and the surgery associated. আজিকালি শিকোৱা নাই নেকি হে মাষ্টৰবোৰে?
Speak loud. Pass.
Next.
Scavenger incision.
Pass.
Pass.
আপুনি কৈ নিদিব এক্সাইটমেণ্ট. Next.
Glux Sorensen.
Glux Sorensen. Yes.
Used in which surgery?
Used in laryngectomy.
5 marks.
5 marks.
Direct question to group K.
Yes. But the similar incision is used everywhere in neck dissection today, sir. Lower collar.
Copulation tonsillectomy.
Correct.
Correct. Copulation tonsillectomy.
10 marks.
10 marks. End হৈ গল নেকি?
নাই.
Huh?
Direct question আমি কোপা start করব?
Direct question, everyone has got a chance. So 2 rounds of direct question to the final groups here. 3 rounds. I seek an advice from the audience. Do we have time to go for one more round? One more round.
Shall we throw one question to the audience?
Gautam da, one more round. Organizer. আৰু এটা ৰাউণ্ড কৰিব পাৰিলে সময় আছে নেকি? হে নহয় এইটোৱে এতিয়া শেষ হৈছিলে নে আৰু এটা ৰাউণ্ড কৰিম নে নকৰিম?
We can wind up.
হা হৈ যাব নাই
অডিয়েন্সৰ কোৱেশ্চন এটা লাগে বোলে।
নাই অলৰেডি one very intelligent person, Vishwajit Gogoi, has signaled me to stop it here. So I think we should stop it here.
With one last question to the audience.
With one last question to the Somboda, please. Last question to the audience. What does the picture say? Itu Anupamor surgery যেন পাইছো.
Question to audience.
Prize money announce কৰা হোৱা নাছিল নেকি? নাই কৰা. Question to audience.
What is the surgery? What surgery is being shown there?
Pass.
What surgery?
No.
It is the nose or the ear? Nose or ear? It's my pet topic. Dual hand technique for interlate implanoplasty.
Okay.
Okay, I think we can finish it.
Okay. So we have come to the question round now.
Scores.
We are left. We are waiting for the scorers to come up with the scores.
Any additional question will be only just tie-breaking question.
Which group you are in?
7.5%.
আগতে মিলাই মিলাব লাগে।
25 তাৰপিছত আপোনাৰ C পাব 27.5 আৰু A পাব 25 J পাব 20 J তো মই গন্তিয়ে নকৰিলো না 20 আছে না
Okay.
10 পাইছে না 25 মানে
So here is an announcement for the winner of the poster. Did you already announce the winner's name? So this is okay. This is my honor. Anyway, the first prize goes to Bijit Kumar Nath. Wait. Okay. The second winner is Shivangi Sahu. Are you here?
Shivangi Sahu.
Shivangi. Come here, come. And the third is Rinjumoni Pang. Someone said you are very active in the department. Are you? Any other blind Marisalu? No, hoy. Tai kotha koise. So, to do the honors, may I request Kudus Ahmed sir, please, to hand over the prizes. The first winner wins a cash prize of by the paisa kiman ase? Eh? Kiman dise? 3 to 1, na jana? 3 to 1. So you are richer with the, sir. Okay. 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 He is Bijit Kumar Nath. You are from Guwahati Medical College? Assam Medical College, okay. Madam of Paskoman did you? Second prize, Shivangi Sahu. There is no certificate for you as per the organizers. So you are richer with this cash prize.
Okay.
Okay, it's okay. The third prize goes to Rinjumoni. MC. Okay. Thank you, sir. Thank you, Marcelda.
Do you have the scores?
Do you have the scores ready? No, to tell. It's a carry forward. Okay. A gift from Dr. S.B. Pukon sir to the to promising bully no idea. Already an established surgeon ENT, very good. Vishwajit Gogoi.
Kazunga conference organizing secretary. I was the secretary.
Okay. Thank you. We have to felicitate. Okay. Another announcement before the final one. So if anyone has not got certificates now, it will be printed digitally by the organizers and sent to you individually. Of course, if you have registered. So the result is ready now. Fifth is group Z with 20 points. They did well, of course. J, where are you?
Group J.
Group Z, okay. Fourth is group A with 25 points. And the prize winners now, there are 3 prizes only. Tinta prize na jano. A D diok na baido. A TI koi diok sandira. Tinta. So group C with 27.5. Congratulations. Group K with 45.
A no.
Group
K,
K code. K. Are uthibo lage bhai. And group H. And please pay your attention. And group H with a whooping 62.5 points. Congratulations. They must have good teachers. Zurhat Medical College. No. That integrity I have. In fact, they also have. Anyway, congratulations to all the winners and all the participants also. Thank you, the organizers, for giving me this chance. In fact, I almost missed the NEBAOICON, which I usually do not do. I was the Rokhia, Sokida in my department, because Madam with a big team came day before yesterday itself. Anyway, I made it in the final round. Thank you. Thank you, everybody. Yeah. And SB Phukan sir always has this habit of giving some prize money also. Prize money also. ঠিক আছে হ'ব ফটো লোৱা আমাকো লোৱা ফটো এখন লওক বাইদেউ এখন ফটো উঠোৱা এই ইফালে আহা ৰবা হেনে বাইদেউ শম্ভুদা তুমিও আহা না মিলন লীনা দে sir. Thank you. No, I have already, you wait here for some time.
No, 654. Or 6,000. First prize is 6,000. চাওক এনভেলপ মোৰ হাতত নিদিব মই এটা মাথা নষ্ট
দিয়া মোক দিয়াচোন
এইটো বেছিটো এইটো কোনোবা এনভেলপ আছে
উলিয়াই দিছে নিতেশ্বৰে এতিয়াহে উলিয়াই দিছে এইটো